health information systems. The idea is not to develop new platforms in countries, but instead pull data from those existing systems. So making that available is very important. We all know that data is very political. So the strong commitment of governments is really important. For the partners, we work closely with them. We strongly encourage them to invest in strengthening health information system in countries, to make use of the output of the regional data hub and work with us in terms of developing a strong health information ecosystem globally. This is the only way that they coordinate their actions in countries. This is how they can prioritize. This is how they can guide their investment. This is how they can take corrective measures in supporting member states.
Africa does not lack health data. What it lacks is one place where that data becomes an answer.
Data is more of a silos, separate data points, thereby making decision making very difficult because you have got different data points. For it to come up with integrated data is very difficult.
That is why WHO in the African region, with its member states, built the Regional Health Data Hub, a shared platform where trusted national data becomes intelligence that countries can act on.
Le centre régional de données doit nous permettre d'avoir un accès plus facile à des données, non seulement de notre pays, mais également des pays de la sous-région. Parce que aujourd'hui, avec la globalisation, les problèmes de santé n'ont pas de frontières.
Country profiles, live indicators, dashboards built with the countries that use them. One regional picture drawn from the systems countries already trust.
It enables ministers and health leaders to answer practical questions. Are we making progress? Where are we falling behind? Which populations are being left behind? And where should we prioritize investments? This is how we transform data into intelligence and intelligence into action.
The dashboards and member states are already shaping them. What comes next depends on what countries bring to it.
Data can only be helpful if it is of good quality. So what we would strongly encourage member states through ministers of health is to develop their national health information system strategies.
Together, let us build it, use it, and invest in it for the benefit of every country and every community in our beloved continent. Because when data become visible, people become visible. And when people become visible, they can no longer be left behind. Nobody should be left behind.
This regional committee is more than an annual report meeting. It is Africa Health Parliament, where we review progress, confront challenges, and make decisions that affect the lives of over 1.5 billion people in the continent.
From communities to action excellencies, we gather at an important moment for African history because the question before us is no longer whether Africa has the knowledge, whether Africa has the talent, or the determination to build a stronger health system. We do. But the question is whether we have a collective resolve to turn our potential into a lasting change.
The decisions we make here today must extend far beyond technical discussions. They must directly advance Agenda 2063, a continental vision that aspires to build an Africa which is healthier, more resilient, and united.
This specific report provides you with
The World Health Organization has verified that Cape Verde, Mauritius, and Seychelles have eventually eliminated both measles and rubella, becoming the first sub-Saharan African countries to achieve this goal. This victory is a victory for Africa. It shows that when governments invest in prevention, when communities champion vaccination, and when health systems stay resilient, extraordinary things happen.
We have successfully kept measles and rubella transmission at bay for decades. This success is not only the result of tireless work on the ground, but also the collaborative efforts of our health professionals, local communities, and partners like the WHO.
Elimination is not the end of the journey. Sustaining this status requires constant vigilance, rapid detection, and immediate response to any imported case.
Our regional goal, as set out, the Immunization Agenda 2030 framework, it is to eliminate measles, rubella in at least 80% of the African countries come 2030. Already 45 countries provide a second measles dose, and 35 have introduced the rubella vaccine into their national schedules.
Vaccination is the best investment in the health of your children. I'm here in Kinshasa, along with my colleague. They're introducing a very large measles rubella campaign and introduction for the entire country. This is an amazing achievement.
Gratifying to note that after 22 years of concerted effort, we have now come to the situation where the World Health Organization has recognized that Namibia is on the path to elimination of mother-to-child transmission of HIV and also hepatitis B. So this serves as an encouragement for us to continue and save more lives.
This achievement is a result of decades of sustained commitment from policymakers and health workers to parents, teachers, and the community champions who have ensured that no child is left unprotected. Africa can lead the world in disease elimination when we stay united in purpose and action.
This specific report provides you with information on health in the region. It not only focuses on where we stand as far as health is concerned, but also provides information on the progress made, some of the issues we are dealing with, and then the next steps regarding the future of health in this region.
One of the elements that is really important for mothers and women that this report put on record is the expansion of maternal and perinatal death surveillance and review. It brings in accountability that health workers can look at every death and review and really find out what is the cause of this death and was this death preventable and what can be done to ensure that another preventable death does not happen like this.
While the national averages are a good way to show progress, they also conceal differences between communities and between districts.
The report also highlights not so much the contraction and collapse of services, but the transformation that had to happen and is still happening in the way we deliver services, because that transformation then allows us to adapt to the contracted resources. And I think for me, that's the real story of the report.
Nous devions toujours répondre aux besoins des États membres parce que les besoins de la santé par la population n'a pas fait une pause parce qu'il y avait une crise.
La santé de nos populations, c'est nous qui devons la financer.
Let us work with purpose, work with solidarity, and work with the confidence that together we can build a healthier, stronger, and more prosperous Africa.
The journey ahead of us is big, and Africa can do it when we work together.
It is a great honor to welcome you to this high-level ministerial dialogue ahead of our 76th session of the WHO Regional Committee for Africa. This is particularly meaningful for me as it is only my second regional committee as a regional director following the RSC 75 in Lusaka last year.
If we want health security, we must buy African
regulate African, and trust African.
We cannot achieve or sustain local manufacturing by just building factories. We need an ecosystem, and everyone has said it, that will ensure that the manufacturers have the confidence to invest. If the regulator is not strong, then the investment can become a wasted investment.
Strong leadership and accountability requires very reliable intelligence. And reliable intelligence also requires a credible source of data. The whole idea of having a regional data hub is to be able to pull data from trusted sources, from multiple health information systems from our member state, again, to guide and inform decision making from policymakers, be able to monitor progress, and also strengthen accountability and transparency in what we do. To be honest with you, if used correctly, even for partners, uh, regional data hub is supposed to be a coordination platform that guide our partners in their investment by identifying priorities from member states and also monitoring progress while implementing, like I said earlier, to make sure that bottlenecks are identified at a very early stage and addressed as we move along. Data can only be helpful if it is of good quality. So, what we would strongly encourage member states through ministers of health is to develop their national health information system strategies that will bring together, or that will first of all define the vision that they want in terms of health information system, the different platforms that they want to have in their countries, and to make sure that they can all shake hands correctly and they can provide very trusted and reliable data to inform decision making. That's one. Two, we also want the support in making that data available because the whole idea is that the regional data hub should pull information from those existing health information systems. The idea is not to develop new platforms in countries, but instead pull data from those existing systems. So making that available is very important. We all know that data is very political. So the strong commitment of governments is really important. For the partners, we work closely with them. We strongly encourage them to invest in strengthening health information system in countries, to make use of the output of the regional data hub and work with us in terms of developing a strong health information ecosystem globally. This is the only way that they coordinate their actions in countries. This is how they can prioritize. This is how they can guide their investment. This is how they can take corrective measures in supporting member states.
Africa does not lack health data. What it lacks is one place where that data becomes an answer.
Data is more of in silos, separate data points, thereby making decision making very difficult because you have got different data points. For it to come up with integrated data is very difficult.
That is why WHO in the African region, with its member states, built the Regional Health Data Hub, a shared platform where trusted national data becomes intelligence that countries can act on.
Le centre régional de données doit nous permettre d'avoir un accès plus facile à des données, non seulement de notre pays, mais également des pays de la sous-région. Parce que aujourd'hui, avec la globalisation, les problèmes de santé n'ont pas de frontières.
Country profiles, live indicators, dashboards, built with the countries that use them. One regional picture drawn from the systems countries already trust.
It enables ministers and health leaders to answer practical questions. Are we making progress? Where are we falling behind? Which populations are being left behind? And where should we prioritize investments? This is how we transform data into intelligence and intelligence into action.
The dashboards are live and member states are already shaping them. What comes next depends on what countries bring to it.
Data can only be helpful if it is of good quality. So, what we would strongly encourage member states through ministers of health is to develop their national health information system strategies.
Together, let us build it, use it, and invest in it for the benefit of every country and every community in our beloved continent. Because when data become visible, people become visible. And when people become visible, they can no longer be left behind. Nobody should be left behind.
This regional committee is more than an annual report meeting. It is Africa Health Parliament, where we review progress, confront challenges, and make decisions that affect the lives of over 1.5 billion people in the continent.
From communities to action, Excellencies, we gather at an important moment for African history because the question before us is no longer whether Africa has the knowledge, whether Africa has the talent, or the determination to build a stronger health system. We do. But the question is whether we have a collective resolve to turn our potential into a lasting change.
The decisions we make here today must extend far beyond technical discussions. They must directly advance Agenda 2063, a continental vision that aspires to build an Africa which is healthier, more resilient, and united.
The World Health Organization has verified that Cape Verde, Mauritius, and Seychelles have eventually eliminated both measles and rubella, becoming the first sub-Saharan African countries to achieve this goal. This victory is a victory for Africa. It shows that when governments invest in prevention, when communities champion vaccination, and when health systems stay resilient, extraordinary things happen.
We have successfully kept measles and rubella transmission at bay for decades. This success is not only the result of tireless work on the ground, but also...
Honorable Ministers, Excellencies, distinguished delegates, please be seated. Excellences, Messieurs, Mesdames les ministres,
Excellencies, honorable ministers, distinguished colleagues, kindly be seated. We are about to begin today's session.
This specific report provides you with information on health in the region. It not only focuses on where we stand as far as health is concerned, but also provides information on the progress made, some of the issues we are dealing with, and then the next steps regarding the future of health in this region.
One of the elements that is really important for mothers and women that this report put on record is the expansion of maternal and perinatal death surveillance and review. It brings in accountability that health workers can look at every death and review and really find out what is the cause.
Non, mais moi, je dois aller me la pas ici. Honorable Minister.
Honorable ministers, distinguished delegates, ladies and gentlemen, good morning. We will continue with the agenda, and we will start with agenda item 8, Africa Health Workforce Agenda 2026-2023, a strategy for sustainable planning, training, and retention of health workers. Kindly refer to document AFR/RC76/4 and document AFR/RC76/WP1 that has the relevant resolution. I would like to invite Dr. Onyango, Director of Health Systems and Services Cluster, to present the document. Dr. Onyango, you have the floor, and I will give you 10 minutes.
On behalf of the Secretariat, I am privileged to introduce document AFR/RC76/4, Africa Health Workforce Agenda 2026 to 2035, a strategy for sustainable planning, training, and retention of health workers, and the related resolution document AFR/RC76 WP1. I was expecting slides to be projected so that we follow the presentation with some visual aid. I'm posing with the chair's permission to see if the slides are going to be uploaded. They're coming up. Oh, sorry. I can't see them on my screen, so I'm behind you in time. So if we go to the next slide, please. In the past decade, the African region has recorded progress in health workforce development, and this was thanks to the policy foundations of the Regional Roadmap for Scaling Up Human Resources for Health 2013 to 2025, the Global Strategy on Human Resources for Health, Workforce 2030, and the related Africa Regional Framework that was adopted in 2017 by the 67th Regional Committee. But post-2017 events, including COVID-19, we have observed a continuous brain drain, fiscal squeeze, and the fact that close to 1 million health workers are at risk of unemployment merits the development of a new agenda that addresses the growing and emerging problems. Next slide, please. We have seen reforms, investments, and improvements in health workforce production, availability, and planning. The region's health workforce expanded from 1.6 million in 2013 to about 5.72 million in 2024, and that includes 1.15 million community health workers. The broader health workforce for selected professions reached densities of 11.67, rose from 11.67 to nearly 30 health workers per 10,000 population. But these gains remain insufficient to meet population health needs. The region will face a projected shortage of approximately 5.85 million health workers by 2030, and this shortage coexists with unemployment and underemployment among trained health workers, which is estimated at around 27%. And this reflects a mismatch between education output, fiscal space, employment absorption, and service delivery needs. The next slide. The annual graduate output from about 4,000 training institutions in the region rose from about 150,000 in 2018 to 325,000 in 2024. However, the region continually loses skilled and specialized health professionals. Please stay on this slide. Loses skilled and specialized health professionals through immigration that is driven by global demand, constrained domestic labor markets, limited career pathways for our health workers, and difficult working conditions. Meanwhile, evidence points to the important competency and performance gaps, which include diagnostic accuracy of about 62% and treatment accuracy of only about 40% in selected settings. These trends demonstrate a complex health labor market challenge, which involves planning, education, quality, financing, employment, distribution, retention, productivity, governance, and data systems. Next slide. In response, therefore, the Secretariat proposes the Africa Health Workforce Agenda 2026 to 2035 as the next generation regional strategic guidance for health workforce development in the African region. The agenda builds on existing commitments while responding to new realities, which include demographic change, epidemiological transition, we are seeing disease patterns change continually, fiscal constraints, health workforce unemployment, migration pressures, emergencies, and persistent inequities in access to the health services. The vision of this, I'm going to share the vision and strategic goals. The goal by 2035 is to halve the health workforce shortage in the African region. This will be done by educating, employing, and retaining at least 3 million additional competent health workers and facilitating equitable access to them within strengthened health systems. Next slide. The document has 5 mutually reinforcing strategic objectives with, underneath them, 34 key actions. One is to operationalize the Health Workforce Investment Charter. This will stimulate sustained policy reforms and investments, optimize the capacity and quality of health professions education to ensure that training institutions produce competent workers. Remember our diagnostic challenges. Increase employment, retention, and performance by strengthening job creation, improving working conditions, addressing maldistribution through appropriate incentives, and supporting our health workers in their career development aspirations. We need to strengthen leadership and governance capacity for effective health workforce stewardship and regulation. We need also to improve health workforce and data and evidence systems to track health labor market dynamics, guide policy, monitor progress, and strengthen accountability. In summary, the Africa Health Workforce Agenda 2026 to 2035 presents a strategic way forward to transform the health workforce in the African region through planning, stronger investment, quality education, employment creation, retention, and performance improvement. It seeks to ensure that health workforce development directly supports universal access to quality and essential health services within resilient health systems. On behalf of the Secretariat, I submit this strategy and the associated resolution to the regional committee's consideration and adoption. I thank you.
Thank you, Dr. Onyango. I now open the floor to member states' interventions.
La République centrafricaine, vous avez la...
Central African Republic, you have the floor. Thank you, Chairperson. Regional Director, we have read with satisfaction the Africa Health Workforce Agenda 2026-2035 that is a response to the concern of a training and retention of health workforce in the region. The Central African Republic welcomes with satisfaction the African Health Workforce Agenda 2026-2035. It aligns with its human resource plan, and our national plan integrates three major dimensions: the sustainable planning of staff, and then the retention of staff. It also takes into account the emerging labor market dynamics and the constraints that are faced in HWF. We have also integrated ethics and professional responsibility in a context that is marked with crisis. We feel that ethics plays an important part. We feel that a health workforce can only be appreciated in terms of number, skills, and competencies, as well as ethics, so that we have people-centered and respectful services being provided. We have put in place a multi-sectoral plan that brings together professional associations, civil society, and other stakeholders. This helps us get real-time data to inform our decisions as well as improve our planning. The Central African Republic encourages the WHO to provide support for technical assistance as well as resource mobilization. We give our full support for the adoption of the Africa Health Workforce Agenda 2026-2035. Thank you.
Thank you. Comoros. Thank you, Mr. Chair, for giving me the floor. Regional Director, Ministers, Honorable Delegates, Salam Alaikum. Our delegation would like to thank the Secretariat for the quality of this report. We support its adoption. In particular, we welcome the strategic orientation of this document. It makes human resources, it puts it at the heart of this strategy, and includes the essential pillars of planning, training, and retention of healthcare workers. Now, we think that this approach responds well to persistent challenges in our region. This is despite the shortage of healthcare workers and the difficult absorption into the labor market of trainees. As for us, as an SID, we think that one of the main determinants is when it comes to UHC, one of the main challenges that we have to face up to is the lack of workers. Now, we have undertaken studies. The reports are still being done, but it has taken into account many different aspects of human resources when it comes to our healthcare system. The previous plan has coming to an end, and we are therefore in line with the regional guideline plans. Now, Comoros is in a decisive phase of developing its healthcare system. Towards the end of this year, we will open our first university hospital facility, and it will require qualified healthcare workers in all professional categories. We have another plan underway, and this will create further healthcare facilities, but also these will have capacity to train healthcare workers as well. This is an ambitious initiative. It is a historic moment for the Comoros. It also will require, and has required, investment and ongoing support from technical partners. Therefore, we are asking the WHO and other technical partners, as well as development institutions, to better support SIDs when it comes to implementing the strategy, especially when it comes to building capacity for training for healthcare workers, when it comes to retention of skilled workers, the engagement of the diaspora, and the use of digital solutions and remote medicine. Finally, we think that the success of this strategy will depend on not only on the number of healthcare workers that we train, but also our capacity to retain them in the labor market. Comoros reaffirms its commitment to implementing this regional strategy, and in advance, we'd like to thank the WHO and all partners for their continuous support in this important phase of our healthcare system. Thank you.
Merci.
Thank you. Please respect the time, dear colleagues. Now, Senegal. Thank you very much, Mr. Chair. Ministers, distinguished delegates, Senegal congratulates the Secretariat for the Health Workforce Agenda 2026-2035. On a national level, we see that it fits in well with our own strategies. We have a national development strategy for health workers. Senegal commits to the goals of this program. These include strengthening retention and furthering training, as well as growing leadership and governance and the management of human resources. We welcome the flagship initiative, and we are willing to support its implementation. On a national level, Senegal is committed to fulfilling its commitments. For example, the National Transformation of the Healthcare System plan aims to consolidate progress made, especially it includes an aspect of retention and investment in the skills of healthcare workers. We are also focusing on underserved areas so that rural areas can be better served. Senegal would appreciate the continued support of the WHO and technical partners in order to invest more in retention, in financing, and so that we can ensure that we employ more and more healthcare workers. We are committed to working together with member states and the Secretariat to implement this program. It is a vital condition for us to have healthy, qualified healthcare workers. We support the program and we call for the adoption of the resolution. Thank you very much. Thank you. Now Burkina Faso. Thank you, Mr. Chair. Burkina Faso welcomes the Africa Health Workforce Agenda 2026-2035. We would like to congratulate the Regional Director for this initiative, which responds to the requirements within our healthcare systems. We particularly welcome the well-informed approach. We think that it is forming a good link between healthcare systems and people on the ground. It also is important given the persistent shortage of healthcare workers in the region. We require well-trained healthcare workers. And when it comes to our president's strategy, we have a domestic strategy which aims to increase drastically the number of doctors and healthcare workers that we are recruiting. And our delegation also appreciates a planning approach which is based on data, especially one which provides for underserved areas. We also see it as important that we manage human resources better. Burkina Faso is a pioneer when it comes to the availability factor. We also welcome investments made in order for healthcare workers to increase their skills. Burkina Faso supports the workforce agenda 2026-2035, and we would appreciate continued support from the WHO. Thank you very much. Thank you. Now Ghana.
Chair, Ghana thanks you for the opportunity to take the floor to comment on Agenda Item 8. We commend the Secretariat for developing this timely and forward-looking health workforce agenda and support its adoption. The agenda comes at a critical time for our region, where persistent shortages, migration, unemployment of trained graduates, inequitable distribution, and retention of skilled health workers continue to constrain progress towards universal health coverage and health security. Chair, for Ghana, investing in the health workforce remains central to achieving UHC and strengthening health security. We have expanded training capacity and increased the production of health professionals. However, our recent health labor analysis has highlighted a critical market failure. Ghana is producing more health professionals than we are currently able to recruit, while significant workforce gaps remain in underserved areas. At a national policy dialogue, we therefore agreed on coordinated reforms to better align health workforce education and training with labor market needs, optimize budget space for recruitment and retention, manage migration, and strengthen workforce management and productivity. Ghana has also developed an investment plan with an ambition to recruit 25,000 workers annually, as well as comprehensive master plan for health training institutions. In May, Ghana launched its health workforce migration policy and strategy to strengthen migration governance, improve workforce planning, structure diaspora engagement, standardize recruitment and deployment, and strengthen health workforce data. Accordingly, Ghana will pursue these commitments, align health workforce planning, training and recruitment with labor market needs and available fiscal space, strengthen retention and equitable distribution through improved working conditions, specialist training, and targeted deployment to underserved areas, strengthen health workforce migration governance through coordinated implementation of the health workforce migration policy and strategy and ethical recruitment practices, improve workforce management and data systems to support evidence-based
Le
planning.
Ghana a tiré la conclusion.
Ghana
Please conclude.
Thank you.
Merci. Le Niger.
Thank you. Niger. Mr. Chair, Regional Director, distinguished guests, I would like to address a word of profound gratitude to the WHO and the Africa Office for their continued support to the strengthening of our healthcare system and to the resilience of our people. Chair, we have reviewed this document on the Africa Health Workforce Agenda 2026-2035, and we think it's coming at a critical moment. Niger has been implementing regional goals, and having done so, we have made significant progress. In fact, Niger is one of the countries which has managed to increase the density of its healthcare workforce by 50% over the last 10 years. In addition to this, we have also drawn up a national strategy and an investment plan. It is based on a labor market analysis in the healthcare sector. It is also focused on the healthcare worker situation. And despite this, health security and healthcare workers is a topic which sits against a backdrop of shortages. And therefore, our priorities in Niger are multifold, such as sustainable financing and fiscal space, so that we can ensure that we can reduce unemployment of healthcare workers, especially new entrants into the market. We also have aimed to align our training programs with best practices in our region. We've also aimed to improve retention of healthcare workers, particularly in rural areas. We have aimed to incentivize them and to improve working conditions. The situation, please conclude. To conclude, I would like to reiterate our unwavering commitment in Niger to continue tirelessly to implement reforms. We support this agenda for the Africa Health Workforce. Thank you very much. Thank you. Ethiopia.
Thank you, Chair. Ethiopia welcomes the African Health Workforce Agenda 2026 to 2035 and supports its adoption. We commend WHO for developing these forward-looking strategies through an inclusive and evidence-informed process. The agenda correctly recognizes a critical challenge facing our region, despite significant growth in health workers' production and improved workforce density. Africa continues to face a projected shortage of nearly 60 million health workers by 2030. While health workers' unemployment remains unacceptably high, this is not simply a shortage of trained professionals, but challenges of unemployment, financing, and effective health labor market management. Ethiopia strongly supports the agenda shifts from focusing solely on production towards planning, employment, retention, and performance. Ethiopia has increased its health workforce density by more than 50%, and it's implementing its health workforce strategy and investment plan to strengthening workforce planning, employment, equitable distribution, retention, and evidence-based decision-making through the National Health Workforce Accounts. We wish to highlight the 3 priorities for implementation: sustainable financing, strengthening health labor market analysis, and planning and improved retention through decent employment opportunities, better working conditions, and support for professionals serving in rural and underserved areas. Ethiopia has also emphasized ethical health workers, migration, and regional cooperation to protect national health systems while facilitating mobility. Ethiopia supports the adoption of the African Health Workforce Agenda 2026 to 2035 and reaffirms its commitment to working with the member state, WHO, and partners to build a stronger and more sustainable health workforce for Africa. I thank you.
Merci.
Thank you. Namibia.
Thank you, Chair. Namibia welcomes the Africa Health Workforce Agenda. This framework aligns well with the National Human Resources for Health Strategic Plan, echoing our core goals of capacity building, task shifting, strengthening management systems, and applying workload indicators for staffing needs. Namibia has launched specialized medical training and expanded our field epidemiology and laboratory training program to ensure emergency readiness. To mobilize resources and improve staff retention in Africa, in 2024, we hosted the launch of Africa's first health workforce investment charter, and we continue to utilize public-private partnerships for multidisciplinary rural medical outreaches. However, structural challenges persist. We face acute staff shortages and uneven urban-rural distribution. Retention remains our greatest paradox. Namibia offers some of the most competitive remuneration packages in Africa and invests heavily in staff training. Despite this, we suffer continuous out-migration of professionals to the private sector and high-income countries. This leads us to ask the following questions. What lessons can we learn from high-income countries to make remaining in Africa more attractive? Is it advanced technology, continuous career progression, or optimized working conditions? While the agenda includes issues of migration, we urge the Secretariat to strengthen its implementation guidance. The strategy must actively counter the aggressive pull factors of the global north by guiding member states to develop holistic globally competitive working environments that go beyond financial incentives. In closing, Namibia urges a transition from merely exporting our top health professionals to engineering the holistic working conditions that will retain Africa's talent for Africa's people. Namibia endorses the report and its accompanying resolution. I thank you.
Merci.
Thank you. Now Eswatini,
Vous serez suivi par
and followed by Benin.
Honorable Chairperson, Excellencies, distinguished delegates, Eswatini welcomes the Africa Health Workforce Agenda for 2026 to 2035 and thanks the Secretariat for placing the health workforce at the center of this committee attention. Chairperson, there is no universal coverage without health workers. Our own position makes the constraint concrete. We filled fewer than 1/5 of the vacancies we set out to fill last year. We remain below the recommended health worker density, and we continue to lose nurses faster than we replace them. The loss of specialist cadres to wealthier labor markets is now a financing risk, not only a staffing one. Eswatini is implementing a costed health workforce strategy for 2025 to 2030 and commits to competency-based education and accreditation, equitable deployment, retention in underserved areas, and stronger workforce data. We welcome the Plan, Train, Retain flagship initiative and ask WHO and partners for sustained support, regional knowledge sharing, and the accountability mechanism by which this agenda will be judged. We have further emphasized the integration of programs as one of the strategies to work on the issues of the shortages in HR. Chairperson, the Ministry of Health of the Kingdom of Eswatini affirms its full support for the adoption of the Africa Health Workforce Agenda 2026-2035 and commits to sustainable workforce financing and to invest in health workers on whom every other commitment depends. I thank you.
Merci.
Thank you. Now Benin.
Merci, Monsieur le Président.
Thank you, Mr. Chair. Delegates, Benin would like to congratulate the Secretariat for this agenda. We call for its adoption. We see that investing in healthcare workers is a national priority for us. We have doubled our training capacity in Benin. We have adapted the sector to our needs, and we have pursued increased recruitment efforts. We've also aimed to retain healthcare workers, particularly in rural areas. Now, all of this has helped us to double our coverage of healthcare workers in recent years. Now, most people, even in rural areas, have access to midwives, for example. We also have a pre-insertion into the labor market program. Benin has also implemented incentives aimed at retaining healthcare workers in rural areas. This includes a package which aims to overcome challenges such as lack of security in certain areas. We've also aimed to regionalize public services for healthcare workers. In fact, we have a strategy on this, and it aims to improve the spread of healthcare workers across our country. Benin sees community healthcare as a pillar of its national healthcare system. We therefore focus our recruitment efforts here as well. We have community workers earning $100 per month who are in charge of this program. We also invest in the development of healthcare workers because this is investment in our own country's development, and we call for the implementation fully of this agenda. Thank you. Thank you. Botswana.
Thank you, Chair. Just 1 second. We are. Right. Thank you very much, Chair, and sorry for that delay. And good morning, Chairperson. Botswana commends the Secretariat for developing the comprehensive health workforce strategy, Africa Health Workforce Agenda 2026-2035. This strategy provides a vital framework for our region to address critical health workforce challenges, building upon previous initiatives and responding to evolving dynamics in the labor market, financing, and employment. Botswana endorses its core objectives, particularly optimizing education, capacity, and quality, increasing employment and retention, and enhancing tracking of labor market dynamics. Botswana particularly appreciates the clear statistics and challenges presented, highlighting the persistent health workforce shortage of 6.1 million by 2030, with Africa accounting for 51% of the global deficit. The alarming 27% unemployment rate among health workers, especially new graduates, underscores the urgency for renewed investment. The disproportionate loss of experienced health workers to emigration and significant competency gaps further emphasize the need for strategic investment or strategic interventions rather. For Botswana, this strategy presents a significant opportunity to strengthen our ongoing healthcare reforms under the Botswana Economic Transformation Program at the National Development Plans. Our vision aligns with the agenda's goal of ensuring all people in the African region have access to competent, motivated, supported, and equitably distributed health workforce. As I conclude, Chair, there is need to increase the numbers of health workforce to achieve the universal health coverage. It is against this backdrop that Botswana endorses the strategy and with its accompanying draft resolution. I thank you, Chair.
Thank you.
Gambia, followed by Guinea.
Chairperson, distinguished delegates, the Republic of the Gambia commends WHO AFRO for developing the Africa Health Workforce Agenda 2026 to 2035 and supports its adoption. The agenda is timely as the region strengthens health systems, advances universal health coverage, and builds resilience to emerging threats. It recognizes that a competent, motivated, equitably distributed, and supported workforce is essential to quality services. The Gambia welcomes its vision of ensuring access to needed health workers and its goal of having the regional workforce shortage by 2035 through education, employment, and retention of at least 3 million additional health workers across Africa. We remain concerned that Africa faces a projected shortage of nearly 5.85 million health workers by 2030, driven by population growth, rising needs, unemployment of trained graduates, migration, and financing constraints. Nationally, the Gambia has progressed in training and recruiting doctors, nurses, midwives, laboratory personnel, and allied health workers. Government has expanded pre-service and in-service training, strengthened continuous professional development, improved community health services, and advanced planning through policies, strategic plans, better data systems, and national health workforce accounts reporting. We support the agenda's strategic objectives, strengthening investment and planning, improving education, quality and training capacity, increasing employment, retention and performance, strengthening leadership and governance, and enhancing workforce information and labor market intelligence. We welcome the plain, train, retain approach, which aligns with national priorities. Sustainable investment in workforce education, employment, and retention is essential to universal health coverage, health security, and Africa's developmental aspirations.
The Gambia calls upon WHO and partners to support member states through technical assistance, capacity building, resource mobilization, health labor market analysis, and knowledge sharing to accelerate implementation. The Gambia supports the adoption of the Africa Health Workforce Agenda 2026 to 2035 and reaffirms its commitment to building a competent, motivated, and resilient health workforce capable of meeting the current and future health needs of our population. I thank you.
Guinea, you have the floor. Kenya, please get ready to take the floor next. Chairperson, distinguished delegates, Guinea favorably welcomes the Africa Health Workforce Agenda 2026-2035 submitted for our consideration together with a resolution. Having motivated, competent, and equitably distributed staff is important for health. For Guinea, where universal health coverage is a constitutional right and a national priority, we have developed a strategy that aligns with the 5 objectives of this strategy. Regarding planning and investment, our National Human Resources Development Plan is being revised so that we have the real needs and the required workforce, the workload and territorial distribution considered. The national dialogue on the funding of the health sector will focus on sustainable financing and within the context of Semando 24, we want to recruit more staff, including 7,000 this year. In terms of training and transformation, we are revising our curricula so that it is tailored to reality. Thirdly, regarding employment and retention of personnel, Guinea is looking at the status of health personnel as well as the academia so that we have more retention, particularly in remote and underserved areas. In terms of improving governance, we are looking at evidence-based initiatives. Guinea, for this reason, supports this workforce agenda. Our roadmap is the national plan, and this agenda is the global plan. Kenya, you have the floor.
Kenya fully adopts the Africa Health Workforce Agenda
Mauritanie se prépare.
Mauritania, get ready.
To 2035. We endorse the Plan, Train, Retain framework to train, employ, and retain 3 million health workers by 2035, cutting our continent's health workforce deficit in half. In Kenya, 2021 data showed 27,000 qualified health workers were unemployed or underemployed despite a national deficit of nearly 60,000. Kenya is now acting decisively. We have brought over 24,000 healthcare interns into service. County and national governments have employed over 35,000 health workers since 2022, with recruitment of 5,000 more nurses and midwives underway. We have deployed over 107,000 community health promoters across all 47 counties. We are ranking 3rd in Africa for national health workforce accounts data. Kenya is using evidence-based staffing to anchor our new National Health Workforce Compact. I make 3 calls to this assembly. 1, mobilize financing, invest aggressively to convert Africa's pool of trained talent into productive public health care jobs. 2, operationalize the Charter, partner with WHO to scale competence-based education, and also expand ethical mobility agreements. 3, deepen peer learning, building shared continental mechanisms for data-driven health planning. Our success will not be measured by how many health workers we train, but how many are employed, equitably deployed, and retained to protect our people. I thank you.
La parole.
Thank you. I'll now give the floor to Mauritania, followed by Uganda. Thank you, Chairperson, Regional Director, distinguished guests. Mauritania congratulates the WHO and supports the Africa Health Workforce Agenda because it is the backbone of the HWF. Guinea has a strategic orientation for health personnel and in particular continued training with a strategy in place recently in the past years. We have been able to progressively improve access to healthcare. However, administrative coverage in terms of human resources does not cover our territory in a geographically distributed manner. And this is why we ask ourselves where to get human resources, because there is a concentration of health workforce in urban areas. And this is why we are trying to have a register of health personnel with a biometrics system in place. The next steps will be strengthening specialized training, digitalization, as well as retention in priority areas. We recommend public-private partnerships as well as regional specialized exchanges in terms of training. We feel that it would be important to translate national investments into human capital. We need a competent and available staff. We recommit ourselves to invest in human capital as well as health. Thank you.
L'Ouganda, vous avez la parole.
Uganda, you have the floor. Zimbabwe will follow.
Thank you, Chair. Uganda welcomes the Africa Health Workforce Agenda 2026-2035 and notes its strong alignment with the ongoing revision of Uganda's own Human Resource Strategic Plan and the development of the new Health Workforce Strategy 2026-2030. Uganda highlights progress in the national staffing levels from 23% to 39% in the 2 fiscal years and the sustained wage budget growth of 26% since 2022-2023, as evidence that domestically financed targeted human resource investment can deliver rapid results and request WHO's continued support to sustain this trajectory. Uganda requests WHO technical support to strengthen the professional regulation, licensing compliance, and to review curriculum in line with the competences required for quality service provision, and to formalize a costed human resource investment plan and compact, building on the establishment of Uganda Health Professional Assessment Board. Uganda supports the agenda and recommends adoption. Thank you.
La parole est
Zimbabwe, you have the floor, followed by Mozambique.
Thank you, Chairperson, Your Excellencies, distinguished guests. Zimbabwe expresses its strong satisfaction with and support for the Africa Health Workforce Agenda 2026 to 2035. We commend WHO Afro for providing a strategic framework that recognizes health workers as the foundation of universal health coverage, health security, and resilient health systems. Zimbabwe has made significant efforts to strengthen its health workforce through implementation of our health workforce strategy and health workforce investment compact. Government has expanded the health workforce establishment, recruited over 5,000 health workers in 2025, and commenced further recruitment in 2026. We are also investing in the expansion and modernization of training with the ambition of substantially increasing the annual production of health professionals by 2030. However, we recognize that workforce numbers alone are not sufficient. We must ensure equitable distribution, retention, appropriate skills, decent working conditions, and sustainable financing, particularly for rural and underserved communities. Chairperson, Zimbabwe particularly emphasizes the importance of responsible and ethical international recruitment and migration of health workers. Migration is a legitimate right, but it must not result in the depletion of the health workforce of countries that have invested scarce public resources in their education and training. Africa needs stronger protection mechanisms, including ethical recruitment arrangements, bilateral agreements, compensation, and investment in training. We therefore call for stronger continental and global cooperation on sustainable health workforce financing, training, retention, migration, governance, and protection of health system. Zimbabwe fully supports the Africa Health Workforce Agenda 2026 to 2035. I thank you.
Thank you. Mozambique followed by Zambia. Thank you, Chairperson. Thank you for giving the floor to Mozambique. We reaffirm our commitment to the Africa Health Workforce Agenda. We recognize that a health system cannot work without a qualified health workforce that is equitably distributed. We support the adoption of this agenda. And we have engaged in an exercise to assess demand and supply, as well as looked at the funding of the training of health workers. This is being done to avoid duplication. We have created a working group in collaboration with the Ministry of Health and the Ministry of Finance with a view to improving the human resources as well as train and hire 11,000 health personnel. The government of Mozambique hopes to ensure sustainability, to strengthen community health systems and accelerate the universal health coverage goal in Mozambique. Thank you.
Thank you.
Zambia.
Zambia welcomes the Africa Health Workforce Agenda 2026 to 2035. We particularly welcome its recognition that Africa's health workforce challenge is not simply about producing more health workers, but ensuring quality education, employment, equitable deployment, and sustainable retention. For Zambia, this agenda is highly relevant. Over the past 4 years, we have recruited more than 21,000 health workers and expanded training with annual graduate output exceeding 10,000. However, gaps remain between the number of qualified graduates and our fiscal capacity to employ them. Shortages and inequitable distribution also persist, particularly in remote areas. We therefore support an integrated and evidence-based approach to health workforce planning, linking education and skills development with labor market needs, staffing requirements, recruitment, financing, deployment, and retention. Zambia particularly welcomes the focus on the health labor market analysis, nationally agreed staffing norms, annual recruitment, deployment planning, competence-based education, and retention strategies. These priorities align with our efforts to strengthen the national health workforce accounts and use workforce data to provide policy, planning, and investment. Zambia therefore supports the adoption of the Africa Health Workforce Agenda and is committed to integrating its priorities in our next Human Resources for Health strategy. We thank the WHO Secretariat for its continued support, including through the Health Workforce Policy Dialogue, which is helping countries translate commitments into practical action. I thank you.
Madagascar, vous avez la parole.
Madagascar, you have the floor, followed by Sierra Leone. Thank you, Chairperson. Chairperson, distinguished delegates and members of the Secretariat, we would like to apologize on behalf of our minister. On behalf of the minister, Madagascar would like to support the adoption of the Africa Health Workforce Agenda 2026-2025 because it aligns with our priorities. Human capital is a pillar of the government which places health and education among its priorities. The development of health personnel, of the training of health personnel is important. We want to create sustainable jobs and have sustainable financing. Particular focus will be given to community health workers, women and children. At the continental level, we need to strengthen cooperation as well as academic exchanges between our countries and invest in skills as well as respond to the real needs of our people. We cannot train staff that we cannot retain or recruit. We would like to thank the WHO for the joint efforts realized and urge you to continue with this collaboration through sustained financing that is aligned. When we bring together the efforts of all member states to train, retain staff, we will build an Africa that is healthier and more resilient. Thank you. Sierra Leone, you have the floor. Eritrea, please get ready.
Mr. Chair, honorable ministers, distinguished delegates, on behalf of the Minister of Health, Sierra Leone, we support the adoption and implementation of the African Health Workforce Agenda. In line with this regional agenda, Sierra Leone has made progress in strengthening health workforce governance, expanding and modernizing pre-service and in-service education, increasing health workforce production, including postgraduate and specialist training programs, improving recruitment, employment and retention mechanism, and advancing the institutionalization of the African Health Workforce Agenda. The country has concluded a health labor market analysis in 2026, which is being used to inform health workforce policy and planning. New medical and allied health workers training schools have been established, and postgraduate training in pediatric, OBGYN, family medicine, surgery, anesthesia, and internal medicines have expanded. To date, the country has recruited more than 3,000 healthcare workers. Sierra Leone also is in the process of establishing a human resource information system, IRIS. We have reviewed the scheme of service, developing and enforcing a regulatory and continuous professional development framework and enhancing access to continued medical education and telemedicine initiative. Sierra Leone has just concluded the development of the National Health Sector Strategic Plan 2026 to 2030 and the Healthcare Financing Plan in 2026 to 2030 with a renewed focus on strengthening workforce capacity, improving service delivery, advancing universal health coverage.
Thank you, Sierra Leone. We now give the floor to Eritrea. Thank you, madam.
Liberia se prepare.
Liberia, please get ready.
Eritrea welcomes the Africa Health
Workforce Agenda 2026-2035 and the agenda's integrated plan, train, retain approach, which emphasizes strengthened workforce planning, competency-based education, sustainable employment, retention, leadership, governance, and robust workforce information systems. We support the agenda's goal of substantially reducing the health workforce shortage in Africa by 2035 and its principle of country ownership, equity, accountability, and evidence-informed decision-making. Eritrea established a national health workforce policy framework and accreditation mechanisms for health workforce education. We are also participating in the implementation of national health workforce accounts, which strengthens workforce planning, deployment, and accountability. These efforts support our commitment to aligning workforce development with population health needs, particularly through primary health care, community-based services, and improved staffing in rural and underserved areas. Eritrea will continue to prioritize evidence-based workforce planning, quality education, continuing professional development, equitable deployment, and sustainable retention strategies. We also emphasize the importance of integrating workforce investments into national planning and budgeting processes. We call for strengthened regional cooperation and continued WHO technical support, particularly in education quality, accreditation, leadership development, workforce information systems, and context-specific retention strategies. Greater South-South cooperation can help countries adapt successful African solutions to their own circumstance. I thank you.
La parole est au Libéria.
Thank you. Liberia has the floor, followed by Congo.
Thank you, Honorable Chair. The Republic of Liberia welcomes the adoption of the Africa Health Workforce Agenda 2026-2035. With a continental health workforce of 46%, Liberia has committed to the planning, training, and retention of health workforce nationally. As of 2025, a country of 5.3 million people, we have recorded 948 health facilities across the country, and 55% of these facilities are located in rural communities, while 44.1% of these facilities are concentrated in urban areas. A health workforce of 20,395, up from 16,064 in 2016, out of which female constitutes 52.8%. Core clinical staff accounts for 32.2% of the health workforce, with nurses making up to 2/3 of the workforce. The current core health workforce density is at 13.9% per 10,000 population, with improvement from 11.8 per 10,000 in 2016. Though still far from below the WHO recommended threshold of 44.5 per 10,000, nationally, the density of midwives per 100,000 births is at 5.1 per 1,000 births, which is 0.9 less than the international benchmark of 6 per 1,000 births. 20% of our health workforce are volunteers, and 34% of volunteers are clinical staff. Honorable Chair, these statistics are not just numbers, but are realities shared by nations of the African continent. Thus, to conclude, we commit ourselves to global and regional initiative, working plan, train and retain health workforce nationally and continentally. I thank you.
La parole est au Congo.
Congo, followed by Cameroon. Chairperson, ladies and gentlemen, the Congo would like to congratulate the Secretariat for preparing this document that highlights the Africa Health Workforce Agenda 2026-2035. We are faced with a shortage of health staff, and then we have inequitable geographic distribution. Pointe-Noire has 60% of the health workforce to the detriment of rural areas. And then the issues of quality of a health workforce is also important. we have 4 priorities in a plan, which includes improved governance, equitable management of the workforce. The Republic of Congo fully supports the agenda and invites the regional committee to adopt it. It reaffirms its commitment to implementing the Africa Health Workforce Investment Charter and strengthening health facilities. We want to continue collaborating with the WHO and its partners so that we have qualified health personnel that are equitably deployed, motivated and supported. And this is indispensable for UHC and the health security of our people. Thank you. Cameroon, followed by Burundi, and Burundi will be followed by Guinea-Bissau. Thank you, Chairperson. Excellencies, ladies and gentlemen, honorable ministers, distinguished delegates. Burundi supports the Africa Health Workforce Agenda 2026-2035. We buy into the strategy that is based on planning, training and retention, which are essential levers to progress towards universal health coverage, improving the quality of health and improving the resilience of our health systems. We have embarked in a number of reforms for the health workforce. We have developed the national accounts for 2025 and the mapping of a health workforce. These tools have helped us understand better the number of staff and the distribution of skills so that we can guide in terms of recruitment. We have looked at an analysis to better understand the dynamics of training and motivation of staff as well as employment. Looking at the workload will help us estimate the needs of the people. Burundi is also looking at an investment plan so that we have a concrete intervention for human resources, in particular for primary health care and progress to universal health coverage. We reaffirm our commitment to strengthening production and the use of health data and having in place strategies for retention of the health workforce. We thank the WHO for its technical support, and we hope that we can implement this agenda in a measurable and equitable way. Thank you. Guinea-Bissau, you have the floor, followed by Chad. Thank you, Chairperson.
Thank you, Chair. Guinea-Bissau has various plans in this regard. We are also focusing very much on retention. And training of human resources is very much a priority. We think that there is no point in training healthcare workers unless they have dignified working conditions, and there also need to be enough jobs for them. Therefore, we aim to improve remuneration, working conditions, career security, and further opportunities. For countries such as Guinea-Bissau, countries which have limited resources, if we lose qualified healthcare workers, this is an enormous burden and a cost on our state. It affects our ability to provide healthcare. Therefore, we fully support the WHO agenda for healthcare workers. We particularly support the goal of distributing equitably healthcare workers in our own countries, especially in underserved areas. Thank you. Now Chad, thereafter Sudan. Mr. Chair, Regional Director, ministers, distinguished delegates, Chad would like to thank the Secretariat for its report on the Africa Health Workforce Agenda. Generally, we would like to thank the WHO for its support when it comes to gradually improving healthcare systems, and particularly the availability of healthcare workers. We have various priorities in Chad. One of these priorities is the accessibility of healthcare workers. Now, our president has personally taken an interest. He has been holding recent monthly meetings, and out of this have come specialized procedures and specialized programs for medical procedures. These may include ophthalmology and other programs. Now, this only complements the other various priorities that we have. We've also aimed to combat brain drain, especially immigration to northern countries. We have aimed, therefore, to increase salaries and to improve opportunities for graduates. The goal is to progressively achieve level 1 and 2 so that we can ensure that we are able to implement UHC. When it comes to specialist doctors, our universities have what they need now in various different medical subjects. We fully support the report that has been presented, and we support the resolution as well. We encourage other member states to adhere to the thinking behind investment in healthcare workers in line with the 2026-2035 agenda. Thank you.
La parole est
Now, South Sudan, thereafter South Africa.
Chair, the Republic of South Sudan warmly welcomes the Africa Health Workforce Agenda as a critical regional roadmap for accelerating progress towards universal health coverage, health security, and the Sustainable Development Goals. We fully support the implementation of its 7 strategic pillars. Despite operating in a fragile humanitarian context, South Sudan has made important progress in strengthening our health workforce. We have enhanced workforce governance through the implementation of the Human Resource for Health policy, the Health Workforce Information System, and the adoption of WHO National Health Workforce Accounts. With the support of WHO, UNFPA, and other development partners, we are successfully expanding pre-service education and continuous professional development for our nurses, midwives, clinical officers, laboratory professionals, and other essential cadres. Chairperson, while we celebrate these gains, the reality on the ground reminds us of the severe constraints we continue to face. Our health workforce density currently stands at only 7.9 skilled health workers per 1,000 population, 10,000 population, remaining well below the level required to achieve universal health coverage. Critical shortages persist, particularly in our rural, remote, and hard-to-reach areas. Furthermore, our ability to retain health workers is severely affected by inadequate financing, difficult working conditions, insecurity, and ongoing reliance on donor supporting incentives. In conclusion, the Ministry of Health of South Sudan remains deeply committed to increasing domestic investment and improving the equitable recruitment, deployment, and retention of our health workforce. We call upon the global community for sustained domestic and international.
Thank you, South Sudan.
Health workforce financing. Thank you.
Now, South Africa. South Africa has the floor, followed by Malawi.
Thank you, Chair. South Africa fully supports the adoption of the Africa Health Workforce Agenda 2026 to 2035 and commends the Regional Office for a forward-looking strategy addressing our continent's critical labor market realities, financing constraints, and retention hurdles. While South Africa produces many healthcare professionals, equitable distribution remains a challenge, particularly in under-resourced public hospitals, rural clinics, and primary healthcare facilities. Our national roadmap, Investing in the Health Workforce for Universal Health Coverage, South Africa's 2030 HRH strategy, directly aligns with this regional vision and supports our transition towards universal health coverage through the National Health Insurance. We are executing this through three core pillars. Firstly, intelligence and alignment, institutionalizing robust labor market intelligence and national health workforce accounts to bridge historic public-private divides, tracking spending and aligning investments with population needs. The second is primary healthcare expansion, prioritizing cost-effective primary healthcare teams, expanding multidisciplinary educational capacity, and scaling up family medicine to meet our evolving disease profile. Thirdly, targeted retention by implementing critical retention schemes, graduate job absorption, and improved working conditions to protect our valuable personnel. Achieving a resilient health system across Africa requires collective solidarity, robust domestic financing, and operationalizing the plan, train, retain flagship approach. South Africa stands fully committed to building a healthier Africa together and thanks the WHO's technical support in ensuring that this strategy becomes realizable. I thank you.
La parole.
Now, Malawi, thereafter Lesotho.
Lesotho supports the adoption of the Africa Workforce Strategy for sustainable planning, training and retention of health workers. Lesotho affirms that an equitable health workforce is the cornerstone for achieving universal health coverage. The country has made significant investments in developing its human resources for health, with 8 accredited nursing schools and a national university providing basic training for health professionals. These training programs are aligned with the Universal Health Care Strategy, the primary health care approach, and integrated service delivery models. Currently, our health workforce meets approximately 47% of national health service needs, with doctor density reportedly at 2.4 per 10,000 populations, and nurses and midwives at 17.6 per 10,000 populations, far below the WHO threshold of 44.5 per 10,000 required for meeting the universal health targets by 2030. This gap underscores the urgency of sustained strategic investment in health workforce development. To address this, the government has updated its Human Resource for Health Strategy and Development Plan 2020 to 2030, which emphasizes building a well-trained, equitable, distributed, and resilient workforce with the technical and financial support from the development and implementing partners. Through a structured and consistent scholarship system, Lesotho invests over 800 million annually in training basic health professionals locally and over 9 million in training health professionals abroad. While these investments have resulted in measurable progress in workforce production, challenges persist, particularly inequitable distribution, limited specialist capacity, and the loss of trained specialists who may not return after completion of training due to more attractive opportunities elsewhere. These gaps continue to constrain access to quality and comprehensive health services, especially in underserved and rural areas. Lesotho therefore calls for strengthened regional cooperation to support shared training platforms, joint curricular development, faculty exchange programs, and the expansion of digital and blended learning solutions. In parallel, investments in building mechanisms, supportive working conditions, and clear career progression pathways are essential to translate training investments into equitable service delivery. Lesotho has advanced plans under the Leboha program to establish a national medical school, further strengthening domestic training capacity. When aligned with national workforce plans and universal health care priorities, such initiatives can advance equity, strengthen health system resilience, and ensure that no population is left behind.
Merci,
I thank you.
Lesotho.
Thank you, Lesotho. Now, Malawi.
Malawi endorses the resolution. Malawi's health workforce investments align with the Africa Health Workforce Agenda 2026 to 2035, a new regional strategy to drive coordinated action to plan, train, and retain health workers at scale. The Ministry of Health and Sanitation is working with WHO to implement the recommendations from the 2025 Health Labor Market Analysis and engage stakeholders in dialogue on investments in health worker demand, supply, and population health needs. Malawi's report on the health labor market analysis highlights a notable increase in the density of healthcare professionals from 6.4 to 12.5 per 10,000 population between 2022 and 2024, a 95% increase in 3 years. This is as a result of a massive recruitment of over 15,000 frontline healthcare workers in the past 4 years. However, the current overall density falls short of the SDG index threshold of 44.5 per 10,000. Malawi has attained 28% of the SDG threshold density, leaving a 72% gap. The country is also advancing its health workforce charter and plans to sign compacts with development partners to consolidate government and partner health workforce investment under recruitment, deployment, performance management, motivation, retention, and to address low staffing levels, particularly in rural areas. Malawi reaffirms its commitment to strengthening the health workforce and to contribute to the effective implementation of the Africa Health Workforce Agenda 2026 to 2035, a strategy for sustainable planning, training, and retention of health workers. Thank you, Chair.
Merci.
Thank you. Distinguished delegates, I do not see any other requests for the floor by member states. Algeria, you have the floor.
Thank you, Mr. Chair. Mr. President, Algeria thanks the WHO Regional Office for Africa for establishing the Africa Health Workforce Agenda 2026-2035, a strategy for sustainable planning, training, and retention of health workers, which will certainly be a useful document for member states. Mr. President, as part of strengthening healthcare management and improving the quality of services offered to citizens, Algeria has opened this year 24,000 jobs positions intended for various medical, paramedical, and administrative staff. This operation for this purpose, a digital platform dedicated to the allocated and transfer of this position has been launched for this purpose. The Ministry of Health, responsible for this operation, has also introduced new measures on the platform to optimize the management of budgeted positions. To this end, the paramedical staffs receive the largest share with 14,000 positions, followed by contract workers 3,000 positions, specialist physician 2,000 positions, and general practitioners 2,000 positions. In addition, 2,000 positions are reserved for public health, midwives, and 94 senior health service administrators. The ministry has also allocated 2,000 positions to certain priority categories, including 1,500 positions for nursing assistants from accredited private schools and 5 positions for first-grade public health pharmacists. This initiative aims to strengthen human resources in the health sector, particularly in new healthcare facilities, and to improve patient care throughout the country. Thank you.
Merci.
Thank you, distinguished delegates. Now I do not see any other requests for the floor by member states of our region. I therefore invite the representatives of member states from other regions, UN agencies, and other IGOs, if they wish to take the floor, please raise your nameplate. And let me remind you that you have 1 minute to speak.
Dérogation, donc
We make an exception. Cameroon, you have the floor.
Merci.
Thank you, Mr. Chair, and thank you for making an exception for me. I just wanted to make another comment. Our delegation welcomes this Health Workforce Agenda 2026-2035. We see it as an ambitious response to the challenges of planning, training, recruiting, and retaining healthcare workers. This is the true globally. And we've faced this challenge in our own country regarding human rights resources. We support the agenda and we support its adoption. We believe that human resources are indeed the basis of a resilient and efficient healthcare system. And I'd also like to remind you that Cameroon has committed to community health, and this is why we are deploying healthcare workers at that level. For our country, we have emphasized the importance of this, including the recruitment. The goal is to recruit 10,000 more healthcare workers. We will also be emphasizing competences, especially when there are gaps in the healthcare system. The goal is to further integrate healthcare workers into the healthcare system, and we are doing so in the framework of our transition program, which aims to harness progress made. Cameroon therefore reaffirms its commitment to investing in health workers so that we can have a more autonomous, more resilient Africa and in better health. Thank you. Thank you, Cameroon. I now give the floor to Somalia, which will be followed by the UK.
Thank you, Chair, for giving me the floor. I also thank the Regional Director, Professor Mohamed Janabi, for inviting Somalia, an EMRO member state from Africa, to this important session. Somalia welcomes the African Health Workforce Agenda 2026-2035 and would like to highlight 4 key points. Number 1, shortage and retention. The persistent shortage of health workers across our continent, coupled with the challenge of retaining them, requires practical solutions to strengthen retention and ensure sustainable financing. Number 2, migration and data gap. Migration of health workers to high-income countries. We currently lack reliable data on this migration from the source countries. We propose African countries establish a joint health workforce migration database at the African Union and the African CDC. Negotiation with destination countries. We must negotiate directly with destination countries to secure fairer terms, compensation of our source for our source countries in line with WHO Global Code of Practice. Training and absorption capacity. Our training institutions are producing more health workers than our public and private health systems can absorb. Training capacity must be matched with the employment capacity. I thank you, Chair.
United Kingdom, you have the floor, followed by Iran.
Thank you, Chair. The United Kingdom congratulates the Regional Director and WHO African Region team on the report on the African Health Workforce Agenda 2026-35, the strategy. We commend the leadership on this topic and the strong technical work that underpins it, and we appreciate the ambition of the goals stated in the report. We also support the ongoing operationalization of the Africa Health Workforce Investment Charter. In the agenda, the strategy, we welcome the emphasis on adopting an evidence-based approach, the need to formalise the health workforce investment commitments through national compacts. This is a process which the UK has managed to support through our global and in-country partnerships in the region. We also, the emphasis we also want to point out is the undertaking of regular health workforce fiscal space analysis. We welcome this. Ministry of Finance and other government stakeholders should be at the table for the planning and oversight. It's incumbent on us, the UK, to be good partners in this and donors and really work to ensure we support the approach, ensure that we follow the government plans and push for investments to be aligned behind those plans. So we will endeavour to do this, and my thanks to the Secretariat for this opportunity to add our voice to this agenda. Thank you.
La parole.
Now Iran.
Thank you, Mr. Chair. Mr. Chair, distinguished guests, the Islamic Republic of Iran and the Iran University of Medical Science is well positioned to support the Africa Health Work Agenda 26 to 235, given the urgent need to transfer education and retention across the region. I recommend a focused partnership in 3 areas aligned with the strategy. First, transfer education. The new agenda emphasizes competency-based training. Without experience establishing a nursing and midwifery training center and school in Ghana, the Iran University of Medical Science can help scale the model by supporting national institutions to adopt the new WHO prototype curricula and develop joint dual accreditation programs. Second, address critical skill gaps. We can mobilize specialists to train local educators in high-demand fields like laparoscopy and medical technology, directly tackling critical skill deficits. This schedule could be coupled with a scholar exchange program to build a sustainable pipeline of local experts, fostering the strategic scientific health alliance we have proposed. The third one, to support the retention through the local manufacturing. In conclusion, we offer a partnership of solidarity to help African nations achieve their plans, train and retain objectives. We request the WHO consideration and support for this initiative. Thank you.
L'OIM, vous avez la parole.
IOM.
Thank you, Chairperson. From IOM's perspectives, we would like to commend the development of the Africa Health Workforce Agenda and subsequent endorsement by the member states here. We believe that this provides an important framework for strengthening the health workforce across the entire continent. While recognizing the challenges that health workforce mobility can present, migration should also be viewed as an asset that creates opportunities for individuals, strengthens regional cooperation, and improves access to healthcare opportunities and services across Africa. Through safe, orderly, and regular migration pathways, skills and knowledge and expertise can be shared where they are most needed, first within countries, and then where appropriate across the region. IOM remains fully committed to working closely with governments under their leadership and strategic direction to invest in training, capacity building, and workforce development within countries, helping to expand and strengthen the health workforce while ensuring that migration contributes to both national health system resilience and the broader development of the continent. This balanced approach contributes both to improved health outcomes and to Africa's broader social and economic development. Thank you.
Merci.
Thank you. Now, Nigeria. Another exception for Nigeria.
Thank you, Chair. Nigeria welcomes the African Health Workforce Agenda 2026-2035 and support the strategy for sustainable planning, training and retention of health workers. We commend the WHO for the timely development of this document. As Nigeria, the president in Nigeria is also the champion of the West African human workforce. Nigerians' achievement to meet the population health needs, Nigerians' health human workforce graduates has increased following the government policy of doubling the admission quota of health professionals across all the health training institutions. In Nigeria, This is aimed at increasing production to meet the shortages created by migration of healthcare workers. Recently, Nigeria has about 1,502 human workforce, and we are in need. By way of retention, Nigeria has dedicated 10% of its National Primary Healthcare Development Agency Gateway Fund under the Basic Healthcare Provision Fund for recruitment of skilled birth attendants and community health workforce for primary healthcare centers. Also, Nigeria developed a national policy on health workforce migration with key retention incentives and interventions to attract Nigerians in diaspora. In June 2026, Nigeria launched the Nigerians in Diaspora Advanced Health Program, an initiative for short and medium-term engagement of diaspora health professionals to enhance service delivery. All those are JATO, so our recommendation by as a country. Nigeria advocates for WHO and partners to strengthen health workforce research capacities and data systems to support the generation of timely evidence for effective policy formulation, implementation, and evaluation. Nigeria advocates for WHO and partners to support, strengthen, and institutionalize health workforce performance and productivity measurements to inform reforms in both pre-service and in-service training and improve quality of care in member states. I thank you, Chair.
Merci.
Thank you for your valuable contributions. I'm glad that I've heard that many non-state actors would like to deliver statements on this agenda item. I now invite them to do so. African Society for Medication and Laboratories, followed by the Federation of Neurology.
Thank you. Thank you, Chair. The African Society for Laboratory Medicine, ASLM, welcomes the Africa Health Workforce Agenda 2026 to 2035. No health system is stronger than the workforce behind it, and laboratory professionals are central to disease surveillance, diagnosis, antimicrobial resistance, and health security. Yet, Africa has only 1.83 laboratory professionals per 10,000 people, far below what is needed to achieve universal health coverage. Through the ASLM Academy and partnerships with member states, ASLM is helping build the next generation of laboratory professionals through competency-based training, leadership development, and modern learning pathways. We encourage the member states to invest in sustainable laboratory workforce development, strengthen career pathways, and recognize laboratory professionals as essential to resilient health systems and health security. Thank you.
La parole.
I now give the floor to the Global Foundation of Neurology, followed by Solem Alati at Lions.
Honorable Chair, Excellencies, colleagues, the World Federation of Neurology, with 126 member neurological societies worldwide, strongly supports the initiatives that led to the Africa Health Workforce Agenda and have made the health workforce an investment priority. We call attention to a shortage of neurologists across most African countries, where the burden of neurological diseases is disproportionately high. The World Federation of Neurology is prepared to collaborate with member states and is committed to strengthening workforce capacity through targeted educational initiatives, including accredited training centers and neurological education for primary caregivers. We advocate for the implementation of the WHO IGAP to preserve and protect brain health and maintain that increasing the availability of neurological services will amplify the impact of investments made in the health workforce, ultimately benefiting more people across Africa. I thank you.
Alliance
The Solem Alati Alliance, and then the International Society of Physical Medicine.
The NCD Alliance and Africa, NCD Africa, appreciate the opportunity to contribute to the Africa Health Workforce Agenda 2026-2035. Effective NCD prevention and management requires continuous, lifelong patient-centered care. However, Africa still faces critical health workforce shortages due to migration to higher income countries, inadequate recruitment, and weak retention of trained health workers. In the context of the agenda, we wish to emphasize the importance of improving NCD competencies, task sharing, and the implementation of PEN packages to the delivery of NCD prevention and care and the attainment of universal health coverage in the region. We support the Africa Health Workforce Agenda and call on member states to invest in and accelerate efforts to promote integrated case management of NCDs into primary care, train and adequately compensate community and primary care health workers, ensure qualified health workers are employed, ensure steady access to basic care technologies like blood pressure monitors, and finally, support medical schools to ensure the training of future medical professionals is of quality and responsive to community needs. Thank you so much, Chair.
La société
The International Society of Physical Medicine and Readaptation and the
International Society of Physical and Rehabilitation Medicine, together with the World Rehabilitation Alliance, welcome the Africa Health Workforce Agenda and support its adoption. Universal health coverage cannot be achieved without access to rehabilitation services with well-trained, equitably distributed and motivated multidisciplinary rehabilitation workforce. We call on member states to explicitly include multidisciplinary rehabilitation workforce in national health workforce accounts, health labor market analysis, national health workforce development strategy, particularly in rural, underserved, and crisis-affected communities. We urge WHO to embed rehabilitation workforce throughout the plan, train, return program, and its technical support. And its technical support and accountability mechanism. We stand ready to support the implementation so that no one who needs rehabilitation is left behind. Thank you.
Thank you. I now give the floor to the World Federation of Societies of Anesthesiologists.
Airway care, perioperative and intensive care, and blood management, working along the entire patient pathway. Yet our continent suffers acute and chronic shortages of this vital workforce, with many countries well below 1 per 100,000 anesthesiologists. Echo care depends on teams, and none of this agenda's occupational categories captures them. A country could meet every target here and still have no functioning surgical or anesthesia workforce. What is not counted is not planned for, not budgeted for, and not reported on. We therefore ask member states to make the surgical, obstetric, and anesthesia workforce visible within national staffing norms and workforce accounts, drawing on national surgical, obstetric, and anesthesia plans where these exist. The WFSA stands ready to support this work. Thank you.
La parole est à la Fédération africaine des associations d'étudiants en médecine.
I give the floor to the Federation of African Medical Students Associations, FAMSA.
The opportunity. Honorable Chair, Your Excellencies, and distinguished delegates, the Federation of African Medical Students Association welcomes and applauds the agenda's emphasis on retaining a strong and sustainable African health workforce, and we encourage consideration of an often overlooked stage of retention, the early years before graduation. Students are more likely to envision their future within African health systems when during their training they have meaningful access to mentorship, research, and cross-African professional opportunities. We therefore call on WHO, member states, and partners to strengthen opportunities for students to build professional networks and career pathways within the region from an early stage of their education. If we want to retain Africa's health workforce, we must begin by giving its future health workers a reason to build their future here. FAMSA stands ready to contribute the perspectives and networks of Africa's medical students to this effort. Thank you, Chair.
I give the floor to AfriHealth and the International Federation of Pharmaceutical Students should get ready.
Thank you, Chair. The African Forum for Research in Education and Health welcomes the Africa Health Workforce Agenda 2026-2035 and supports its adoption. We draw attention to one target in the annex, the proportion of countries implementing competency-based curricula aligned with regional prototype targeted from 11% to 80% by 2035, which is the steepest trajectory. Paragraph 11 identifies why it is difficult. Standards without institutional capacity to apply them will not move this indicator. AfriHealth contributed to the development of the Africa Health Professions Education Quality Standards, referenced at paragraph 31b and in the train pillar at paragraph 36b2. We are ready to support member states on this. We also note that paragraph 33c, AfriHealth has developed with the Secretariat a postgraduate curricula in human resource for health, leadership, and management. Finally, we support the emphasis of paragraph 9, investment in education alone without parallel financing for employment risks, training health workers whom health system cannot absorb. AfriHealth thanks the regional committee. Thank you.
La parole.
I give the floor to the International Pharmaceutical Students Federation.
Thank you for giving the floor. Honorable Chair, distinguished delegates, Africa's health system continues to face critical shortages, uneven distribution, and weak retention of health workers, with pharmaceutical personnel among the 10 priority occupation tracks under this agenda. IPSL represents over 600,000 pharmacy students and recent graduates in over 100 countries and support workforce readiness through our Leader in Training event and further mentorship, capacity building, and career development programs that prepare pharmacy graduates for practice across the region. We call upon WHO and membership states to operationalize the Africa Health Workforce Investment Charter with sustainable financing, modernize and expand pharmacy education capacity and quality, improve employment, retention, and career progression pathway for young pharmacists, strengthen leadership, governance, and management training for early career health workers. Thank you very much.
Public Services International, you have the floor. And the International Federation for the Medical Students, please get ready.
And esteemed delegates, PSI appreciates member states' affirmation of commitment to address the health workforce crisis in the region with this agenda. We note the improvements in health workforce density despite COVID-19 and abrupt external funding cuts shock, but remain deeply concerned that half of the estimated 12.9 million global health workforce shortages by 2035 will be in the region. The vision and guiding principle of the strategy, hinged on enthroning the human right to health, provides a foothold for fundamental steps to remedy the situation. We urge member states to base investment in the health workforce on public funding and align their health workforce fiscal analysis with advocacy in multilateral spaces and the global political economy to push back IFI conditionalities, austerity frameworks, and migratory contexts which have created the paradox of both 700,000 unemployed health professionals and severe workforce shortages. We also call on member states to include active involvement of trade unions in the sector and social dialogue in the agenda in line with the WHO Working for Health theory of change. Thank you, Chair.
The International Federation of Medical Students Associations.
Honorable Chair, distinguished delegates, the International Federation of Medical Students Association welcomes the Africa Health Workforce Agenda 2026-2035, recognizing that universal health coverage depends on the people who deliver it. Yet Africa's health workforce shortage is projected to exceed 5.85 million by 2030, while many educated health professionals remain unemployed and underserved communities lack care. We urge member states to translate this agenda into national investment plans that align education with employment and deployment. We must train the workforce we can employ while investing in their salaries, safe working conditions, career development, and mental health support to retain health workers. We further call for competency-based education, accreditation, and inclusion of students and professionals in workforce planning. Africa cannot build its health workforce without planning where they will serve, how they will grow, and why they will stay. Thank you.
Merci. La parole est à...
The World Association of Family Medicine.
Thank you. Family physicians.
Honorable Minister.
Family physicians are well-trained generalist doctors who can reduce the competency gap in multidisciplinary teams within primary healthcare and primary hospitals. They help manage people with more complex medical problems, act as consultants to the clinical teams, build capacity, improve quality and patient safety. Strong evidence shows that continuity, coordination, and comprehensiveness deliver better outcomes, patient safety, and stronger communities across the life course. These are the hallmarks of person-centered family medicine. The World Organization of Family Doctors in the African region shares the concerns expressed in the African Health Workforce Agenda regarding this competency gap and the need for a functional workforce to achieve universal health coverage. WONCA Africa calls on WHO and member states to support the scale-up and development of training programs for family physicians, for example, the new East, Central, and Southern African College of Family Physicians, and deploy graduates within primary healthcare teams and primary hospitals. Thank you.
Merci.
Thank you. I do not see more requests for the floor. I'd like to invite the Secretariat to make any comments. Dr. Jenabi, you have the floor.
Thank you, Chair. Honorable Ministers, Excellencies, distinguished delegates, as we are discussing the health workforce, allow me to share with you a reality that should concern all of us as listening to your contribution in this session. It is important the world should know Africa is investing in training health workers. Between 2022 and 2024, our member states trained and added more than 500,000 health workers, including approximately 300,000 community health workers. Yet our region still has only about 46% of the health workers it needs, and we face a projected shortage of nearly 6 million health workers by 2030. At the same time, approximately 1 in every 10 doctors and nurses trained in Africa is working abroad, while many more are considering leaving, actually 1 in 6. Allow me to be clear. This is not an argument against mobility. Our health workers have every right to pursue opportunities wherever they choose. Mobility is part of the global labor market, but mobility must be matched by partnership. A recent UK parliamentarian inquiry estimated that NHIS has benefited from approximately £14 billion in avoided training costs through employing international trained doctors, nurses, midwives, including more than £1 billion in avoided costs in a single recent year. I was there in March this year in Charterhouse with 13 of these bipartisan MPs and NHIS top brass discussing about this topic. But the United Kingdom is only one example. The same pattern is seen across Europe, North America, Middle East, and parts of the Pacific, where health systems increasingly rely on professionals trained in Africa. There's another reality we must confront. Much of the training of health workers in Africa is supported through grants and development financing, originating from partners in the global north. We train the workforce, often with resources we struggle to mobilize ourselves, yet a significant share of the benefit is realized elsewhere. In some cases, the value gained from recruiting our trained professions exceed the annual health budgets of several of our member states. Honorable Ministers, this is a question we should be all asking. For how long? For how long will Africa continue to train a workforce that it cannot fully retain? For how long will countries with severe workforce shortages effectively subsidize health systems that are far better resourced? Yet we also know what works. Let me give you an example of Zimbabwe. In Zimbabwe, a WHO-supported health labor market analysis informed a national workforce investment compact of approximately $463 million. The results were remarkable. Health worker attrition fell by 61%, 14,000 new health worker positions were created, annual graduates doubled to 8,000, and 23,000 community health workers were formally integrated into the health system. What does this say? It demonstrates that challenges is not that Africa cannot retain health workers. The challenge is whether we are willing to invest at the scale required. Africa is not asking for destination countries to stop recruiting our professions. We are calling for a new compact based on a shared responsibility, where recruitment is accompanied by co-investment in African training institutions, specialist education, employment opportunities, and workforce retention. This is not an aid, it is fairness, it is partnership, and it is an investment in global health security. The question before us is not whether Africa can train health workers. We already are. The question is whether the world is ready to invest with us so that Africa can retain, deploy, empower the workforce needed for our continent and for the world. I thank you. Dr. Onyango, please.
Thank you very much, Chair and RD. I will just I acknowledge the interventions and the overwhelming support that we have received from the 34 member states of the African region, plus 3 others from member states from other regions that took the floor to speak on this agenda item, and our non-state actor partners. So we are well aligned. This is a strategy that has been very inclusive in its development. We have had repeated consultations with member states and with professionals. So I'm glad that it reflects the expectations in terms of the quality of a document that comes from the World Health Organization. Responding very specifically to a question raised by Namibia, or rather a recommendation, the question has been responded to by our regional director in terms of what other countries could do better and how we can leverage the assets we have in terms of the training and the compacts that we make with the recipient countries. Now, on strengthening the implementation guidance, some of that actually is part of what we're doing as we conduct the National Health Workforce accounts, as we do the labor market analysis, because that defines what the priorities are and the needs are in each country. And therefore, as we follow those principles and we bring together the collaboration of different sectors, the public health, the training in terms of the education and financing, we are creating an environment, we're creating the situation that responds to a very specific country needs. So the work that is ongoing and that many of you have acknowledged is actually part of the implementation guidance, because then it has to be customized to each country's needs. And therefore, we thank you. I thank you very much and hand back to the chair in the interest of time. Thank you.
Thank you, Secretariat. The Secretariat has taken note of the comments raised. Shall I take it that the Secretariat has taken note of the comments and that the Regional Committee is ready to adopt the resolution contained in document AFR/RC76/WP1, which includes adoption of the proposed actions of the document AFR/RC76/4 entitled Africa Health Workforce Agenda 2026 to 2035, a strategy for sustainable planning, training, and retention of health workers? I see no objection. It is so decided.
Nous allons poursuivre nos travaux avec le...
We will now continue with agenda item 9 entitled Advancing Early Childhood Development Outcomes for Children in the WHO African Region, a regional strategy under Goal 2, Provide Health. Please refer to document AFR/RC76/5 and the accompanying resolution in document AFR/RC76/WP2. These documents will be presented by Dr. Onyango, Director of the Health Systems and Services Cluster. Dr. Onyango, you have the floor, and you have 10 minutes for your presentation.
Thank you, Chair. And as the presentation comes up, on behalf of the Secretariat, I'm privileged to introduce document AFR/RC76/5, the Regional Strategy on Advancing Early Childhood Development Outcomes for Children in the WHO Africa Region, 2026 to 2032. The purpose of the document is to position early childhood development as an urgent priority, catalyze accelerated scaled action by the health sector to give every child the best start in life. It outlines the context, key challenges, and strategic actions needed to improve early childhood development outcomes across the African region. Next slide, please. Early childhood development lays the foundation for life. From conception up to the age of 8, children develop cognitive, physical, language, and social and emotional skills that will shape lifelong health, learning, and productivity. The graph on the left shows you that from conception to the age of 3, the brain develops at an extraordinary pace, creating a critical window where nurturing care builds potential and adversity can limit that potential for life. Yet, in our region, up to 2/3 of children risk never reaching that full potential. As you look to the panel on the right, we can see that investing in early childhood development is a high return imperative. It will reduce inequality, build human capital, and achieve SDG target 4.2.1 and Agenda 2063. Our human capital is critical. The cost of inaction is therefore lifelong, and the health sector has a unique opportunity to change this and to do that now, because we have critical contact with mothers and children in that stage of this development. Next slide, please. Children need nurturing care. This means, next slide, please. This means environments that meet health and nutrition needs, provide emotional support, stimulation, play, and protection from adversity. Caregiver and maternal mental health and psychosocial well-being are also important for early child development. we see what exists already in early child, maternal and child healthcare. We have already interventions in health and nutrition, and these need to be strengthened. We can see also that we need to do more for caregivers and families, because we do not always have contacts with women and families as they need the support that will help them to provide the care that their children need. Their own well-being is important for the young ones' well-being. So on the next slide, let's look quickly through the issues and challenges that we need to pay attention to as we move forward on the implementation of the strategy. There are persistent inequalities that continue to undermine development, and I think we understand that from the disparities in the resources that are available for families across socioeconomic cadres. There is insufficient support to families, as I've already alluded, because there's inadequate support for providing nurturing care. I'm glad that we're doing some of this work in the context of preventing violence against children, because that violence comes also as part of the lack of adequate care and the partnership that we have on this with UNICEF and other partners. Then we have the health and social protection systems that remain weak and under-resourced. The investment in early childhood development falls short despite the fact that it has these proven returns, so we need to make an economic case for those investments. Data and accountability also are a little lacking, and we have mechanisms that need to be improved in terms of making sure that we have access and translation of adequate, of sufficient data. There is the need for multi-sectoral coordination between the health sector, the social protection sectors, education sector, and all those who come together in the support of children in this very critical period. Plus, of course, we understand that there are external factors, conflict, climate change, and economic shocks that also threaten the progress that we can make in this area. So we go to slide 5 and look at some of the proposals that the Secretariat is putting forward to member states to consider, and as we move into strategic action. One for the Ministries of Health is to elevate childhood development as a national development and investment priority through shared accountability and coordinated action with other sectors. We see it's an investment in overall development if the children are catered for in ways that will ensure that they can learn, they can grow, they can perform when they become workers. We need to institutionalize community engagement and participation so that families are empowered and communities are supported in providing what the young children need for their development and well-being. We need to strengthen systems and scale up integrated services to enable survival and healthy development of every child. They need to survive, but they need after that, and very much after that, to thrive, because that's the future. Then we need to strengthen measurement, monitoring, and accountability for early childhood development outcomes. On behalf of the Secretariat, on behalf of the Secretariat, I submit this strategy and the associated resolution for the Regional Committee's consideration and adoption. Thank you.
Merci, Dr.
Thank you, Dr. Onyango. I now open the floor to member states' interventions.
La Guinée, vous avez la parole.
Guinea, you have the floor, followed by Niger. Thank you, Chairperson. Honorable Ministers, distinguished colleagues, distinguished guests, Guinea would like to thank you for the quality of the regional strategy and supports this roadmap. We share the conviction that investing in early childhood is the way to the country's sustainable development. Guinea has been doing vaccination, nutrition, and delivery interventions. However, neonatal deaths, poor vaccination coverage, and nurturing care are an impediment. We thank you for this multi-sectoral strategy that brings together social protection, education, health, and other components that are important for human capital. We are there for women, children, and adolescents. We want to fight against malnutrition, violence, and unequal access. We want more investment in primary health care, community workers, and we support the adoption of this strategy. We encourage the WHO to support member states in its implementation through capacity building, technical assistance, and the mobilization of sustainable resources. We are committed to actively contributing to this new dynamic so that our children have a success. Thank you.
La parole est
Now Niger.
Monsieur le Président,
Mr. Chair, Regional Director, distinguished delegates, the situation of infant mortality by age in Niger is roughly it has rather been reducing in recent years from around 2 to 3, and the mortality rates have been reducing even across the different age ranges if we compare it to 2021. And we have been doing studies on this. The studies show that we've been improving our statistics, especially when it comes to the health of young children. We have been undertaking various different programs aimed at, amongst others, reducing neonatal mortality. We've been improving monitoring and health and the well-being of mothers. We have been undertaking audits of our performance as well. We have done a communities level study so that we can understand how children are being cared for at that level and how we can finance it. Now, Niger will continue to do pediatric audits in hospitals. This will focus on the health of newborns and children between the ages of 6 and 8. We support the regional strategy on advancing early childhood development in the WHO African region, and we would invite other member states to also adopt it. Thank you.
Eswani, vous avez la parole. L'Angola se prépare.
The next is Eswatini.
Chairperson, the case for this strategy is both moral and economic. What happens in a child's earliest years shapes health, learning, and productivity for a lifetime, and those years cannot be revisited. This strategy aligns with our integrated management of neonatal and childhood illness programs and our wider primary healthcare reforms. We see particular value in early identification of developmental delay, support for children with disabilities, nutrition, child protection, and we emphasize this, caregiver mental health. We cannot support a child's development while ignoring the well-being of the person caring for them. The need is visible in our own data. Teenage pregnancy stands at 18 per 1,000 facility beds, and non-communicable diseases now account for close to half of all deaths, reaching the caregiving generation directly. We commit to multi-sectoral governance with clear mandates across health, education, social protection, and community systems, to scaling integrated services, and to sustainable domestic financing with regular reporting. We can build on existing strength. Routine reporting completeness and now exceeds 97%. And this past year, we digitized community health information nationally for the first time, a base on which to add developmental indicators rather than construct a parallel system. We asked WHO for technical support and for regional exchange of what already works, since early childhood outcomes remain our least well measured. Chairperson, the Minister of Health of the Kingdom of Eswatini affirms its full support for the adoption of this regional strategy and commits to ensuring that every child in Eswatini has the opportunity to survive, to thrive, and to reach their full potential. Thank you.
Merci.
Thank you. Angola. And CAR is next. Thank you, Mr. Chair, Your Excellencies, Ministers of Health, Your Excellency, Regional Director. Angola congratulates the Secretariat for the regional strategy on ECD outcomes for children in the WHO African region. Angola is aware that the early years are determinative for young children. It's a very important time in order to protect their health in later years. Therefore, an approach needs to be based not only on the survival of children, but overall health, so that they can grow emotionally, cognitively, socially, and in safety. These are essential interventions so that each child can achieve its full potential. Therefore, we fully support an approach which is multi-sectoral in nature, which puts health and education, social protection at the very heart of the approach. Primary healthcare is an essential platform for this. It will support this approach. We must ensure that pregnant women are supported adequately, that they have high-quality healthcare, and that they are duly supported throughout the process. And children must benefit from health care of a high quality from the moment they are born. We also need to ensure that they are accompanied by the healthcare system throughout their early years so they can achieve their full potential. Angola sees that it is important to focus on the inclusion of this approach in our policies on ECD. We must also focus on the most vulnerable. Therefore, mobilizing domestic resources is vital. We also need commitment from partners. Thank you, Angola. Angola supports the approach. Thank you. Now CAR, following by Sierra Leone. Thank you, Mr. Chair. The CAR would like to thank the Secretariat for the regional strategy aiming to improve ECD outcomes for children in the region. We would in particular support its integrated and multi-sectoral approach, which places the family and the child at the heart. Now, CAR has been investing strategically in ECD. We've been therefore investing in human capital too. And there is a clear link between this strategy and our own policies and programs, because we aim to invest in nutrition, education, social protection, and child protection. However, the CAR continues to face significant challenges, especially when it comes to accessing healthcare services. This includes nutrition, hygiene, and protection of children. And these challenges are starkest in areas where where communities have been hit the hardest by crises. We therefore need to ensure that healthcare interventions are done from the moment of birth. We need to include vaccination in this effort. We also need to ensure that parents are supported. Therefore, the CAR sees it necessary that we focus on community-level interventions. We encourage WHO and partners to support member states when it comes to resource mobilization, building capacity, and identification of progress that has been made. Conclude, the CAR supports the regional strategy, and we reaffirm our commitment to accelerating investments in ECD so that each African child can develop fully and realize their potential. Thank you very much. Now, Sierra Leone, you have the floor, followed by Mali.
Thank you, Mr. Chair. Representing the Minister of Health, Sierra Leone welcomes the regional strategy on advancing early childhood development outcomes for children across the WHO African region. Sierra Leone has made important progress integrating early childhood development in the health system. We have strengthened the integration of well child care, developmental milestone screening, nurturing care, and early stimulation within nutrition, newborn and child health services. The early childhood development has also been incorporated into our integrated management of newborn and childhood illnesses guidelines and training tools. We are particularly pleased to highlight the establishment of National Early Childhood Development Network amongst ministries, departments, and agencies, as well as national champions. We recognize significant gaps and are currently undertaking assessments in facilities to assess preparedness for early child development, which will help us better understand service delivery gaps, workforce capacity availability, and resources required to scale up quality early child development interventions. We therefore commend WHO Afro for this important regional strategy and encourage continuous support to member states to translate the strategy into country-level action. Sierra Leone remains committed to ensuring that every child has the opportunity to survive, thrive, develop to their full potential, and contribute meaningfully to the future of our nation. Thank you very much.
Mali has the floor, followed by Mauritania. Thank you, Mr. Chair, ministers, distinguished delegates. Mali reaffirms its commitment to the strategy on advancing ECD outcomes. Progress in this report shows that there is momentum at the regional level, but we also now know what to do to achieve our goals. Mali would like to see increased support, especially when it comes to supporting midwives, and to do so at a community level too. Considerable challenges face us, such as inequality of access, the lack of qualified personnel, and the effects of security and climate-related crises. In Mali, we have a serious situation, and this requires increased collaboration and cooperation. This is why we welcome investments into the healthcare system. We have been investing in, among others, social protection and hygiene and ECD in general. In this way, we can make our healthcare system more resilient especially at a time of crisis. Mali welcomes and is grateful for the constant support of the WHO, and we would appreciate ongoing support. We can work together to ensure that each child and each woman is adequately supported. We recommend the adoption of this report. Thank you. Now, Mauritania, followed by Zambia. Mr. Chair, Regional Director, distinguished delegates, the Islamic Republic of Mauritania welcomes this regional strategy on ECD outcomes. And Mauritania sees ECD as a vital investment for human capital and development in general. The Ministry of Social Action and Childhood is in charge of our domestic strategy. Despite efforts made in our country, there are persistent challenges. When it comes to preschool education, we have been focusing on community-level support, but access to this is still limited. Progress has been made when it comes to vaccination, nutrition, maternal health, childhood health. This progress has helped improve the development and growth of children. New lifestyles have unfortunately led to the resurgence of various different diseases. In conjunction with this, malnutrition is still a problem. Therefore, we need to ensure that we protect children from various risks. This includes exploitation. This is why we would appreciate clearer guidelines on how to draw up programs which can better achieve this goal, namely nutrition and support for ECD. This can include digital tools. We also need to ensure that we can respond to climate-related events, remembering that ECD is a timely intervention in the life of a child. Therefore, clear guidelines would be very helpful so that we can have effective programs. We need policies that support communities to provide a more holistic support to children. Now Zambia, Mauritania, now Zambia.
Thank you, Chairperson, honorable ministers, distinguished delegates. Zambia's experience in advancing early childhood development aligns with the WHO Africa Regional Strategy 2026 to 2032 and the Nurturing Care Framework, and therefore support the adoption of the resolution. Recognizing that the early years lay the foundation for lifelong learning, health, and economic productivity, Zambia has steadily translated regional frameworks into nationwide practice across health, education, and social protection sectors. A cornerstone of Zambia's progress is a strong multi-sector governance and policy leadership. By actively engaging parliamentarians as champions across health, community development, and education committees, the country has built high-level political buy-in for sustained ECD funding and legislative alignment. Operationally, the Ministry of Health has integrated care for child development principles in primary health care, developing standardized manuals that equip healthcare workers and community agents to counsel families on responsive caregiving, early play, and proper nutrition. To ensure equity, Zambia prioritizes community-based implementation and caregiver well-being. Through frontline health volunteers, parenting groups, and home visits, nurturing care interventions reach the most vulnerable households with practical guidance on child safety, early stimulation, and positive parenting. Through the community-based integrated ECD hub approach, known as INSACA, Zambia is scaling up a multi-sector ECD program nationally to converge health, including immunization, nutrition, early learning, social protection, WASH, and parenting services closer to the communities. Concurrently, initiatives such as caring for the caregiver acknowledge that supporting parental mental health is indispensable for responsive care. By combining national policy leadership, frontline health system capacity, and community empowerment, Zambia exemplifies how member states can operationalize the regional strategy to ensure that young children survive, thrive, and reach their full potential. I thank you.
La parole è alla Tanzania.
Now Tanzania, followed by Madagascar.
Thank you, Mr. Chair. Tanzania, by realizing that the ECD is very critical and also thinking to foster the coverage, we developed a national multi-sectoral ECD program, but also we are implementing, focusing on the 5 nurturing care of the WHO. So we integrated the ECD into the existing packages, particularly for the maternal health, but also assigning the focal person in multi-sectoral programs, but also the implementation of growth monitoring and feeding programs, deworming and the management of the malnourished child, but also implementation of the school health feeding and fortification programs, allocation of at least $50 for children under 5 in every district. All this aims to improve nutrition. We're also operationalizing the parenting guidelines, but also the provision of child health booklets and the intervention within immunization. All this aims to provide the early learning at home, but also the preschool education integrated. The ACD also aims on the same purpose. But also we have the prevention and the management programs, especially prevention for injuries and common diseases like malaria and diarrhea, but also the adaptation of the global policies. All these aims for safety and security. So, Mr. Chair, as I conclude, that integration and multi-sectoral planning, coordination, implementation, and the follow-up of high-impact intervention is a key for scale-up of OECD nurturing care. I submit.
Madagascar, followed by Ethiopia. Thank you, Mr. Chair, Your Excellencies, dear colleagues. Madagascar would like to thank and congratulate the Secretariat for this strategy. We fully support this strategy. Like many other countries, in our country, children still face multiple challenges. These include climate-related crises, GBV, and a lack of access to essential services. We are implementing a national strategy for ECD, and we are also ensuring that all children benefit from this. So our approach is based on stimulation and mental well-being. Our priorities are clear. We want to better coordinate between healthcare, education, social protection. We want to better integrate ECD in primary healthcare and data usage. Madagascar has also been developing a strategic plan which is aimed specifically at supporting children. We would appreciate the support of our partners in order to implement this. We would like to ensure that each child has an avenue for growth, and this is part of the Africa that we want approach. Thank you. Now Ethiopia, followed by Comoros.
Thank you, Mr. Chair. Ethiopia welcomes the regional strategy on advancing childhood development outcomes for children in the WHO Africa region 2026-2032 and supports the adoption of the strategy and its accompanying resolution. We commend the Secretariat for providing a practical framework that responds to the urgent reality that too many African children still fail to reach their development potential. The evidence is clear. Investing in the early years yields substantial returns for health, learning, and productivity. Ethiopia speaks from experience. We adopted and operationalized the nurturing care framework through multi-sectoral collaboration, capacity building, and coordinated planning. We have also developed a national early childhood care and education policy framework and established mechanisms to strengthen monitoring and accountability. Through the Sakota Declaration, we remain committed to ending child stunting by 2030, while continuing efforts to expand access to early learning and nurturing care, particularly for underserved population. Ethiopia offers 3 observations. First, we strongly support government-led multi-sectoral coordination mechanisms with a formal mandate, authority, and sustainable financing as reflected in the strategy's target. Second, we welcome the strategy's costing approach and encourage support to help member states translate regional estimate into actionable national financing plans. Third, we support triennial progress reporting and encourage alignment with existing reporting mechanism to reduce duplication and strengthen accountability. Ethiopia commits to strengthening multi-sectoral coordination, closing equity gaps in access to nurturing care and early learning, advancing measurements for young children, and sharing lessons from our experience. Ethiopia supports adoption of the strategy and resolution. Thank you, Chair.
La parole au Comores.
Now Comoros, followed by Togo. Mr. Chair, Comoros would like to thank the Secretariat for this high-quality report on the ECD outcomes for children in our region. We welcome this initiative because it looks to operationalize NCF and to achieve the SDGs. It also aims to achieve the agenda for the 2063 agenda of the African Union. Comoros sees investment in ECD as one of the most strategic investments when it comes to human development in a general sense. We want to ensure that each child has an opportunity to have good health, to grow up in a safe environment, and to learn from an early age, that is, to have education. Now, in this line, Comoros has implemented targeted interventions, for example, maternal health and community healthcare. We see this as vital in order to ensure that ECD is included within the healthcare system. Now, we encourage the systematic integration of climate resilience and the continuity of essential services, as well as emergency situations in national development policies for ECD. The goal there is to preserve progress made and to make sure that the most vulnerable children do not get left behind. Comoros supports the adoption of this regional strategy, and we reaffirm our commitment to working with the WHO and partners to ensure that every child has the best opportunity as possible. Thank you.
Le Togo.
Togo has the floor, followed by Senegal. Thank you, Mr. Chair. Dear colleagues, distinguished delegates, Togo fully supports the guidelines in the regional strategy on NCF and ECD. We note that the earliest years of life are the most important for human development and economic development too. It is in line with this that Togo has taken several reforms in this area. For example, we have a national framework for ECD. We have strengthened the vaccination program, which we've also enlarged in its scope. We've also focused on infant and maternal health. We have free health care for school children in our country. Now, we also have a program to support pregnant women and newborn children. We have social programs to fight against child malnutrition. Togo is also extending its support for newborns. This is also aimed at ending stunting. We have also been providing school cafeterias, especially in underserved areas. However, access to preschool education is still limited in rural areas. Likewise, integrating maternal health in the healthcare system is a challenge that we still have to overcome. And this is why Togo would appreciate increased regional solidarity. And we invite member states to adopt the strategy. Thank you.
La parole.
Senegal, thereafter Kenya.
Merci, Monsieur le.
Thank you, Chairperson. Chairperson, Honorable Ministers, Regional Director, distinguished delegates, Senegal would like to thank and congratulate the Secretariat for developing the Advancing ECD Outcomes for Children in the WHO African Region 2026-2032, a regional strategy. Senegal places ECD, in particular, the first 1,000 days of life as part of its priorities. It has achieved significant progress through the reduction of child mortality by 50% since 2000. It has developed strategic documents, put in place multi-sectoral coordination platforms, and trained teams in 4 regions. The strategy for early childhood has been revised, and stunting that affects 1 out of 2 children, unequal access to health and education, limited access to preschooling, and high exposure to screens, climate shocks, economic shocks, fragilize ECD. Senegal wants to have a conducive environment for vulnerable children and institutionalize participation of communities and scale up essential services. We would like international cooperation that is strengthened for innovative financing for the first 1,000 days of a child's life, and we want to invest in Africa's future and achievement of Agenda 2063. No child should be left behind. We take note of the strategy and we call for the adoption of the proposed measures therein. Thank you. Thank you. The floor is to Kenya. And Mozambique should get ready.
Children born in the world will soon be African. This single reality defines the future of our continent. The trajectory of human history will be decided by how we protect and empower our youngest citizens today. Early childhood development is not a welfare luxury. It is the cornerstone of national productivity, economic growth, and security. Yet, across sub-Saharan Africa, 2/3 of our children risk failing to reach their developmental potential due to poverty and malnutrition. We cannot build the Africa we want on a foundation of compromised human capacity. Kenya is stepping up while 78% of our young children are on track developmentally. We are pushing to hit global standards. We have embedded milestone tracking into every health clinic contact. We have integrated perinatal mental health into primary healthcare. We are finalizing a unified national early childhood development policy. I call on all member states to join us in elevating early childhood to a primary national priority. Let us break down government silos, empower our local communities, and hold ourselves strictly accountable to the children we serve. When we nurture our youngest citizens, we secure the future of Africa itself. I thank you.
Merci.
Thank you. Ladies and gentlemen, I'd like to remind you that we would like to complete the list before lunch. Mozambique, followed by Ghana. Good afternoon, Chairperson. Thank you for giving me the floor. We would like to thank the Secretariat for the quality of the regional strategy drafted for the future of the region for Mozambique. Investing in the early years of a child is a strategic decision with a view to reducing poverty in a sustainable manner. And this is why the country supports the Advancing ECD Outcome Strategy 2026-2032. We are finalizing our own strategic plan, which will integrate the strategy and so that we can ensure that we integrate early childhood services and so that we have early stipulation and ensure that we can face public health emergencies and climate shocks that our country faces. We would like technical support from the WHO to ensure that we improve our health information systems, particularly in the context of emergency situations. We want to work in concert with other countries of the Africa region so that we do not leave any child behind during the first 1,000 days of their lives. Thank you. Ghana, you have the floor.
Thank you, Chair. Ghana has made important efforts to promote early childhood development through interventions spanning health, nutrition, education, and social protection. We recognize, however, that improving outcomes requires stronger coordination across these sectors, particularly during pregnancy and the first years of child's lives. Ghana therefore welcomes the strategy's emphasis on integrated, multi-sectorial approaches and strengthening services at the primary healthcare and community levels. We believe that health facilities and community health platforms provide important opportunities to promote responsive caregiving, early learning, maternal and child health, nutrition, growth and development monitoring. Accordingly, Ghana will pursue the following priorities: strengthen integrated early childhood development services through primary healthcare and community-based platforms with greater attention to developmental screening and early intervention. Strengthen the capacity of frontline health workers and caregivers to identify developmental concerns and promote responsive caregiving, early learning, and appropriate nutrition. Improve coordination across sectors, particularly health, education, nutrition, and protection to ensure that children and families receive comprehensive support. Strengthen data and monitoring to better track early childhood development outcomes and identify children and communities requiring additional support. And finally, Ghana supports the regional strategy and calls for sustained domestic investment and stronger partnership to ensure that every child in the African region has the opportunity to survive, develop, and reach their full potential. Thank you, Chair.
I'll give the floor to Burkina Faso, and Botswana will follow. Thank you, Chairperson. The delegation of Burkina Faso would like to thank the Secretariat for the quality of the documents and commends the development of the Advancing ECD Outcomes for Children in the WHO African Region 2026-2032 regional strategy. We subscribed to its integrated approach based on nurturing care that include the development of a child in all dimensions, which is indispensable for their survival and their thriving. Chairperson, Burkina Faso has a national development strategy that integrates early childhood, complemented by a national strategy for accelerated preschool education 2021-2025. The latter aims to improve access to quality preschool education. At the health level, our country continues providing free care for children aged below 5, covering curative care and providing necessary medicine. It also ensures that there is vaccination with the introduction of anti-malarial vaccines in routine vaccination or immunization campaigns since 2024 and vaccination against typhoid in 2025. Burkina Faso pays particular attention to nutrition and the monitoring of growth and development of children, as well as early stimulation and preschooling. These interventions are complemented by protection measures of the rights of the child, prevention of violence, and particularly the protection of vulnerable children. Burkina Faso supports the regional strategy 2026-2032 and urges all member states to adopt it. Thank you. The floor is to Botswana. Gambia will follow.
Botswana, yes.
Botswana first.
Thank you. Thank you very much, Chair. Botswana welcomes the opportunity to comment on the regional strategy for advancing early childhood development outcomes for children in the WHO African region. We appreciate the work undertaken by the Secretariat, the member states and partners for recognizing the importance of early childhood development in improving health, well-being and lifelong outcomes for children across the African region. Botswana considers ECD important in the achievement of national development priorities, and we have had a policy framework for holistic early childhood development since 2018, implemented through the Ministries of Health, Local Government, Child Welfare and Basic Education. Our experience demonstrates that effective ECD implementation requires coordinated action across sectors and integration within existing systems. Botswana has further developed an intersectoral ECD implementation plan and a common reporting framework for holistic ECD. This reinforces the importance of ensuring that regional priorities are translated into practical country-led actions. As countries faces increasing demands on primary healthcare systems and persistent gaps in the early identification and referral of children with development difficulties, Botswana recommends stronger regional collaboration on integration or integrating nurturing care, developmental monitoring and early intervention into routine maternal, newborn and child health services. In conclusion, Chair, having examined the draft resolution of this agenda item, Botswana support the adoption of the regional strategy and its draft resolution. Thank you.
La parole.
I now give the floor to Gambia, followed by Congo.
Thank you very much. The Republic of the Gambia commends the WHO Afro for developing the regional strategy on advancing early childhood development outcomes for children in the WHO Africa region 2026 to 2032 and supports its adoption. Investing in early childhood development is essential to improve health, learning, well-being, and long-term productivity. The Gambia shares the concern that many children in the region still face poverty, malnutrition, inadequate stimulation, violence, and limited access to quality services. We welcome the strategy's focus on nurturing care, equity, multi-sectoral action, and sustainable financing. Nationally, the Gambia has made progress through expanded primary health care, immunization, maternal and child nutrition, integrated management of childhood illnesses, early learning initiatives, and community health promotion. Collaboration across health, education, nutrition, gender, and social protection has also improved support during the critical early years. The country continues to promote maternal, newborn, and child health services, exclusive breastfeeding, growth monitoring, parenting education, and community awareness, contributing to improved child well-being and stronger family recognition of early childhood development. However, challenges remain, including stunting, micronutrient deficiencies, uneven access to quality services in rural and hard-to-reach communities, limited resources, weak data systems, and insufficient integration across sectors. The Gambia welcomes the strategy's call for stronger leadership, effective coordination, domestic financing, family and community engagement, caregiver support, and improved monitoring and accountability for results. We encourage WHO and partners to support member states to strengthen policies and coordination mechanisms, expand integrated services for underserved communities, build workforce capacity to deliver nurturing care, improve data systems, and mobilize sustainable investment. The Gambia family believes that every child deserves the opportunity not only to survive, but to thrive and reach their full potential. We support the adoption of this strategy and reaffirm our commitment
Gambie, merci.
to advancing.
I give the floor to Congo. Malawi, please get ready. Chairperson, ladies and gentlemen, Congo congratulates the Executive Secretary for introducing this regional strategy for development of early childhood 2026-2032 that responds to child survival and thriving concerns. We have already begun on this journey through offering free services and scaling up immunization services. We have increased our vaccination to 85% between 2022 to 2025. The infant and child mortality rates have dropped in 2 years, that is between 2023 and 2025. We have scaled up immunization. We've introduced polio vaccines and hepatitis B in 2026. We still have challenges, including the funding of inputs and malnutrition, despite our efforts. Therefore, the Republic of Congo supports this regional strategy and wants to integrate it in its next national health development strategy and wants to intensify its fight against malnutrition so that all children have integral and optimal development. Thank you. Ladies and gentlemen, we're going to complete this agenda item before going to lunch. Malawi, you have the floor, followed by Nigeria.
Chair, Malawi endorses and adopts the regional strategy for advancing early childhood development outcomes for children in the WHO African region 2026 to 2032. Malawi's Child Health Strategy 2, 2021 to 2026, aligns in its interventions with the Nurturing Care for Early Childhood Development, a framework for helping children survive and thrive to transform health and human potential. This framework has transformed our understanding of what all children need to survive and thrive, our objectives under the Strategy for Women's, Children, and Adolescent Health. Between 2016 and 2025, maternal mortality ratio has reduced from 439 to 224 maternal deaths per 100,000 live births, a decrease in neonatal death from 27 to 24 neonatal deaths per 1,000 live births, reducing child mortality from 42 to 35 child deaths per 1,000 live births. However, the proportion of adolescent girls aged 15 to 19 who have ever been pregnant rose from 29 to 32%, highlighting the need for intensified efforts to achieve the national target of reducing teenage pregnancies to 15% by 2030. The child nutrition indices have stagnated, with exclusive infant breastfeeding decreasing from 61 to 60 and stunting at 38%. To improve child health outcomes and accelerate progress to attain SDG 3, Malawi adopted the WHO UNICEF guideline on improving the health and well-being of children and adolescents, guidance on scheduled child and adolescent welfare visits to improve outcomes. Malawi will further strengthen its interventions in advancing early childhood development to sustain the gains. Thank you, Chair.
La parole est au Nigeria.
I now give the floor to Nigeria, followed by Burundi.
Thank you, Mr. Chair. Nigeria welcomes the regional strategy on advancing early childhood outcomes for children in the WHO African region. In line with the strategy, Nigeria has integrated ECD interventions within the existing PHC system rather than creating a parallel service delivery structure. An integrated ECD package of interventions has been developed through multi-sectoral collaboration between the Federal Ministry of Health and Social Welfare, other line ministries, and partners. The package provides an evidence-based multi-sectoral framework covering preconception through early childhood and promotes coordinated implementation across health, nutrition, education, social protection, food systems, and child protection sectors. Foundational nurturing care interventions have been established and are being advanced through existing reproductive newborn, child and adolescent health, maternal newborn mortality reduction initiative, and PHC platforms, supporting long-term scale-up efforts. Despite progress, the country is faced with some challenges. These include developmental screening, responsive caregiving counseling, parenting support, referral pathways for developmental delays, and ECD indicators within routine health information systems are not yet fully institutionalized in PHC services. Multi-sectoral governance, planning, coordination, and financing mechanisms require strengthening, including the integration of costed ECD packages into national and subnational plans.
Merci, Madame.
Thank you, Madam. I now give the floor to Burundi.
Regional strategy will reaffirm our commitment to integrating ECD into PHC
Merci,
and
Madame, pour votre
implementing
Thank you, Madam, for your intervention.
partner in its implementations. Thank you. I thank you, Mr. Chair.
L'Algérie se prépare.
Burundi, then Algeria. Thank you, Chairperson. Burundi would like to thank you for including advancing ECD outcomes for children in the region in the agenda of this regional committee meeting. We have been looking at early childhood and the well-being of women and children. We have been strengthening PHC, immunization, breastfeeding, and care for mothers and newborns. The government of Burundi recognizes that early childhood cannot just be considered from a health perspective. We need to bring together health, nutrition, education, social protection, protection of the children, water, sanitation, and hygiene, as well as involve families, communities, and partners. It is in this regard that Burundi began on a process to improve its integrated childhood development program by coming up with a multi-sectoral strategy that spans 2021 to 2027, bringing together WHO, UNICEF, and the World Bank. We reaffirm the commitment of Burundi through the First Lady of Burundi to support nutrition of children and women. She organizes a high-level forum of women leaders on the early childhood development, as well as other initiatives, including spaces for thriving in communities and school canteens. Burundi would like to reaffirm today its commitment to continue and fast-track its efforts so that each child can benefit from conception from good conditions so that it can learn and thrive. And we hope that member states will share good practices and ensure that the plan is tailored to the realities of each country. Algeria, you have the floor.
Mr. President, Algeria attaches great importance to early childhood development, recognizing that the first years of life are critical period for child's health, well-being, and future development. In this context, Algeria implements a multi-sectoral approach that brings together health, nutrition, education, child protection, and social protection. In this regard, Algeria places particular emphasis on maternal and child health, vaccination, monitoring children's growth and development, as well as the prevention and treatment of malnutrition and childhood diseases. The efforts made by my country have led to achieve significant improvement in health indicators, including achieving the Sustainable Development Goals related to maternal and child health. Regarding health indicators, the official the infant mortality rate has seen a significant decrease, falling from 142 deaths per 1,000 live birth in 1970 in the immediate aftermath of independence to 19 deaths in 2024, representing a reduction of over 86% in a half century. In this regard, 99% of births now take place in medically supervised and assisted settings. Nutrition is another essential pillar of our efforts. Adequate nutrition during the early years of life is essential for children's physical and cognitive developments. Algeria, therefore, continues its effort to prevent malnutrition, promote breastfeeding, and raise awareness among families about good nutritional practices. The Algerian delegation emphasizes that improving early childhood health requires close cooperation among different sectors, as well as strengthened international cooperation and the sharing of best practices. Algeria affirms its commitment to continue its effort to promote the health and well-being.
I give the floor to Seychelles.
In order to ensure every child's right to grow up healthy in a safe and supportive environment conducive to their development. Thank you.
Algeria, please stop. We hand over to Seychelles.
Proposed strategy because it also falls aligned to our own era for healthcare and also part of our national development strategy. Seychelles established an Institute of Early Childhood Development in 2013, though it operates under the Ministry of Education. The mission is to strengthen early childhood care and education so that children receive accessible, high-quality and holistic support, including positive early learning experience and strong foundation for school and later life. The main responsibilities to coordinate the early childhood development policies and program, advise government on ECD-related policy and planning, develop standards and guidelines, conducting and or supporting research to inform policy, advocating for the importance of early childhood development, and regulating and registering childminding, child care services, approving premises used for child care services. In 2023, Seychelles IECD was inaugurated as a UNESCO Category 2 Center for Early Childhood Care and Education. This gives the Institute a wider regional and international role. It can contribute to UNESCO's ECC strategy and share Seychelles' experience in good practice in other countries, with other countries and institutions. Why it matters for health. Although IECD is institutionally linked to the Ministry of Health, it works, is inherently multi-sectoral. In fact, it is our pediatrician that chairs the board of this institute. Early childhood development depends on coordinated actions across health and nutrition, maternal and child health, early learning, school readiness, child protection, parenting and family support, disability and devotional screening, developmental screening, regulation of childcare environment. For public health planning, ICD, therefore, is a very important partner in integrating the first
La parole est à
1,000
l'Afrique
days
du Sud,
and throughout 0
Seychelles.
to 8 age.
South Africa, you have the floor, and then Chad will follow.
South Africa commends the regional office for this visionary roadmap aligned with the nurturing care framework. South Africa's national vision, anchored in our national integrated ECD policy and the Children's Act, recognizes that survival is not enough. Children must thrive. Through our comprehensive child health platform, we have institutionalized routine immunizations, growth monitoring, and the Road to Health book. Furthermore, our flagship side-by-side communication campaign has successfully reached millions of caregivers across multiple official languages, promoting nutrition, responsive caregiving, and early stimulation. Despite being in possession of many of the building blocks required to implement the strategy, South Africa still faces critical hurdles, including stunting, suboptimal exclusive breastfeeding rates, caregiver mental health, equitable service access, ECD measurement systems, and gaps in the systematic developmental screening. To turn the tide, South Africa is committed to a phased approach aligned with the regional strategy. In the near term, we are strengthening developmental screening within primary health care and scaling up our family-centered caregiver support platforms. In the medium term, we are integrating perinatal mental health into maternal and child health services and working to meet national nutrition targets. In the long term, we are committed to establishing a comprehensive national ECD measurement framework, institutionalizing multi-sector accountability mechanisms with dedicated budgets, and developing a national ECD learning and research platform to achieve universal access in underserved communities. Chair, as highlighted in the strategy, investing in the foundational first years of life is a moral imperative and an economic necessity for achieving the Africa we want. South Africa commits to translating these strategic objectives.
Thank you. The floor is now to Chad, followed by Cameroon.
Merci, Monsieur.
Thank you, Mr. Chair. Chad recognizes that the earliest years are the most significant when it comes to the development of our human capital. Therefore, an NCF is vital. We therefore support the regional strategy on ECD in the African region. Chad believes that this approach must feed into an approach that starts at pregnancy and continues thereafter. In this way, we can ensure that nurturing care is provided, and it also can ensure that a safe environment is created. Children in our region face severe challenges linked to malnutrition, and we also need to ensure that we better integrate ECD services. So this shows us the scale of the challenge, but it also tells us that we need to invest, and therefore, to this end, we need a multi-sectoral approach. This will involve health, social protection, education, communities, health services. They are at the heart of all this action. Therefore, we recall the Lome Call to Action 2010 on ECD, and we need to follow it in order to accelerate the implementation of ECD norms, which requires a multi-sectoral approach. Chad will continue to implement this and scale up its efforts when it comes to ECD. We will include ECD in our policies. We reaffirm our commitment to the development of each child, and we fully support the adoption of this regional strategy. We need to invest in every child. If we do so, we will be building Africa of tomorrow. Thank you. Cameroon has the floor.
Merci.
Thank you, Mr. Chair. As for Cameroon, we would like to thank the Secretariat for the quality of this report, and we also welcome the program that has accompanied it. Now, we support this initiative. What we have done is ensure that we analyze what threats are still to be faced, such as malnutrition and preventable deaths linked to vaccination. And we also need to focus on infant and maternal well-being. There's also the need to increase coverage of preschool education so that there is equitable access thereto. So Cameroon welcomes the progress made. For example, children under the age of 5 have been at the target of our policies. We are converging closer and closer to the WHO objectives. But obviously, challenges remain. This includes the lack of a clear national policy on nutrition and consolidated multi-sectoral approach. We are still building that approach. And when it comes to child stunting and breastfeeding and measles, these are further challenges which require a more robust response. We need therefore the support of the WHO and further partners. This also requires a multi-sectoral approach and indeed a global approach. Therefore, we call for further investments into nutrition and vaccination. With your commitment, we can all achieve the goal of improving children's futures thanks to health. Thank you, Cameroon. Thank you, dear colleagues, for your valuable contributions. I understand that several non-state actors have requested to deliver statements on this agenda item. They are now invited to do so. I'll give the floor to Unity to Combat and the Elizabeth Glaser Pediatric AIDS Foundation.
Excellencies, Uniting to Combat Neglected Tropical Diseases warmly welcomes this important strategy on early childhood development. We welcome its recognition that investing in children is one of the most important investments countries can make to improve health, strengthen human capital, and support sustainable development. To realize this ambition, every child must have the opportunity to grow, learn, and thrive free from preventable diseases that limit their development and future potential. The WHO NTD Roadmap demonstrates that eliminating NTDs improves children's health and well-being. Building on this, the recent United Nations Human Rights Council resolution on human rights and NTDs creates new opportunities to strengthen political leadership, multi-sectoral collaboration, and sustainable national ownership needed to accelerate implementation, helping to ensure that every child affected by NTDs has the opportunity to grow, learn, and thrive free from preventable disease and disability. The earliest years of life shape every opportunity that follows. Investing in children means investing in Africa's future.
Thank you very much. And I'll give the floor to the Elizabeth Glaser Pediatric AIDS Foundation, and the International Foundation will follow.
Thank you, Chair. The Elizabeth Glaser Pediatric AIDS Foundation strongly welcomes this strategy and its call to integrate early childhood development into systems that already reach children, mothers, and families. For children and families affected by HIV, developmental risks are often compounded. HIV can intersect with undernutrition, caregiver illness, stress, poverty, and each diminishing a caregiver's capacity to provide the responsive, nurturing care that development depends on. This means our response must address the child and caregiver together, strengthening responsive caregiving while identifying developmental risks early and linking families to appropriate support. Our experience shows this integration is feasible within existing platforms. The opportunity is to make developmental monitoring part of continuum of care. The same provider assessing a child's HIV treatment, viral suppression, should be able to assess whether that child is growing and developing appropriately, identify developmental risks, factors, and determine whether the caregiver requires additional support. We applaud the strategy's call for integrated child and family-centered.
Thank you.
Thank you.
Now, International Society of Physicians and Readaptation.
Thank you, Chair. The International Society of Physical and Rehabilitation Medicine, together with the World Rehabilitation Alliance, welcomes the regional strategy on advancing ACD in the region and support its adoption. As we work to ensure that every child not only survives but thrives, rehabilitation must be recognized as an integral part of early childhood development and nurturing care. The strategy rightly emphasizes early identification and intervention for children with developmental difficulties and functional limitation, whom it recognizes must not be left behind. Rehabilitation translates this commitment into meaningful outcome, helping children optimize their functioning, communicate, participate in play, learning, and engage with their family and communities. Building rehabilitation into existing early childhood development system rather than creating parallel programs maximize existing investment, strengthen continuity of care, and improve the return on investment in early childhood development. Thank you for your attention.
West African
Alcohol Policy, you have the floor, and the International Federation of Pharmacy Students prepares to go next.
Chairperson and distinguished delegates, the West African Alcohol Policy Alliance, WAPA, welcomes and supports the adoption of the regional strategy for advancing ECD outcomes in the WHO African region. WAPA recognizes the critical role of the health sector in promoting child health, nutrition, and development from conception. Advancing ECD must include preventing alcohol-related harm before birth. Prenatal alcohol exposure can result in fetal alcohol spectrum disorders and lifelong developmental challenges for children. WAPA therefore encourages member states to integrate alcohol prevention, routine screening, and brief interventions into antenatal and maternal health services, while strengthening the capacity of healthcare workers to support affected children and families. We also call for surveillance and research on prenatal alcohol exposure within existing health monitoring systems. As this region works to ensure every child can survive, thrive, and reach their full potential, preventing avoidable alcohol-related harm must be a core part of this effort. Thank you, sir.
Now, the International Pharmaceutical Students Federation.
Honorable Chair, distinguished delegates, the International Pharmaceutical Students Federation, representing over 600,000 pharmacy students and recent graduates, promotes early childhood development through community education and advocacy. IPSF welcomes the regional strategy for early childhood development in WHO African region 2026 to 2032. Early childhood development from pregnancy to 8 years of age shapes health, learning, productivity, and well-being. Nevertheless, children in the African region face poverty, malnutrition, violence, limited access to healthcare, and insufficient early learning opportunities. We call upon WHO and member states to integrate early childhood development into health, education, and social protection policies, strengthen developmental monitoring in healthcare, support caregivers through accessible nutrition and mental health services, train pharmacists and pharmacy students on child health and developmental risks. Thank you.
La parole.
When International welcomes the strategy's recognition that children's development depends on nurturing, enabling environments, and caregivers' mental health. Yet alcohol harm remains unaddressed. Alcohol spending crowds out household investment in health, nutrition, and education while fueling violence and disease, risking child health and development. Both scientific evidence and lived experience show that alcohol harm is a major obstacle to early childhood development. To protect children, we call for both population-level policy solutions and health systems responses. We urge that the planned integration of perinatal mental health into maternal, newborn, and child health services also address alcohol use during pregnancy and caregiving, and the essential health service packages include alcohol screening and brief intervention. Movendi International stands ready to support this work. Thank you.
Alliance Lentien, vous avez la parole.
MTN Alliance.
Thank you, Chair. The NCD Alliance and the Global Coalition for Pediatric and Congenital Hearts appreciate the opportunity to speak on advancing early childhood development outcomes. Across the region, childhood onset heart disease, including congenital heart disease and rheumatic heart disease, takes young lives that could be saved and impacts childhood development. As the region makes progress against infectious causes of child death, congenital heart disease, the most common birth defect affecting 1 in 100 live births, is emerging as a high contributor to childhood mortality. And yet it remains invisible on global and national agendas and inadequately reflected in the NCD response, UHC planning, and child survival strategies. We commend the region's leadership through the PEN Plus strategy, which has begun bringing care for rheumatic and congenital heart disease closer to children at district hospitals. To build on this progress, our coalition is supporting a resolution on childhood onset heart disease at the 80th World Health Assembly in 2027. We are grateful to the government of Namibia for its leadership and Tanzania for its support, and call on other member states to champion and co-sponsor this resolution. Thank you.
Merci beaucoup.
Thank you. International Federation of Pharmacy Students Associations.
Honorable Chair, distinguished delegates, a child's ability to thrive is shaped long before they enter a classroom. Yet the WHO data shows that only 60% of children aged 36 to 59 months in the African region are developmentally on track across key developmental domains. We, as the International Federation of Medical Students Association, welcome this regional strategy and ask member states to secure sustainable domestic financing for nurturing care while integrating quality early childhood development interventions across primary healthcare, nutrition, and other essential services. We further call for measurable national targets and stronger information systems to identify children being left behind. Health professionals should also be equipped to recognize developmental risks early and support families through responsive rights-based care. Universal health coverage must give every child not only the chance to survive, but also to thrive. Thank you.
Merci.
Thank you. I do not see any other requests to take the floor. Does the Secretariat have any comments?
Thank you, Chair. Thank you, Chair, and would like to acknowledge the interventions of 30 member states and 8 non-state actors, our partners, in the interest that's been demonstrated in this an important part of the investment in our health and economic development. We have taken note of some of the areas that need extra guidance, like on screen time use. Some of that is already integrated in the recommended actions. And we've also taken note of the fact that it is recognized across the board that this cannot be a one sector responsibility. And in fact, all the initiatives that are already being implemented at country level are multi-sectoral if they're going to be successful. So the countries already know what to do, and those that have made progress in significant ways have also expressed their willingness to share that learning. And we are in an open world, and I believe that through our different initiatives with partners across the continent, we're going to be able to accompany the countries adequately. So we take note of those requests for accompanied support, and we also acknowledge that it's going to be our joint and committed going forward partnership with the countries that we are here to serve. Thank you.
Merci.
Thank you. Shall I take it that the Secretariat has taken note of the comments and that the Regional Committee is ready to adopt the resolution contained in document AFR RC76 WP2, which includes adoption of the strategy on advancing early childhood development outcomes for children in the WHO African region, as contained in document AFR RC76 5. I see no objection. It is so decided.
Merci.
Thank you all for your important contributions. And this brings us to the end of the discussion of Agenda Item 9. Honourable Ministers, distinguished delegates, ladies and gentlemen, before we go to lunch, I have the honour of inviting Dr. Diallo, Director of the Programme, to take the floor for a special announcement. Dr. Diallo, you have the floor.
Merci, Monsieur le Président.
Thank you, Mr. Chair.
Heads of delegations and partners. Under the leadership of Dr. Mohamed Janabi, the WHO Africa region would like to kindly invite all member states and partners present to join him in recognizing the WHO Director General, Dr. Tedros Adhanom Ghebreyesus, the first African to ever lead the organization, for his exceptional leadership and service. Dr. Tedros has led the WHO through outbreaks, pandemics, and financial crises. He has initiated and implemented significant, impactful reforms. His tenure will end in August 2027, following the appointment of the next Director General at the 88th World Health Assembly, due to take place in May 2027. The staff and management of WHO Afro are pleased to present the following symbols of appreciation. A traditional portrait of the Director General commemorating the beginning of his journey at the helm of the organization. A storybook that all member states are kindly invited to sign before the end of this RC76. It is now my pleasure to invite Dr. Janabi to unveil the portrait and present it to the Director General's Chief of Staff, Dr. Razia Pense, on behalf of the region. Dr. Janabi, over to you. Thank you, Dr. Janabi. So as soon as the book is ready, we will circulate it and once again kindly invite all member states to sign it. Thank you very much.
Nous rappelons
Please be reminded that the polio closed door session for Southern African countries, which is by invitation only, will start at 12:45. But I see that it's already 12:45. But this will take place in conference room 5. You are invited to join that meeting if you have been invited. We will start again at 2 o'clock.
Les cliniques mobiles permettent d'observer les populations éloignées des centres de santé, améliorer ainsi la couverture sanitaire. Elle offre des services de santé reproductifs tels que le soin maternel, la consultation nourrisson, le dépistage de la malnutrition, la vaccination et la consultation curative. Cela permet d'identifier les risques à temps et de fournir une prise en charge adéquate.
inji da doktor kwarara ta aran bakwai zama zanka kan man duken sa kubante amman dulak amman zanka kan duken sa kubante ba dori bunaka ngo aga kamba
Ika kani sino dori kusi ko kiaga dori kusaiga lokotara imbono dirka ki se ika ne o.
L'OMS fait partie de partenaires qui est toujours disponible pour pouvoir nous accompagner et nous appuyer dans le cadre de la mobilisation communautaire pour offrir à la population des soins et services de santé de qualité.
Toutes les populations qui sont dans les endroits assez difficiles, le projet clinique mobile a beaucoup contribué pour vraiment atteindre ces populations, pour approcher les soins à ces populations qui ont vraiment pu bénéficier des soins de qualité. Et tous les jours, on a les retours positifs.
Lokotara ibumbono dirka ki gari kwarara aine siyasin tinano a hiyon banda ine dori saga dori saiga ai maka ne bina go farha.
Bounia, dans l'enceinte des centres médicaux évangélistiques de Bounia. À notre arrivée, les collègues de l'hôpital étaient en train de gérer plusieurs patients suspects confirmés avec les moyens à disposition dans un bâtiment à l'intérieur de l'hôpital. On est arrivé à ouvrir les nouveaux centres de traitement de CME de Bounia. Les personnels de santé arrivent chaque matin ou chaque soir avec leur habit privé, personnel. Avant de rentrer, ils doivent passer à côté de la buanderie où nos collègues ils assurent que chaque jour, on a à disposition des tenues et des bottes propres et désinfectées pour faire notre travail. À l'intérieur aussi, on a une pharmacie où les pharmaciens et les infirmières ils préparent les médicaments prescrits par les médecins et à donner à notre patient. On a la salle d'habillage, là où les personnels sanitaires, avant de rentrer dans la zone des patients ou la zone à haut risque, ils doivent s'habiller en utilisant l'équipement de protection individuelle. Et ensuite, comme on peut voir, on a la porte d'accès transparent vers les chambres du malade. Une fois terminées nos activités au sein de la zone à haut risque, la zone des patients, on doit sortir par les déshabillages. Là, on a tous les matériels, les dispositifs techniques à disposition pour se déshabiller en toute sécurité. On a des solutions chlorées, de l'eau savonneuse, les seaux avec les déchets et tout ça. Et à part d'avoir un poster avec toutes les instructions détaillées pour la rémoction, on a aussi des collègues qui nous rappellent step by step ou étape par étape comment on se déshabille en sécurité. On espère de pouvoir contribuer à la réponse en offrant un endroit où les patients ils pourront recevoir des soins sécurisés, humanisés et de qualité pour eux et aussi sécurisés pour les prestataires de santé et pour les communautés autour.
Shida ni mingi sana kwa hapa, hatuna hospitali, skuli hakuna DMS ya maana, hatupati chakula.
Wan walbo aan jabte, wan walbana aan rabtay meesha soo jirta anaa ndur ana kama sheeda qamna dadadan teen dheeftuwa baka wali marsun baasito.
Most of the mothers, they only come when they are critical ill.
There's a need for collaboration between WHO and Tana River County or the Department of Health to ensure that they get access to these services, which are very critical, both for the mothers and also for the children.
So those mentorships have done a lot for us because they've been in the facility.
Sasa ikija hapa inatusaidia, at least tunapata dawa za watoto na za zetu za ugonjwa, at least mafua.
Kwanza mimi ninawapongeza na nawapatia asante WHO, nasema na washukuru shirika wote.
amena kwali asimingi titre muduna ko dombe chingangu akadi kama perdre tambi mo so asanje na pe eretma so mogwe na hospital ani sara kwatmo ala kushe pendre na dungo chi kwala akiri penda la ga muna wangu keta la ga techi ala sana ishona pe
balopika yanga dans l'endroit atene ya tinya son directement mi mulo na ita 1 heure mi gana na hôpital atem so si ya zona muna yi ti tene i bembendo na ngota mama tingo so wala ya tu wana ngbakete wala ya tu wani akono ti tene i bembendo il faut zoni même terlo son il faut le gana hôpital rapidement.
Avec le soutien des bailleurs engagés, nous avons déjà pu former et déployer 8000 agents de santé communautaire et 1200 matrones communautaires. Nous avons construit et réhabilité une centaine de maternités et renforcé les plateaux techniques en soins obstétricaux d'urgence. Nous avons aussi créé 4 nouvelles écoles régionales de formation de personnel paramédical, y compris des sages-femmes et des assistantes accoucheuses.
Mafiti sensibiliser ala so mbeni tingangwa idankor ngape ama machango na mama cha bébé parce ala ke gagi na hôpital.
Betnde so ala undangana mara zon to so tena jingana ya chika cheni a iso ikingana vechi hospital nga peso ala la gana tere chi si amunga na i conseil chi tene iganga na hospital chi tene sauver vie chi so.
De nombreux accouchements se déroulent désormais dans de meilleures conditions et les soins deviennent progressivement plus accessibles. Bien que le chemin reste encore long, les actions sont en cours pour une bonne santé à la naissance, pour un avenir plein d'espoir en République centrafricaine.
Dans le cadre de la réponse Ebola, nous avons organisé l'acheminement de 80 mètres cubes d'équipements, de matériel et de consommables médicaux de Kananga jusqu'à Boulapé. Nous avons sollicité l'appui de notre partenaire, le Programme alimentaire mondial, pour la mise à disposition de 4 camions. L'opération s'est déroulée dans un contexte géographique très complexe. Il n'existe pas de route praticable entre Kananga et Boulapé, ce qui rend l'accès particulièrement difficile, et notamment pour des volumes aussi importants.
La route n'est pas bonne. On est en train de se débrouiller pour passer. Il y a des arbres qui se coupent, le crevaison des punais. Un humanitaire, il faut avoir du courage, l'amour envers les autres. Nous prenons ces risques-là pour sauver la population.
Ces intrants qui ont pu être livrés vont permettre d'assurer la continuité de nos activités dans le cadre de cette réponse, que ce soit les activités de prise en charge, de PCI et de surveillance. C'est un bel exemple de collaboration entre les agences des Nations Unies, notamment le PAM, qui nous ont permis ensemble d'assurer le maintien des opérations dans le cadre de cette réponse.
Primera haseta botinida masheta
لبتنا أنا كنت فيصل من فيصل خلق قالوا قال الصغير ده ما يقدر يمرق بيتيت الصغير ده قاعد فوق بس ما يقدر يمرق بيتيت كمان خلينا نجي شنوها هنا جيت شنوها هنا كمان خلاص قالوا لي قال خلينا نمشي نسوي عملية خلاص سووا عملية ومرقوا صغير الحمد لله ما منتونا جراتشي سوينا جراتشي ساعدونا الحمد لله لكن كان أول نقولة من دي نقدر
L'Organisation mondiale de la santé, avec l'appui de ses partenaires, a répondu à ces besoins prioritaires qui ont été exprimés, principalement l'aménagement de plateaux techniques, la disponibilité en médicaments essentiels, contribuant ainsi à l'amélioration graduelle de l'offre de services de soins et la prise en charge des urgences néonatales et obstétricales.
Les décès ou bien les retards même dans les prises en charge, quelquefois est lié par l'absence de certains produits qu'il faut aller courir de gauche à droite pour en trouver afin de sauver la femme. Donc certainement, ces produits ont contribué à la réduction de la mortalité, si j'ose le dire comme ça, de la mortalité maternelle dans nos informations sanitaires.
En janvier 2026, dans les 175 accouchements, on a 0 décès maternel. Sur ces faits, nous, on a reçu de matériel de l'OMS et ça entre vraiment dans la prise en charge de nos femmes.
L'OMS nous a aidés. Comme nous, on a des médicaments, les femmes ne payent pas.
L'OMS nous a offert les boîtes de césariennes. Bien avant, on a des boîtes de césariennes. Avec l'ajout de l'OMS, ça nous a aidé d'avoir plus de boîtes. Et ça veut dire la patiente sera opérée et plus sécurisée. La prise en charge, il faut que ça soit rapide et adéquate pour sauver la mère et l'enfant.
Les cliniques mobiles permettent d'observer les populations éloignées des centres de santé, améliorer ainsi la couverture sanitaire. Elles offrent des services de santé reproductive tels que le soin maternel, la consultation nourrisson, le dépistage de la malnutrition, la vaccination et la consultation curative. Cela permet d'identifier les risques à temps et de fournir une prise en charge adéquate.
in ji da doktor kwarara da aran makwai zama zanka kan man dukiyar ta kubante a man dulakkal amman zanka kan dukiyar ta kubante ba dori bunaka an ga wa ga kan ba
Ika kanisino dori kusiye ko kiaga dori kusaiga lokotara imbono dirka kise ika newo.
L'OMS fait partie de partenaires qui est toujours disponible pour pouvoir nous accompagner et nous appuyer dans le cadre de la mobilisation communautaire pour offrir à la population les soins et services de santé de qualité.
Toutes les populations qui sont dans les endroits assez difficiles, le projet clinique mobile a beaucoup contribué pour vraiment atteindre ces populations, pour approcher les soins à ces populations qui ont vraiment pu bénéficier des soins de qualité. Et tous les jours, on a les retours positifs.
Lokotara ibumbono dirka ki gari kwarara aine siya sintinano a heyong banda ine dori saga dori saiga ai maka ne bi na go faraha.
J'avais discuté avec les jeunes et les mamans par rapport à l'âge des filles et des jeunes garçons dans la période de puberté. Dans ces moments, la jeune fille peut avoir certains signes comme les premières règles. En plus, on a parlé de PF, les méthodes contraceptives.
Kɔnjitɔ woto ne míanɔ kuro míawo be ne mí ɖi xixea, eleke nyɔnuwo fiɔna mí be míado ɖovuvu aɖewo me. Eya ŋuti wova to ne mí le egbea, masɔ kpe ɖe ɖekee ŋuti ye ava kpe ɖe ŋuti ye le sɔ me.
L'implication des agents de santé communautaires qualifiés, des relais communautaires, est un levier essentiel pour améliorer l'accès des services de santé sexuelle reproductive. L'adolescence et la jeunesse constituent une période clé pour acquérir des informations fiables pour éviter que les jeunes n'adoptent des comportements à risque.
Les soins de santé sexuelle et reproductive, par exemple la planification familiale. Les femmes n'y accédaient pas par peur, mais avec les sensibilisations, elles viennent. Donc quand elles viennent, il suffit juste qu'on puisse les mettre en confiance, qu'on leur parle bien et puis elles arrivent à se confier et on peut trouver une solution à leur mot.
Demi sai fango e do hosi planning gu nyoleton bunu mi e de collier jeton bo jo e no ha bono tun asale ji an mo ayi sunu gan pa ma mo ho a bono gbe lo mo mi zan collier bo pon we.
Over the years, my 13 years working experience in Zantrin Research Center has seen TB testing revolutionized, which has helped the country as a whole improve case detection and also reduce the turnaround time from when patients produce samples to when they receive their result.
Before it was 72 hours, but now it's 24 hours. Like TB lamp is just within 3 hours, they get their result and we commence them on their drugs.
Once you are on drugs, you complete your drugs and the exact dose that the doctor asks you to take. By the grace of God, everything will be okay.
That is still a lot of work to do. And when you are even doing so well, sustaining those efforts requires a lot of energy, a lot of engaging everyone that needs to be engaged, so that we are all working towards the same direction.
WHO commends the efforts of Nigeria to expand TB testing and close the gap on undetected cases. We will continue to support the country every step of the way.
As a facility, we have a design system which aids also in the training and the training of staffs on the various work fronts to ensure that quality and efficiency is maintained.
I was physically, mentally, spiritually down, thinking maybe that is the end of the world. But as for now, I thank God I'm free now, and my life has changed.
I feel motivated actually, working on this client. And then number two, I have to feel bad not having the full set of the service here.
We are investing quite a lot in terms of trying to support the country build its health system so that people can actually access and use these services. We're also investing directly in uptake of a lot of these services.
أنا مرتاحين شديد ب WHO. هو بيشيلنا في training أو كمان بيعمل support supervision ودوايات ممكن يجيبوا لنا سالا كون دلتا سبايكو كانسر أجن سنو دي كل من يجيبوا سراين. دايما أنا بوري لأمهات دي من productive age لكاد في 40 أنا بينا دومن كده موجة زنكرين مسكرين من
أنا قاشر حور لي أنا ده الشهب تاعي أنا جشتكل لسن أجل تومن أنا بكون فرحان لما النسوان الحامل ده كان أنا جرا سلومون جيجا في كيشف جيشيلو علاجات أنا جيكون مرتاح.
Quand je vois une femme en travail, bien une femme enceinte, je l'oriente pour les CPNT, le travail a commencé. Il faut aller à l'hôpital parce que maintenant, les accouchements de la maison avec les complications, là, c'est pas bien.
Dans le cadre de ce programme, ces accoucheuses traditionnelles ont été formées sur la détection des signes de danger et également sur l'orientation précoce de ces femmes. Et donc, cela permet en fait d'agir sur les retards notamment le premier retard qui est celui de la décision pour pouvoir se rendre au centre de santé, et également sur le troisième retard, la précocité de la prise en charge.
La plupart des accouchements en communauté se passent à domicile. Le MES, avec le ministère, essaie de travailler avec ces accoucheuses traditionnelles. Grâce à cette collaboration, les femmes accouchent maintenant dans les formations sanitaires par un professionnel qualifié, d'où la qualité des soins que nous recherchons.
Par jour, on fait au moins 30 à 35 femmes qui viennent à la CFN, les accoucheuses traditionnelles. Ça nous aide beaucoup parce qu'avant, il y avait beaucoup de perdus de vue pour les femmes enceintes. Donc, ces AT suivent les femmes dans les quartiers et on les oriente pour ne pas que la femme reste à la maison et elle accouche à domicile.
L'accouchement à la maison, c'est un risque. Du fait que tu vas accoucher à la maison, tu ne sais pas ce qui va t'arriver. Toi, la femme, quand tu sais le temps de venir à l'hôpital, déjà, là, c'est déjà trop tard. Donc, c'est mieux d'accoucher à l'hôpital et être en sécurité.
Une fois accouché dans les très bonnes conditions, le bébé se porte bien, la maman se porte bien. C'est un plaisir pour moi.
Faire les pratiques sur les mannequins avant de pratiquer sur les humains. Et ça nous a beaucoup aidé. L'apport des mannequins nous a donné beaucoup de confiance en nous. Ça nous a aidé à être très sûrs et quand on fait nos pratiques sur les êtres humains.
Nous avons aujourd'hui des mannequins qui sont même couplés à des ordinateurs pour nous faire simuler des anesthésies générales sur les patients, des arrêts cardiaques sur les lits des patients. J'ai plus de 25 ans dans l'anesthésie, mais depuis là, j'ai senti un changement. Et mes étudiants aussi sont toujours très contents parce qu'après chaque fois, on fait un débriefing.
Depuis la reprise de cette formation sur mannequin, les compétences de région vraiment ont été améliorées. Ils savent mieux prendre en charge la patiente. C'est ce qu'on appelle les soins humanisés. Et c'est vraiment indispensable pour réduire le pronostic maternel et périnatal en nombre de décès.
La formation SONU nous a permis de renforcer nos compétences et enfin d'améliorer la prise en charge de la mère et du nouveau-né. Avec les mannequins, ça nous permet d'éviter certaines erreurs qu'on pouvait faire sur les mères.
La création de la salle de simulation SONU a été motivée par le besoin d'amélioration de la qualité de la formation des apprenants, de sécuriser les patientes qui viennent en consultation pour qu'il y ait moins d'incidents.
We need to be concerned about severe acute malnutrition simply because of the burden that it contributes to. Currently, globally, we know that close to 42 million children are affected by child wasting.
Ethiopia is striving to reduce the burden of malnutrition in the past decades, even though some regions remain still high in burden of wasting.
The importance of the training is to create national capacity on the WHO global training package for the management of acute malnutrition. And Ethiopia has been advanced in the revisions, and now we are working on the 19 training materials. This training helps us to align the Ethiopian revisions with the global tool of WHO in the prevention and in the management of severe acute malnutrition with medical problems.
In 2023, WHO released new guidelines on the prevention and management of wasting, and for the first time, those guidelines include infants less than 6 months old as a priority focus group. And so that has meant including new, more detailed guidance for the management of wasting in those infants, because those infants need as a priority to establish or re-establish exclusive breastfeeding as the cornerstone of their best treatment.
እነዚህን አዳዲስ ጥናቶችና ግኝቶች ለሀገር ውስጥም ወይም ደግሞ እዚህ ኢትዮጵያ ውስጥ ለምሰራቸው ስራዎች እንደ ኢንፑት ይሆናሉ። ትሬኒንጉ የሚሰጠው የግሎባል ስታንዳርድ ነው የደብሊውኤችኦ ስታንዳርድን የጠበቀ ስለሆነ በጣም ጥሩ ልምድና እውቀትና ስኪል ወይም ክህሎት እንድናዳብር አድርጎናል ብዬ አስባለሁ። ያለውን የኑትሪሽን ሰፕላይ እጥረት አድረስ በሚያደርግ መልኩ በአግባቡ ደግሞ ህፃናት የምግብ እጥረት ያላቸው ህፃናት በአግባቡ የሚታከሙበት ሁኔታ አላይን ያደረገ ሁለቱን ዓላማ አድረስ ያደረገ ስለሆነ እሱ አዲስ አፕዴት ነው ብዬ አስባለሁ።
So our institution hosting this training, we are benefiting a lot. One thing, our professionals are getting a hands-on training. There is update on the guideline, so these updates will help our health professionals.
I want to really appreciate the government of Ethiopia for showing us the leadership that is required when it comes to addressing issues to do with malnutrition. Secondly, we are not doing this alone as WHO. We are working together with various UN agencies. We have UNICEF, WFP, UNHCR as part of the Global Action Plan on Wasting Partners, and also the implementing partners who are on the ground to ensure that the services are delivered for the children. In a special way, we have received support from Irish Aid to first of all develop the guidelines themselves, develop the training manuals, and then move ahead to cascade the trainings at the country level.
Over the past 3 years, Ethiopia has made important progress in improving the prevention and management of child wasting in line with the 2023 WHO Global Recommendation. These efforts are helping in strengthening Ethiopia's nutrition system and improve outcomes of vulnerable children and communities.
Shida ni mingi sana kwa hapa, au tuende hospitali, chakula hakuna dems ya maana, hatupati chakula.
wan walbo aan jabte wan walbona aan rafay markasa waa jirta anaad ndur ana kama sheeda qamna dadadanteen dheertuwa baka wali marsun baasito.
Most of the mothers, they only come when they are critical ill.
There's a need for collaboration between WHO and Tana River County or the Department of Health to ensure that they get access to these services, which are very critical, both for the mothers and also for the children.
So those mentorships have done a lot for us because they've been in the facility.
Sasa ikija hapa inatusaidia, at least tunapata dawa za watoto na za zetu za ugonjwa, at least mafua.
Kwanza mimi ninawapongeza na nawapatia asante WHO, nasema na washukuru shirika wote.
C'est une activité de renforcement de capacités par rapport avec la surveillance épidémiologique de la maladie à virus Ebola. Partant des alertes jusqu'aux investigations, comment faire le listage des contacts, comment s'assurer que tous les contacts listés autour d'un cas confirmé sont suivis pendant 21 jours. Mais nous avons eu aussi le temps de discuter de comment faire la recherche active dans les établissements de soins de santé et dans la communauté. C'est une activité critique pour nous.
Cette formation nous apprend comment nous devons surveiller la maladie épidémiologique Ebola dans le milieu où nous sommes. C'est important pour moi. D'abord, c'est pour me protéger moi-même et protéger aussi la communauté que je suis en train de vivre.
My name is pharmacist Sherifat Omini. I'm a mother of 2. My second child is 7 months. Right now, I want to prepare him to receive a malaria vaccination at the health facility. I am glad that he falls within the age brackets, which happens to be 5 to 11 months. And I would like to advise all mothers which their children falls within this age bracket of 5 to 11 months to also bring their children to the health facility to benefit from this malaria vaccine. So any child that happens to fall with this is a great privilege and opportunity for them to minimize the spread of the malaria. I want to appreciate the governments and partners like WHO, UNICEF, Gavi, for giving us this opportunity for Kebbi to be one of the states that is found to rule out the malaria vaccine.
My name is Nathan John. I'm 43 years old. I'm a regular donor. It has been so wonderful. I feel fulfilled because it's something that I can do it single-handedly. Single-handedly in the sense that nobody pushed me to do it. I do it willingly. Blood is something that science cannot create it. Money cannot buy it. So in that aspect, I see that if I have it to give, especially to those who are in dire need, it has been fulfilled life for me to see that everything I'm doing is by, it's on the policy of National Blood Service Agency, accepted by WHO and accepted by Nigerian government. To commemorate the World Blood Donor Day, I will be donating to save life and keep humanity alive.
Avec cet avènement de la maladie à virus Ebola, tout le monde craignait l'hôpital. C'était difficile pour le fonctionnement de l'hôpital. Un soulagement, pas seulement pour nous les prestataires, mais aussi pour la communauté. La décontamination et bio-nettoyage a été faite dans le nord. Et toutes les salles de l'hôpital doivent être utilisés sans perte ni crainte. Il y a eu reprise d'activité. La fréquentation continue à augmenter chaque jour.
This context in particular, it's important to do IPC because what IPC does is it tries to mitigate, to control transmission by the measures and standards that it basically implements. And those measures and standards are called the standard precautions and transmission-based precautions. And they focus around things that are very practical, like hand hygiene, the PPE that people wear, the environment that they're in, the ensuring that triage is in place, that there's isolation capacity, and that patients are placed in a place where they do not affect or can infect other patients.
The fragile right way in physics in Bopodo when Gabriel facing problem with this time where I can.
Before we had this maternity home, we had a lot of problem with our pregnant women reaching to the facility. Some of them, they would come from far distances.
It's all about partnership. It's all about working together towards the SDG goal of achieving reduction in maternal mortality.
We've invested in training. We have ensured that the midwives and nurses at the health facilities have the skills necessary to provide care. We have skilled birth attendants in almost all of our health facilities.
And yeah, and I know that I will give birth safely because I'll be giving birth in Kuwait.
Avoir un laboratoire au cœur de l'épidémie permet à ce qu'il y ait une prise en charge plus rapide, dans le sens où plus tôt on reçoit l'échantillon, plus tôt on l'analyse et on sait prendre en charge les cas.
Lorsqu'on prélevait les échantillons ici à Boulapé pour les acheminer jusqu'à Kinshasa, vu l'état des routes et les difficultés que nous avons, ça faisait autour de 2 à 3 jours pour arriver à Kinshasa. Alors actuellement, avec l'installation du laboratoire sur place, les rendus des résultats qui sont rapides, en 2 heures, on a déjà les résultats et la prise en charge nous est facile.
Lorsqu'on nous amène les échantillons, nous devons d'abord déballer, nous allons amener ça pour identifier. Après, nous allons inactiver. On ne peut pas lancer échantillon sans l'inactivation. Nous allons mettre ça dans les cartouches d'une experte pour lancer ça directement. Ça peut nous prendre au moins des heures du temps.
L'apport de l'OMS dans cette riposte a consisté à faciliter le transport des machines, des gene experts et tous les outils dont nous avons besoin pour le diagnostic et le suivi de malades, mais aussi la formation de personnel de laboratoire sur la biosécurité, la biosanté au laboratoire a permis à ce que nous ayons rapidement la main-d'œuvre sur place. Et cette main-d'œuvre sera utilisée à Boulapé, à Moïka, mais également à Chitapa.
L'hôpital n'avait pas la capacité de réaliser de PCR. Nous avons eu à installer une machine CP Gene Expert qui nous permet de faire le diagnostic Ebola Zaïre en moins 1h30. On a les résultats. Et aussi, on a eu à installer des machines de biochimie Piccolo qui nous permet aussi d'avoir des résultats biochimiques pour suivre aussi l'état des patients.
La proximité de laboratoire avec les centres de traitement permet la promptitude dans l'obtention des résultats et donc ça améliore rapidement la prise de décision. Nous n'avons pas fait traîner les malades comme cas suspect dans les centres de traitement parce que s'il est suspect, il peut sortir non cas et s'il traîne, il peut s'exposer.
This specific report provides you with information on health in the region. It not only focuses on where we stand as far as health is concerned, but also provides information on the progress made, some of the issues we are dealing with, and then the next steps regarding the future of health in this region.
One of the elements that is really important for mothers and women that this report put on record is the expansion of maternal and perinatal death surveillance and review. It brings in accountability that health workers can look at every death and review and really find out what is the cause of this death and was this death preventable and what can be done to ensure that another preventable death does not happen like this.
While the national averages are a good way to show progress, they also conceal differences between communities and between districts.
The report also highlights not so much the contraction and collapse of services, but the transformation that had to happen and is still happening in the way we deliver services, because that transformation then allows us to adapt to the contracted resources. And I think for me, that's the real story of the report.
Press here. But on c'est Liberian.
Des États membres, parce que les besoins de la santé par la population n'a pas fait une pause parce qu'il y avait une crise.
La santé de nos populations, c'est nous qui devons la financer.
Les cliniques mobiles permettent d'observer les populations éloignées des centres de santé, améliorer ainsi la couverture sanitaire. Elles offrent des services de santé reproductive tels que le soin maternel, la consultation nourrisson, le dépistage de la malnutrition, la vaccination et la consultation curative. Cela permet d'identifier les risques à temps et de fournir une prise en charge adéquate.
inji da doktor kwarara da aran bakwai zama zanka kan man dukiyar ta kubante amman dulak amman zanka kan dukiyar ta kubante ba dori bunaka ngo aga kamba
Ika kanisino dori kusiye ko kiaga dori kusaiga lokotara imbono dirka ki se Ikaneo.
L'OMS fait partie de partenaires qui est toujours disponible pour pouvoir nous accompagner et nous appuyer dans le cadre de la mobilisation communautaire pour offrir à la population des soins et services de santé de qualité.
Toutes les populations qui sont dans les endroits assez difficiles, le projet clinique mobile a beaucoup contribué pour vraiment atteindre ces populations, pour approcher les soins à ces populations qui ont vraiment pu bénéficier des soins de qualité. Et tous les jours, on a les retours positifs.
Bounia, dans l'enceinte des centres médicaux évangélistiques de Bounia. À notre arrivée, l'hôpital, les collègues de l'hôpital étaient en train de gérer plusieurs patients suspects confirmés avec les moyens à disposition dans un bâtiment à l'intérieur de l'hôpital. On est arrivé à ouvrir les nouveaux centres de traitement de CME de Bounia. Les personnels de santé arrivent chaque matin ou chaque soir avec leur habit privé, personnel. Avant de rentrer, il doit passer à côté de la vianderie où nos collègues ils assurent que chaque jour, on a à disposition des tenues et des bottes propres et désinfectées pour faire notre travail. À l'intérieur aussi, on a une pharmacie où les pharmaciens et les infirmières ils préparent les médicaments prescrits par les médecins et à donner à notre patient. On a la salle d'habillage, là où les personnels sanitaires, avant de rentrer dans la zone des patients ou la zone à haut risque, ils doivent s'habiller en utilisant l'équipement de protection individuelle. Et ensuite, comme on peut voir, on a la porte d'accès transparent vers les chambres du malade. Une fois terminées nos activités au sein de la zone à haut risque, la zone des patients, on doit sortir par les déshabillages. Là, on a tous les matériels, les dispositifs techniques à disposition pour se déshabiller en toute sécurité. On a des solutions chlorées, de l'eau savonneuse, les seaux avec les déchets et tout ça. Et à part d'avoir un poster avec toutes les instructions détaillées pour la rémoction, on a aussi des collègues qui nous rappellent step by step ou étape par étape comment on se déshabille en sécurité. On espère de pouvoir contribuer à la réponse en offrant un endroit où les patients ils pourront recevoir des soins sécurisés, humanisés et de qualité pour eux et aussi sécurisés pour les prestataires de santé et pour les communautés autour.
Shida ni nyingi sana kwa hapa, hatuna hospitali, chakula hakuna demu jamani, hatupati chakula.
on walbo aan jabte on walbana aan rafay meesha waa jirta anaad ndur ana kama sheeda qamna dadadan teen eertuwa baka wali marsun baasitu
Most of the mothers, they only come when they are critical ill.
There's a need for collaboration between WHO and Tana River County or the Department of Health to ensure that they get access to these services, which are very critical, both for the mothers and also for the children.
those mentorships have done a lot for us because they've been in the facility.
Sasa ikija hapa inatusaidia, at least tunapata dawa za watoto na za zetu za ugonjwa, at least mafua.
Kwanza mimi ninawapongeza na nawapatia asante WHO, nasema na washukuru shirika wote.
Amena kwali asimingi titre muduna ko dombe chingangu akadi kama perdre tamingi mo so asanje na pe eretma so mogwe na hospital ani sara kwatmo ala kushe pendre na dungo shi kwala akiri penda la ga muna wango keta la ga techi ala sana ishona pe
balopika yanga dans l'endotini atene ya tinyason directement mi mulo na ita 1 heure mi gana l'hôpital atem so si azona muna yi titene ibembendo na ndota mama tingo so wala yatu wana ngbakete wala yatu wani akono titene ibembendo il faut zoni même relation il faut le gana hôpital rapidement.
Avec le soutien des bailleurs engagés, nous avons déjà pu former et déployer 8000 agents de santé communautaire et 1200 matrones communautaires. Nous avons construit et réhabilité une centaine de maternités et renforcé les plateaux techniques en soins obstétricaux d'urgence. Nous avons aussi créé 4 nouvelles écoles régionales de formation de personnel paramédical, y compris des sages-femmes et des assistantes accoucheuses.
mafiti sensibiliser ala so mbeni tingangwa ida encore ngape ama machango na mama cha bébé parce ala ke gagi na hôpital.
Betni anje so ala undangana mara zon to so tena jingana yashika cheni a iso ikingana vechi hôpital ngape so ala lala gana tere chi si amunga na i conseil chi tene iganga na hôpital chi tene sauver vie chi so.
De nombreux accouchements se déroulent désormais dans de meilleures conditions et les soins deviennent progressivement plus accessibles. Bien que le chemin reste encore long, les actions sont en cours pour une bonne santé à la naissance, pour un avenir plein d'espoir en République centrafricaine.
Dans le cadre de la réponse Ebola, nous avons organisé l'acheminement de 80 mètres cubes d'équipements, de matériel et de consommables médicaux de Kananga jusqu'à Boulapé. Nous avons sollicité l'appui de notre partenaire, le Programme alimentaire mondial, pour la mise à disposition de 4 camions. L'opération s'est déroulée dans un contexte géographique très complexe. Il n'existe pas de route praticable entre Kananga et Boulapé, ce qui rend l'accès particulièrement difficile, et notamment pour des volumes aussi importants.
La route n'est pas bonne. On est en train de se débrouiller pour passer. Il y a des arbres qui se courent. le crevaison d'Épinay, un humanitaire, il faut avoir du courage, l'amour envers les autres. Nous prenons ces risques-là pour sauver la population.
Ces intrants qui ont pu être livrés vont permettre d'assurer la continuité de nos activités dans le cadre de cette réponse, que ce soit les activités de prise en charge, de PCI et de surveillance. C'est un bel exemple de collaboration entre les agences des Nations Unies, notamment le PAM, qui nous ont permis ensemble d'assurer le maintien des opérations dans le cadre de cette réponse.
بريميرا حسيت بوتني مشيت لبتان أنا كنت أنا فيصل من فيصل خلاص قالوا الصغير ده ما يقدر يمرق بيتيت الصغير ده قاعد فوق بس ما يقدر يمرق بيتيت كمان خلينا نجي شنوها هنا جيت شنوها هنا كمان خلاص قالوا لي قال خلينا نمشي نسوي عملية خلاص سووا عملية ومرقوا صغير الحمد لله ما منتونا جراتشي سوينا جراتشي ساعدونا الحمد لله لكن كان أول نقولة من دي نقدر
L'Organisation mondiale de la santé, avec l'appui de ses partenaires, a répondu à ces besoins prioritaires qui ont été exprimés, principalement l'aménagement de plateaux techniques, la disponibilité en médicaments essentiels, contribuant ainsi à l'amélioration graduelle de l'offre de services de soins et la prise en charge des urgences néonatales et obstétricales.
Les décès ou bien les retards même dans les prises en charge, c'est quelquefois est lié par l'absence de certains produits qu'il faut aller courir de gauche à droite pour en trouver afin de sauver la femme. Donc certainement, ces produits ont contribué à la réduction de la mortalité, si j'ose le dire comme ça, de la mortalité maternelle dans nos informations sanitaires.
En janvier 2026, dans les 175 accouchements, on a 0 décès maternel. Sur ces faits, nous, on a reçu de matériel de l'OMS et ça entre vraiment dans la prise en charge de nos femmes.
L'OMS nous a aidés. Comme nous, on a des médicaments, les femmes ne payent pas.
L'OMS nous a offert les boîtes de césarienne. Bien avant, on a des boîtes de césarienne. Avec l'ajout de l'OMS, ça nous a aidé d'avoir plus de boîtes. Et ça veut dire la patiente sera opérée et plus sécurisée. La prise en charge, il faut que ça soit rapide et adéquate pour sauver la mère et l'enfant.
Les cliniques mobiles permettent d'observer les populations éloignées des centres de santé, améliorer ainsi la couverture sanitaire. Elles offrent des services de santé reproductive tels que le soin maternel, la consultation nourrisson, le dépistage de la malnutrition, la vaccination et la consultation curative. Cela permet d'identifier les risques à temps et de fournir une prise en charge adéquate.
inji da doktor kwarara da aran makwai zama zanka kan man duken ta kubante aman dulakkal amman zanka kan duken sa kubante ba dori bunaka an ga aga kan ba
Ika kanisino dori kusiye iko kiaga dori kusaiga lokotara imbono dirka kise ika newo.
L'OMS fait partie de partenaires qui est toujours disponible pour pouvoir nous accompagner et nous appuyer dans le cadre de la mobilisation communautaire pour offrir à la population des soins et services de santé de qualité.
Toutes les populations qui sont dans les endroits assez difficiles, le projet clinique mobile a beaucoup contribué pour vraiment atteindre ces populations, pour approcher les soins à ces populations qui ont vraiment pu bénéficier des soins de qualité. Et tous les jours, on a les retours positifs.
Lokotara ibumbolo dirosa ni gari kwa aine siyasin tinano a hiyon banda ine dori saga dori saiga ai maka ne bi na go faraha.
J'avais discuté avec les jeunes et les mamans par rapport à l'âge des filles et des jeunes garçons dans la période de puberté. Dans ces moments, la jeune fille peut avoir certains signes comme les premières règles. En plus, on a parlé de PF, les méthodes contraceptives.
Konjito autonomie no kuro mi obe nemi di hihea eleke nyo no fiona mi be mi ado do buwando mi enyanti o ba autonomie le pea maso pero de kienji e ava pero nti le so mi.
Honorable Minister, distinguished delegates, can we take a seat? Distingués délégués, on va commencer bientôt. Si vous pouvez vous asseoir, merci.
Distinguished delegates, kindly take your seats. We are going to begin shortly.
L'adolescence et la jeunesse constituent une période clé pour acquérir des informations fiables pour éviter que les jeunes n'adoptent des comportements à risque.
Les soins de santé sexuelle et reproductive, par exemple la planification familiale, les familles n'aidaient pas par peur, mais avec les sensibilisations, elles viennent. Donc quand elles viennent, il suffit juste qu'on puisse les mettre en confiance.
Hello, good afternoon. Distinguished delegates, can you take our seats? We are about to start. Let's take our seats. Let's take our seats. Ladies and gentlemen, welcome back from our lunch. I'm sure now we are ready for the next session. We shall now proceed with agenda item 10, which is strategy for financing the future of health in the WHO African region 2026 to 2035, which is contained in document AFR/RC76/6, and the accompanying resolution contained in document AFR/RC76/WP3. The documents will be presented by Dr. Adelaide Onyango, Director of Health Systems and Services Cluster. Over to you, Dr. Onyango. You have 10 minutes. Let's stick to time.
Thank you, Chair, and good afternoon, honorable delegates. On behalf of the Secretariat, I am privileged to introduce document AFR/RC76/6 and document AFR/RC76/WP3, the strategy for financing the future of health in the WHO African region 2026 to 2035. The African region continues to face structural financing weaknesses that have been exacerbated by the COVID-19 pandemic, rising debt burdens, abrupt reductions in external assistance, and increasing exposure to climate, humanitarian, and health shocks. Next slide, please. While member states have implemented important and innovative reforms, progress remains uneven. First, financial protection remains insufficient. Although financial hardship declined from 37.7% in 2015 to 35% in 2022, nearly 385 million people in the region are still annually pushed into poverty or deeper poverty due to direct health payments. Second, public financing for health remains constrained, with 18 member states in the region experiencing a decline in the share of government expenditure allocated to health between 2019 and 2023. And third, the region remains vulnerable to financing shocks, with continued reliance on external financing for, on average, 25.5% of current health expenditure, according to 2023 figures. In the next slide, we look a little bit at the context in which, therefore, we are discussing the new strategy. It provides member states with updated, evidence-based guidance on to mobilize resources and more effectively optimize the use of available funds, reduce financial hardship, and build resilient health systems capable of advancing universal health coverage and health security. It proposes 5 objectives: strengthening national health financing systems, improving equitable and efficient use of health resources, strengthening financial protection and reducing out-of-pocket spending, strengthening health financing governance, evidence generation, and accountability for results. And finally, promoting integration of health financing into national and regional development agendas. The strategy also sets clear targets for the next decade, including a sustained increase in government spending on health and improved financial protection in 56% of member states, a 4 percentage point reduction in the share of the population impoverished by health spending, and 75% of member states having clearly articulated up-to-date financing, up-to-date health financing for health priorities. In the final slide, we're looking at what the priority, please let's have the next slide, the priorities that are proposed with interventions across 7 domains. These are already contained in your strategy document, so we're just going to look at the headings that are listed out here. So the priority interventions include health financing policy, process, and governance, revenue raising, pooling, and the pooling of revenues, purchasing and provider payment, benefits and conditions of access, public financial management, and financing public health functions and programs. The details of each of these priority interventions are included for your, I'm sure you've reviewed them and see how they fit into your national agendas. So the regional committee is invited to examine and to adopt the proposed strategy and the accompanying resolution. I submit.
Thank you very much, Dr. Onyongo, for that presentation. I now open the floor to member states' interventions. Distinguished delegates, honorable member states, strictly 2 minutes. Let me see. We'll start with Kenya, followed by Tanzania, then followed by Burkina Faso. Kenya, you have the floor.
Thank you, Chairperson. Kenya supports the adoption of the strategy for financing the future of health. Chairperson, this strategy arrives at a defining moment. External assistance is falling sharply, and out-of-pocket spending in our region averages 35% of the health expenditure against a benchmark of 20. Under the Social Health Insurance Act of 2023, we established the Social Health Authority as a strategic purchaser, consolidated fragmented schemes into 3 funds, and replaced the flat rate premium with a means-tested income proportional contribution. More than 32 million Kenyans are enrolled, and we target 85% of the population by 2030. 2 lessons, briefly. Financing reform succeeds or fails in public financial management. Kenya has rolled out integrated financial management information systems across 47 counties and enacted Facility Improvement Financing Act. We are cutting national health accounts production from 18 months to 45 days through digitization. And we must be honest about what is not done. Out-of-pocket spending remains too high. Indigence and informal sector enrollment is incomplete. The primary healthcare fund still lacks predictable multi-year allocations. Chairperson, Kenya makes 2 asks. 1, that WHO sustains hands-on technical support for countries in mid-transition. The hardest period is not the design, it is year 3 of the strategy.
10 seconds.
2, that the region office convenes structured peer exchange among members, states implementing purchasing reforms. Kenya is ready to host and share both our results and difficulties. I thank you.
Thank you, Kenya. We now have Tanzania.
Chairperson, Tanzania recognized the sustainable health financing is a fundamental to achieving universal coverage, strengthening health security, and advancing the health sustainable development goals. In the context of a changing global financing landscape, including declining external assistance and increasing health needs, African countries must strengthen domestic resource mobilization and build more resilient and self-reliant health system. Tanzania, therefore, welcomes this strategy as a timely and important for guiding countries towards sustainable, equitable, and efficient health financing. Tanzania remains firmly committed to increasing domestic for health and strengthening financial protection to ensure equitable access to quality services. We support the 3 priorities of the strategy, particularly increasing domestic public investment in health, improving health efficiency and value for money, promoting strategic purchasing and equitable resource allocation, and building national capacity for health financing policy and implementation. The priorities are well aligned with Tanzania's ongoing health sector reforms and commitment. Tanzania support the adoption of the strategy for financing the future for health in the WHO region 2026-2035. We will continue to work closely with the WHO member state, developing partner, and other stakeholders to ensure successful implementation of the strategy. I thank you.
Thank you, Tanzania. Now we have Burkina Faso. You have the floor.
Burkina Faso would like to thank the Secretariat for the high standard of the documents and endorses the guidelines set out in the strategy for financing the future of health in the WHO Africa region. This strategy comes at a time characterized by a decline in international funding, growing budgetary constraints, and high out-of-pocket expenditure, which place a strain on households and also jeopardize progress towards UHC. Chair, Burkina Faso regards health not merely as a budgetary burden, but as a strategic investment in human capital, productivity, and sustainable development. This approach calls for strengthening the mobilization of domestic resources and the financial protection of the population. This vision was reflected in the holding in March 2026 of our first National Forum on Health Financing, which enshrines sovereignty, equity, and efficiency as the guiding principles for the reform of our health systems financing. Despite the challenging security and budgetary context, our country allocates more than 12% of the state budget to health. Efforts are also focused on increasing domestic resources, rolling out the Universal Health Insurance Scheme, providing free health care for vulnerable groups, and exploring innovative financing mechanisms such as community ownership. The rationalization and digitalization of public health expenditure have become tools promoting efficiency implemented on a national scale. My delegation welcomes the fact that the regional strategy recognizes Burkina Faso's progress in developing digital financial management platforms which help to strengthen efficiency, transparency, and accountability. Burkina supports the adoption of the 2026-2035 strategy and encourages the WHO to support its implementation. Thank you very much, Burkina Faso.
Followed by Niger. Botswana, you have the floor.
Thank you very much, Chairperson. Botswana commends the Secretariat for the strategy for financing the future of the health in the WHO region. The strategy addresses critical challenges in health financing and has a noble goal. And its noble goal is to ensure sustainable health financing to reduce financial hardship and guarantee equitable access to quality health services for all. Botswana aligns with this framework. We recognize that robust health financing is a central enabler of inclusive growth and long-term resilience. To this end, Botswana has sustained investment and financial independence with public expenditure at nearly 80% of total health spending, equivalent to about 4 to 6% GDP, and 12% of the total government expenditure. This investment has resulted in an out-of-pocket spending of 4%, domestic financing of 95%, and a per capita health expenditure of about $400. In order to sustain this investment, the Parliament of Botswana recently passed the National Health Insurance Policy and are at an advanced stage towards considering an NHI bill, which will lay the groundwork for Botswana to have a strengthened, sustainable health financing system supported by resilient supply of medicines, health technologies, and quality health services towards UHC. Other initiatives include a costed essential health service package, collection of ancillary revenue from public facilities through leasing and unused facility space, sharing or renting underutilized medical equipment, and introducing commercial services to generate additional income. Botswana is strengthening health financing stewardship as an enabling function and strengthening collaboration with the Ministry of Finance of Botswana. In conclusion, Chair, Botswana supports the strategy for financing the future of the region and the accompanying draft resolution. Thank you.
Thank you, Botswana. Now we have Angola. You have the floor.
Thank you very much, Excellency, Chairperson, Honourable Ministers, Your Excellency, Regional Director. The Angolan delegation would like to laud the Secretariat on the presentation of the Strategy for Financing the Future of Health in the WHO African Region 2026-2035. And we thank you for the quality translation of the document. We believe that sustainable investment is fundamental in health so that we can reach UHC, ensure health security, and reduce financial hardship on the part of populations in accessing health. The reduction of external assistance and the growing number of public health emergencies means that we need to mobilize domestic resources and make better use, fairer use of available resources. We are committed to progressively including in our health priorities immunization with an emphasis also on PHC, prevention, and availability of essential medicines. We highlight the importance of aligning our national priorities with foreign assistance, making sure that we strengthen our health systems as well. We hope that there will still be technical assistance to help develop our national strategies to finance health, strengthen our capacities, and improve monitoring of the system. The Angolan delegation supports the adoption of this strategy. Thank you.
Angola. Can we have now Niger?
Monsieur le Président.
Chair, Regional Director, Excellencies, ladies and gentlemen, honorable ministers, distinguished delegates, Niger congratulates the Secretariat for the quality of the document and for the consultative process that took place, allowing member states to contribute to the drafting of the document. Health financing in Niger comes mainly from partners, the state, mutual assistance entities. The credit available is limited, however, given the increase in health expenditure. In 2023, when drafting the new health development plan, the Ministry of Health and its partners decided to review the national financing strategy so that it takes into account the new health strategies and priorities with a view to achieving UHC by 2030. The aim is to improve the global performance of the national health system based on 6 pillars, focusing on efficiency, equity, and sustainability. And so we endorse the objectives contained in this strategic document. Our work focuses on continuity of our national health plan. We will continue to assess the work being done and will be drafting further plans. We are preparing for universal health insurance through a pilot exercise which will allow for progressive introduction of the system in our health districts. We also will have tracking systems. This is covered financially by the Ministry of Health. And so we fully support the adoption of the Strategy for Financing the Future of Health in the WHO African Region 2026-2035 and its accompanying resolution. Thank you.
Thank you, Niger. Can we now have Ghana, followed by Mali, followed by Nigeria? Ghana, you have the floor.
Mr. Chair, Ghana thanks the Secretariat for developing this timely strategy and supports its adoption. For Ghana, universal health coverage is anchored in a complementary financial architect. Free primary healthcare seeks to remove financial barriers at the point of entry. The National Health Insurance Scheme pools risk and finances care across the health system, while the Ghana Medical Trust Fund addresses catastrophic costs associated with non-communicable diseases. We recognize that sustaining these gains will require stronger domestic resource mobilization. greater efficiency, accountability, and continued health financing reforms. We therefore welcome the strategy's emphasis on reducing out-of-pocket expenditure, strengthening strategic purchasing, and ensuring that health financing is aligned with national development priorities. Ghana also supports stronger regional collaboration through pooled procurement, local manufacturing, and digital solutions to improve efficiency and accountability. These are important steps towards greater health sovereignty and resilience. Chair, the future of health financing must be built on country ownership, sustainability, and solidarity. Ghana's Accra Reset Agenda, launched following the African Health Sovereignty Conference in Accra in August 2025, reflects this commitment through greater domestic investment, stronger public health institutions, local manufacturing, health workforce development, and more equitable partnership. Ghana remains committed to working with WHO, member states, and partners to advance financing reforms that protect our populations from financial hardship and ensure equitable access to quality health services. We note the proposed actions and the recommendations therein. Thank you.
Can you wind up? Thank you, Ghana, for your presentation. Now, Mali, you have the floor.
Merci, Monsieur.
Thank you, Chairperson, distinguished guests. Financing health in Mali is based on several sources: the state, technical partners, households, the insurance and social protection schemes, as well as the various regions and provinces. Despite this support, we face major challenges: not enough public resources or funds, dependency on external funds, and fragmented financing. In order to go towards UHC, the national strategy aims at mobilizing more domestic resources, would like to pool risks, reduce out-of-pocket payments, and protect households when it comes to expenditures linked to disasters. Public financing needs to progressively increase. We need to improve our budget execution, mobilize domestic resources, and implement universal insurance. We also need to coordinate financing. We need to strengthen community and primary health services and develop strategic procurement mechanisms. That what is at stake is not more expenditure. It's not about spending more, sorry. It's about better mobilizing, better distributing, and ensuring equitable and sustainable access to health services. We endorse this report. Thank you.
Thank you very much. Can we have Nigeria? Is Nigeria there?
That will be later, please. Nigeria is here, but give us some minutes. Thank you, sir.
Let's have Guinea-Bissau, then Nigeria. When you are ready, we'll ask you to speak. Guinea-Bissau?
Thank you very much, Chair. Guinea-Bissau is currently drafting its national strategy to finance health, collaborating with WHO. We fully support the strategy for financing the future of health in the WHO African region for 2026 to 2035, which considers domestic resource mobilization, efficiency, and sustainability fundamental to transforming health systems. For our country, this means progressively increasing domestic financing of health, improving management and efficiency in resources, and improving the income of families working with our partners. This is particularly important for us as it is an inflection point. We are still far too dependent on external assistance. So we are therefore committed to the strategy and committed to building a more sustainable health system, one that is fairer, more resilient, with a view to achieving UHC by 2035. Thank you.
Thank you very much for that brief presentation. Can we now have Eritrea, followed by Comoros, and then Zambia? Eritrea, you have the floor.
Thank you, Mr. Chairperson. Eritrea welcomes the strategy's comprehensive approach, particularly its focus on strengthening governance, mobilizing domestic resources, improving pooling and purchasing arrangements, modernizing public financial management, and ensuring sustainable financing for essential health functions. These elements are crucial for advancing universal health coverage, strengthening health security, and improving the resilience of health systems across the region. The state of Eritrea supports the overall direction of the strategy and emphasizes that health financing reforms should remain country-led, context-specific, and aligned with national development priorities. At the same time, such reforms must continue to promote equity, efficiency, financial protection, and resilience. In Eritrea, we remain committed to placing primary health care, prevention, and equitable access to services at the center of our health sector development. We continue to strengthen community health services, improve strategic planning and service delivery, and make better use of available resources to support an integrated and nationally owned health system. Eritrea will prioritize stronger alignment with health plans and budgeting processes, improved expenditure tracking and accountability, evidence-informed resource allocation, and sustainable financing for primary health care, health security, and essential public health functions. We also call for strengthened regional cooperation and continued WHO technical support in areas such as institutional capacity development, strategic purchasing, and financial system strengthening. I thank you.
Thank you, Eritrea. Can we have Comoros, followed by Zambia, followed by Central African Republic?
Okay, merci.
Thank you, Mr. Chairperson. The Union of Comoros would like to thank the Secretariat for preparing this strategy that is very timely for Africa's health systems, knowing that there's a reduction in external finances, we have an increase in health needs, and it's essential to accelerate progress towards UHC. Comoros supports the priorities identified because they're fully in line with our own priorities, our national health priorities. Indeed, the Union of Comoros has a national strategy to finance health from 2019 to 2030. And this year, we are doing the midterm review in order to assess the progress made to identify remaining challenges and align this strategy on our new regional context as well as global context and priorities. Furthermore, the government recently launched a 3-year pilot project for health insurance. It will strengthen financial protection for our population and progressively reduce the out-of-pocket expenditures for our households and families. Mr. Chairperson, the Union of Comoros would like to emphasize the fact that domestic resource mobilization should take into account structural realities that are peculiar to some countries, in particular small island developing countries. In this context, equity, which remains a core principle for the implementation of this strategy, should be promoted. We'd like to encourage the WHO and our partners to develop mechanisms that are adapted to our needs. We would also like to call for more predictable, flexible funding, and those should be better aligned on our priorities in order to assist us in moving progressively towards more sustainable financing mechanisms. The Union of Comoros would like to support the adoption of this strategy, and we reiterate our commitment to implement necessary reforms. Thank you.
Thank you, Comoro. Zambia, you have the floor, followed by Central African Republic, followed by Zimbabwe.
Chairperson, Zambia welcomes the strategy for financing the future of health in WHO Africa Region 2026 to 2035. We commend its recognition that sustainable domestic health financing is critical to achieving universal health coverage, particularly amid fiscal pressure and declining external assistance. The strategy aligns with Zambia's efforts to strengthen domestic resources mobilization, public financing management, and country-led financing, while reducing fragmentation and ensuring external resources are aligned with national priorities. We strongly support increased fiscal space through health taxes, public sector engagement, and more strategic purchasing linking resources to population needs, efficient and measurable health outcomes. For Zambia, primary health care, prevention, and affordable benefit package remains central to building an equitable and resilient health system. We therefore encourage implementation, support, including technical assistance to member states to translate the strategy into country-level action. We further call for closer alignment between this strategy, the African Union Health Financing Agenda, and the Lusaka Agenda to promote greater coordination, accountability, and African ownership of healthy financing. Zambia supports the strategy and stands ready to contribute to the collective efforts to build resilient, equitable, and sustainable health financing system across Africa. I thank you, Chairperson.
Thank you, Zambia. Can we have Central African Republic? You have the floor.
Monsieur le Président,
Mr. Chair, Mr. Regional Director, the Central African Republic congratulate the Secretariat on the strategy for financing the future of the health sector in WHO African region 2026-2035. Our country is particularly aligned with the strategic directions set out in this strategy. In this regard, CAR has undertaken several structural reforms. First, we have developed a national health financing strategy, which now serves as a reference framework to guide reforms, improve resource mobilization and utilization, and to progressively strengthen the financial protection for our population. Second, our country has embarked on an ambitious process to align and harmonize technical and financial partners around our national priorities. This approach aims to bring partners together around one plan, one budget, and one reporting framework. Significant progress has been made with a maturity score of 4 out of 5, reflecting the momentum generated by CAR. Our goal being to reduce aid fragmentation and strengthen national ownership of health financing. Third, in order to improve governance and traceability of resources allocated to health, the government has established a multi-sectoral committee bringing together the Ministry of Health and Population and the Ministry of Finance and Budget. The dialogue will also be promoted. CAR always sends representatives from both ministries to WHO meetings. Fourth, the Central African Republic has initiated a process to establish health insurance, which represents a major step towards improving financial protection for households. It is important that external assistance be predictable, coordinated, and aligned on priorities defined by countries pursuant to the spirit of the Lusaka Agenda. CAR reaffirms its full support for the adoption of the 2026-2035 regional strategy. Thank you.
Thank you. Can we have Zimbabwe?
Thank you, Chairperson. Zimbabwe welcomes the strategy for financing the future of health in the WHO Afro region 2026 to 2035. We commend WHO Afro for advancing country ownership, sovereignty, and sustainable domestic financing at a time of declining external assistance and growing health challenges. Zimbabwe is committed to translating this vision into action through our National Health Strategy and Health Financing Strategy 2026 to 2030. Our experience demonstrates that innovative domestic financing can deliver results. Zimbabwe's well-acclaimed AIDS levy, introduced more than 2 decades ago, has made a significant contribution to sustaining our national HIV response and the remarkable gains achieved in HIV prevention, treatment, and viral suppression. We are building on this experience through other innovative financing measures, including health-related sin taxes. The sugar-sweetened beverage tax, for example, has enabled us to mobilize resources for critical cancer treatment and radiotherapy equipment, demonstrating how fiscal measures can both address health risks and finance essential services. Like other sister African member states, we are also establishing a national health insurance program to reduce fragmentation,
strengthen financial protection, and expand equitable access to essential health services. Chairperson, Zimbabwe believes sustainable health financing must be country-owned, predictable, and resilient. We encourage countries to learn from successful African innovations and adapt them to their own context. We stand ready to work with member states and partners to operationalize this strategy and build resilient health systems that leave no one behind. I thank you.
Thank you, Zimbabwe. Can we have Liberia, followed by Senegal, followed by Ethiopia? Liberia, you have the floor.
Honorable Chair, Excellencies, distinguished delegates, Liberia supports adoption and member state contextualization of the WHO African Region Health Financing Strategy 2026 to 2035. We recognize that the universal health coverage means quality care without financial hardship. Sustainable financing requires three answers: who, what, how much. Honorable Chair, the third financial protection is our greatest gap. In Liberia, 62% of health spending is out of pocket. 1 in 12 households forgo care due to cost. With aid declining and donor transition on the way, catastrophic spending demands national, sub-regional, and regional actions. Our response is 2 bills are before our national legislature. 1, Health Equity Act of 2026, which establishes an autonomous authority to strategically purchase services and monitor providers. 2, Health Equity Fund Act of 2026, which is mandatory coverage for all, including the vulnerable, via diversified statutory revenues. We also push for the Abuja 15% budget target, though current allocation fluctuates between 8.5 to 14%. Honorable Chair, national efforts must align with regional solidarity. Liberia, therefore, endorses this 2026 to 2025 strategy. I thank you.
Thank you, Liberia. Now we have Senegal, followed by Ethiopia, followed by Mauritius. Senegal, you have the floor.
Je vous remercie. Thank you, Mr. Chair. Senegal commends the Secretariat on the development of the strategy for financing the future of health in the African region at a time where sustainability and self-reliance of health financing have become strategic imperatives. Health financing must be recognized as a strategic investment in quality human capital, sustainable economic growth, and social cohesion. In line with this vision, Senegal, as committed through its National Health System Transformation Strategy 2025-2034, so has committed to accelerating progress towards UHC and strengthening its health resilience. 3 areas or priorities guide this action: mobilizing domestic resources, in particular through innovative fiscal mechanisms, rationalizing expenditure through performance-based financing, and also strengthening financial protection and equity by restructuring health insurance and coverage of vulnerable groups. Mindful of the volatility of ODA, Senegal supports the 2026-2035 strategy and recommends the following: supporting states in establishing innovative financing mechanisms and sustainable fiscal space with more efficiency and transparency. Secondly, aligning TFPs with national priorities, particularly through the health compact, strengthening political commitment and dialogue between the ministers responsible for health and finance, mobilizing private sector resources, supporting the establishment of a mandatory health insurance scheme, strengthening monitoring and accountability through integrated dashboards. In conclusion, Senegal invites the RC to take note of this strategy and calls for the adoption of the related resolution. Thank you.
Can we have Ethiopia?
Thank you, Chair. Ethiopia welcomes the strategy and supports its adoption. Ethiopia commends the Secretariat for an evidence-based, contextually grounded strategy that responds squarely to the realities of the region. The 7 strategic action domains are broadly consistent with, and in several respects directly reinforce, the reform pillars already embedded in Ethiopia's health financing strategy Sustainability Roadmap 2026 to 2035, and Health Sector Development and Investment Plan 2. We offer the following proposals. First, for the strategy to include stronger guidance on the political economy of pooling transitions, including the design of subsidy mechanisms for the informal sector, which represents much of the population in many member states. Second, external assistance is rightly transitional, but its pace must match absorptive capacity. We urge explicit transition risk management minimum timelines, domestic top-up mechanisms, and country-level joint financing compacts that domesticate the Lusaka agenda. Third, on benefit package, iterative revision must be supported by a functioning health technology assessment system. The call to institutionalize such assessments should be accompanied by regional capacity building programs and a WHO-hosted repository of cost-effectiveness data relevant to the African epidemiological context. Finally, on monitoring, Ethiopia supports the 4-indicator framework in the annex, but recommends for adequacy to be measured alongside trend. Ethiopia calls for the adoption of the strategy with the listed proposal and urges WHO to provide robust country-tailored technical assistance to help member states translate commitments into budgeted, time-bound national health financing reform plans. I thank you.
Thank you so much. Can we have Mauritius, followed by Chad, followed by the Gambia?
Thank you, Chair. Since independence in 1968, Mauritius operates a tax-funded universal health system where services are provided free at the point of use across the continuum of care. Around 70% of the healthcare needs of the population are managed in the public sector. The country made long-term commitments to achieve universal health coverage. In spite of rising costs, government through the recent budget has strived to bring investments to shore up public health systems by increasing the fiscal space from 15.18 billion rupees to 19.8 billion rupees for the financial year 2026-2027. Per capita government expenditure on health, which was 12,026 rupees, has increased to 15,944 rupees in the current financial year, reflecting sustained investment in the sector. These include socio-economic measures like free maternal and child care, free HIV and AIDS programs, overseas treatment funded by the ministry, free methadone substitution therapy. Mauritius has reached a universal health coverage service index of 75, life expectancy of 70.5 years for men and 77.5 years for women, immunization coverage exceeding 95%, and substantial reductions in maternal and child mortality. The strategy's call for strengthened domestic resource mobilization is particularly pertinent as Mauritius deals with competing national priorities across sectors and constraints, which include human resource pressures, fragmented data systems, and capacity gaps. We respectfully request that the Secretariat provide sustained technical support to strengthen institutional capacity, particularly in health economics and independent monitoring and evaluation functions, and to help member states engage finance ministries as key partners in this agenda. In this line, Mauritius will adhere to the African Regional Strategy on Financing the Future of Health through aligned measures in the upcoming Health Sector Strategic Plan 2026-2030, which will have a positive impact on health financing. Thank you for your kind attention.
Thank you, Mauritius. Please, let's stick to the time. 2 minutes only. Can we have Chad?
Merci. Thank you, Mr. Chair. Excellencies, ladies and gentlemen, the ministers, the delegates, the delegation of Chad would like to thank the Secretariat for the document, the Strategy for Financing the Future of Health in the African Region 2026-2035. Chad fully supports or endorses the objectives announced in this, spelled out in this strategy. It's timely for health services that are facing the constant reduction of APD, and it is now an imperative to move swiftly towards UHC by 2030. Similarly to many countries in the region, the fiscal space in Chad is limited, and we have high out-of-pocket expenses. So our most vulnerable populations face catastrophic expenditures. The Chad delegation insists on two messages. Firstly, the progressive increase of health budgets. Chad would like to reiterate its commitment towards the Abuja Declaration, the objective being 15% of the national budget allocated to health. My country is on the path of increasing its domestic resource mobilization in order to reach the Abuja targets. We need the technical assistance of the Secretariat for a transparent monitoring of progress in countries concerning now pooling risks. We support these mechanisms, health insurances and other schemes that will reduce the out-of-pocket expenditures and lighten the burden on these households covering more than 60% of their health expenditures. We need WHO's TA in order to strengthen our national capacities in this area. Chad would like to call upon member states and partners to adopt the proposed strategy for sustainable and equitable financing of health for our populations. Thank you.
Thank you very much. Now we give the floor to the Gambia, followed by Madagascar, and then DRC. The Gambia.
Chairperson, distinguished delegates, the Gambia commends the Secretariat for this timely, evidence-based framework, which offers practical guidance to strengthen health financing systems, mobilize domestic resources, improve efficiency, reduce financial hardship, and accelerate progress towards universal health coverage and health security. The Gambia fully supports the proposed strategy and recognizes that sustainable and equitable health financing is essential for building stronger health systems that can respond effectively to current and emerging challenges, particularly in a context of constrained physical space, high out-of-pocket expenditure, and declining external assistance. The Gambia has a national health financing policy 2017 to 2030 and a national health financing strategy 2026 to 2030 to guide reforms and align health investments with national priorities. Following enactment of the National Health Insurance Scheme Act in 2021, implementation of the National Health Insurance Scheme is advancing with more than 70 public health facilities accredited as service providers. We have institutionalized production of national health accounts to improve health expenditure tracking and inform policy dialogue, planning, and decision-making. Chairperson, the Gambia supports the adoption of this strategy and reaffirms its commitment to working with WHO, member states, and partners to translate its recommendations into concrete national actions that advances equity, sustainability, resilience, and universal health coverage. Thank you.
Thank you very much, the Gambia. Can we have Madagascar?
Merci, Monsieur le
Thank you, Mr. Chair. Madagascar supports the adoption of the strategy for financing the future of health in the WHO African region 2026-2035. Given the dwindling APD and increase in health needs, our countries have to build financing systems that are more autonomous, sustainable, and equitable in Madagascar. Out-of-pocket expenditure and low coverage by our health insurance mechanism exposes many households to a financial hardship. Currently, we're working towards progressively increasing public financing. We want to improve efficiency and transparency of expenditures all the way to primary health structures. We want to strengthen the financial capacity of our health structures at all levels, and we also want to implement financial protection mechanisms that tally with our needs in order to have health staff, medicine available in our communities in order to move towards UHC. Madagascar would like to ask WHO and partners to support us in mobilizing domestic resources, in reducing inefficiencies, and in aligning APD to our national priorities. Together, let's build sustainable financing for health so that no citizen in Africa finds themselves choosing between health and satisfying essential needs. Thank you.
Thank you very much. Now we have DRC.
Merci, Monsieur le Président.
Thank you, Mr. Chair. I take the floor on behalf of His Excellency, Mr. Minister of Public Health in DRC. hygiene. He had other commitments, state commitments. Indeed, DRC would like to commend WHO Secretariat on the quality and clarity of the document under review. Our country clearly endorses the priorities proposed for 2026, 2035. Since 2019, DRC has increased its health financing, focusing mostly on health control, pandemics preparation, malnutrition, procurement of vaccines, and specific inputs. We also made deliveries free, as well as the neonatal care. And now when it comes to innovative financing, DRC has also, in collaboration with the Ministry of Finance, established a health promotion levy, 2% for some imports and exports that would be dangerous to our health, sorry. We're also working towards rehabilitating health structures, and DRC would like to reiterate its commitment towards the progressive increase of domestic resources for health, and we will continue our efforts towards UHC. Finally, DRC would like to congratulate WHO. We would like to also endorse the priorities, and we also supported this strategy. We approve it. Thank you very much.
Thank you so much. Can we have Sierra Leone, followed by Namibia, followed by Uganda? Sierra Leone, you have the floor.
Thank you, Mr. Chair. Ministers of Health, colleague delegates from member states. In Sierra Leone, we are undertaking a fundamental transformation of our health system. A major achievement to our transition from a fragmented, donor-dependent, and largely out-of-pocket financing system towards a national coordinated UHC financing architecture. We are developing the National Health Financing Strategy 2026 to 2030 with a stronger focus on domestic resource mobilization, financial protection, strategic purchasing, and sustainability. We are also working towards a unified national health benefit package and stronger institutional arrangements for UHC financing, while exploring innovative approaches to financing primary health care and directly financing facility based on population needs, quality, and results. Our priority is to build a health system where resources are pooled, financing follows population needs, decisions are driven by reliable data, and every Sierra Leonean can access quality essential health services without financial hardship. We thank our WHO country office and WHO Afro for accompanying us on this journey and call for support to stronger regional collaboration and investment. Sierra Leone remains fully committed to the provisions in the strategy for financing the future of health in the WAHU African region and call on other member states to endorse the same. Thank you.
Thank you so much, Sierra Leone. Can we have Namibia, followed by Uganda, and then Congo?
Thank you, Chair. Namibia commends the Secretariat for developing this timely strategy. The report underscores the sobering reality that many countries in our region still grapple with alarmingly high out-of-pocket costs and unmet domestic financing targets, a reality that we must address head-on. Namibia has successfully reduced out-of-pocket health expenditure to 8%, significantly below the 20% WHO benchmark. Furthermore, health consistently commands the second largest share of our national budget, fulfilling our Abuja Declaration commitments. However, financing or financial inputs alone do not guarantee improved health outcomes. We urge the Secretariat to enhance its technical support to help member states efficiently translate these financial commitments into tangible, equitable health gains for our populations. Chair, Namibia believes it is unjust to demand increased domestic health financing from African nations while an unfair global financial system drains our domestic resources. As the report highlights, many countries now spend more on debt servicing than on health and education combined. High interest rates and sluggish relief frameworks systematically deplete our public health budgets. In an era of declining donor funding, addressing this debt burden is a fundamental health imperative necessary to unlock vital fiscal space. In conclusion, Namibia supports the adoption of the strategy and the resolution. We respectfully request that when the Secretariat reports on the implementation of this resolution, it explicitly includes updates on measures undertaken to support member states in addressing the debt crisis, including advocacy for global mechanisms like debt for health swaps and pandemic debt servicing freezes. I thank you.
Thank you, Namibia. We now have Uganda.
Thank you very much, Mr. Chairman and distinguished delegates. Uganda welcomes the strategy for financing the future of health and notes its strong alignment with the country's own joint planning and budgeting-driven financing reform agenda and the December 2025 National Health Compact commitments. Uganda notes its explicit identification in FR/RC 76/6 as one of the 5 member states at risk of losing 20% or more of current health expenditure due to donor transitions, and requests that WHO and partners prioritize technical and financial support to Uganda under the strategy's revenue raising and public finance management action domains. Uganda calls on external partners in line with strategy paragraph 20D and the Lusaka agenda to progressively align funding through the government public finance management systems, building on the precedent set by the US government on the budget memorandum of understanding to help close Uganda's exposure gap ahead of further donor transitions. Mr. Chairman, Uganda requests continued World Health Organization support to reverse the declining PHC share of domestic health spending, down from 42% to 32% since the post-COVID period, to ensure budget growth translates into frontline service delivery. I thank you very much.
Thank you, Uganda. Can we have Congo followed by Benin and then Togo?
Le Congo, par ma voix.
Congo would like to congratulate the Secretariat through me and the regional office for having included the strategy for financing the future of health in the WHO African region 2026-2035 in the agenda. Our country, like other member states, has to deal with budgetary constraints that are structural in order to finance its health system. The budget allocation to health is below the 15% Abuja target. And so we need equitable and sustainable financing, and that is why we have an innovative mechanism which includes taxes and mobilization of funds. It is also important to point out that there is free treatment and also free access to medicines for HIV/AIDS. Despite significant progress, we're still dependent on ODA, and families have high out-of-pocket expenditure, which is why we welcome the strategy for financing the future of health in WHO African region 2026-2035, which we hope the regional office will adopt and implement. We want to work towards UHC ensure performance-based implementation, efficiency, digitalization of financial management in our health systems in order to implement this strategy. We encourage the region to continue its efforts in this area, and we will continue to work with WHO to guarantee financing in this area and the attainment of UHC.
Thank you. Can we have Benin?
Thank you very much, Chair. Benin would like to congratulate the Secretariat for the initiative of developing the strategy for financing the future of health in the WHO African region 2026-2035. Benin shares the view that there are structural vulnerabilities in the region. A lot of expenditure is directly borne by families, and this is an obstacle to equity and to achieving UHC. Fragmentation also underscores the need to strengthen efficiency and sustainability of the whole health system. Given these challenges, Benin has undertaken structural and institutional reforms that are ambitious with a view to strengthening health governance and increasing sustainable financing of health. This has allowed us to duplicate state budget allocations to health, reducing also significantly the part of out-of-pocket expenditure that comes from families, which was 52% in 2016 and has fallen to 45% in 2025. We are currently drafting our national strategy for health financing with a view to achieving UHC, which seeks to operationalize and implement compulsory health insurance. We congratulate the country offices and the regional office that have been alongside us in this process, assisting us with consultants. We restate our full commitment to the national strategy and urge all member states, therefore, to also support and implement the strategy. Thank you.
Thank you very much, Benin. Can we now have Togo, followed by Nigeria, then followed by South Africa?
Merci. Thank you very much, Chair. Togo thanks the regional committee that has been working with member states to implement important reforms to make health financing more sustainable. We need to ensure stable resources and provide quality services to our population. That means optimizing expenditure and focusing on endogenous products. We need to undertake a reform of our national public financial system so that we can better use resources. And that means focusing on the social sector, better exploiting the mechanisms available, such as new specific taxes, focusing on a contribution that is one that focuses on solidarity. This helps us to mobilize significant resources thanks to the amounts paid in by those who are insured. Universal health insurance is also work that is ongoing, working with civil servants, self-employed workers and others, and we will now be extending this to vulnerable peoples and agricultural workers. There are, however, important challenges. We need to set up an interoperable information system that is robust. We need to make available essential medicines, focus on infrastructure, and think also about health community agents on the ground. We need to continue to work on aligning our national priorities, and we therefore ask for sustainable mobilization of resources in the African region and urge member states to take note of the current resolution. Thank you.
Can we have Nigeria, followed by South Africa, and then Algeria? Nigeria, you have the floor.
Thank you, Chair. Nigeria welcomes the strategy for financing the future of health in the WHO African region 2026 to 2035 and supports its adoption. In line with the strategy, Nigeria is focused on increase in financial protection, domestic financing through Basic Healthcare Provision Fund, the development of national policy and strategy for healthcare financing, and the adoption of a sector-wide approach. Nigeria calls on WHO and partners to prioritize technical assistance for public financial management, strategic purchasing, health technology assessment, expenditure tracking, and health financing capacity within government systems. Strengthen the link between health financing and fiscal policy through stronger domestic revenue mobilization and improved prioritization of health in national budgets, and the establishment of a regional mechanism for peer learning, earmarking, and tracking progress on domestic financing, financial protection, efficiency, health expenditure, and transition from external financing. In conclusion, Nigeria supports adoption of the strategy and is committed to its implementation through country-owned, measurable, and adequately financed actions. Thank you for your attention.
Thank you very much. Can we have South Africa, followed by Algeria?
South Africa commends the Secretariat for the Comprehensive Strategy for Financing the Future of Health in the WHO Afro region. As we address regional fiscal pressures, plateauing public health spending, and the challenge of high out-of-pocket expenditure, South Africa shares its national experiences and priorities in advancing sustainable health financing. A core pillar of South Africa's domestic health financing reforms is a transition towards a consolidated and equitable resource pool. To overcome historical fragmentation between our public and private sectors, we are actively working to pool public resources to maximize risk and income cross-subsidization. Consolidating these streams ensures that healthcare access is driven by population health needs rather than socioeconomic standing. In alignment with the strategic action domains of the regional strategy, South Africa is shifting away from passive region line item budgeting towards systematic strategic purchasing. By linking financing mechanisms and provider payment reforms to output performance and quality standards, the state enhances efficiency, accountability, and value for money across the healthcare delivery. Furthermore, South Africa emphasizes that modernizing financial and health management systems is critical for resource tracking and transparency. The deployment of digital health platforms, electronic health records, and robust data analytics are vital enablers to streamline administrative workflows, monitor real-time resource utilization, and support evidence-informed decision-making. South Africa supports the adoption of the regional strategy. I thank you.
Thank you, South Africa. We now have Algeria, followed by Malawi. Algeria, you have the floor.
Thank you, Mr. President. Mr. President, the financing of the Algerian health system is mainly provided by, Mr. President, Algeria attaches great importance to early childhood development, recognizing that the first years of life are... Okay, the right statement. Mr. President, Algeria welcomes the presentation of the strategy for financing the future of health in the WHO, African regions, 2026-2035, and wishes on this occasion to highlight the significant financial efforts made by the Algerian government to strengthen and sustain its national health system. Mr. President, the financing of the Algerian health system is mainly provided by the government and social security organization, CNAS and CASNOS. The Algerian government covers a large part of the budget for public structures, health infrastructure, and prevention programs, such as free health care in the public sector. Regarding social security organizations, funds like CNAS, National Social Insurance Fund for salaried workers, and CASNOS, National Social Security Fund for the self-employed, ensure reimbursement for healthcare, medications, and benefits for their members. Furthermore, the use of the inter-scheme electronic card, SHIFA, facilitates this flow. The scale of funds allocated to the health sector is reflected through the 2026 finance bill. The health sector is allocated more than $6.8 billion. Algeria also attaches particular importance to the fight against cancer through
Can you please wind up?
Through the mobilization of dedicated resources and the strengthening of financing mechanisms aimed at improving patient care. This measure illustrates Algeria's approach of mobilizing additional domestic resources for health while using taxation as an instrument for prevention and for combating
Thank you,
risk
Algeria.
factors.
Thank you.
Finally, Algeria stands ready to work within the framework of triangle cooperation to share its experience in matter of financing the health sector, taking into account the strategy for financing of the WHO African region. Thank you.
Thank you. Can we now have Malawi?
Thank you very much, Mr. President. Malawi endorses and adopts the strategy for financing the future of health in the WHO Africa region, 2026-2030. The National Health Financing Strategy, that's the Malawi strategy, 2023-2030, aligns with the strategy, this strategy that we're discussing. The health financing strategy aims to set a well-governed health financing architecture that can mobilize adequate resources, distribute the resources efficiently and equitably, and strategically purchase services based on a well-defined benefit package in pursuit of our UHC goals. Within the 2019-2022 National Health Accounts Report, the Malawi report, government has committed to annually reduce donor dependence for funding the health sector. Current rate stands at close to 50%, 47.3%, reducing out-of-pocket health expenditure which has increased from 11 to around 14%, and further invest in our primary health care. Furthermore, Malawi is pleased to report that under the health financing strategy, the country has progressed the reform on direct facility financing, which dedicated budgetary allocation in the 2026-2027 National Health Budget, and all our 29 districts are being funded. This reform is critical to improving the health facility responsiveness to critical needs. Malawi is committed to increasing its domestic resource mobilization towards a government-led and financed health sector, and to attain its health financing and UHC objectives and goals. Finally, in this regard, the country has established its National Health Fund, approved by Parliament already, to improve domestic resource mobilization, pool health resources sustainably, and reduce heavy reliance on external donor funding. And Malawi will continue to strengthen financial protection. Thank you.
Thank you. Thank you, colleagues, for your valuable interventions. I understand that several non-state actors have requested to deliver statements on this agenda item, and they are now invited to do so. We will start with African Society for Laboratory Medicine. You have the floor, and please note that strictly 1 minute.
Thank you, Chairperson. The African Society for Laboratory Medicine, ASLM, welcomes and supports the strategy for financing the future of health in the African region. Health security cannot be sustained without sustainable investment in diagnostics and laboratory systems. Diagnostics are often strengthened during emergencies, but underfunded afterwards. This cycle must change. ASLM is working with countries to generate evidence on the value of diagnostics, strengthen laboratory systems, and define essential diagnostic services packages that can help countries prioritize investments even in resource-constrained settings. We encourage member states to place diagnostics and laboratory systems at the center of domestic health financing as a strategic investment in preparedness, resilience, and better health outcomes. Thank you.
Thank you. Now we have United to Combat, MTDs.
Chair, Excellencies, Uniting to Combat Neglected Tropical Diseases welcomes WHO-AFRO's strategy for the financing the future of health, with the emphasis on sustainable financing, country ownership, and building more resilient health systems. Achieving sustainable financing will require a range of complementary approaches, including domestic resource mobilization, stronger public financial management, innovative financing, continued party engagement, and more efficient use of existing resources. The recent UN Human Rights Council resolution on neglected tropical diseases should be seen as an important contribution to this agenda. By eliminating neglected tropical diseases, we can deliver benefits not only for health, but also for education, productivity, gender equality, employment, and economic development. It provides ministers of health with a stronger platform to engage colleagues across government around shared national priorities. Uniting looks forward to supporting member states who have and
Can you wind up?
partners
Thank
into
you.
the future. Thank you.
Can we now have NCD Alliance? Please, strictly 1 minute.
The NCD Alliance of the Africa NCDs Network welcomed the strategy for financing the future of health in the African region. NCDs cause 75% of all deaths worldwide, yet receive only an average of 2% of ODA for health. Financing the future of health in Africa without a clear, ambitious, and accountable NCD financing strategy, including taxes on tobacco, alcohol, and sugar-sweetened beverages and UHC benefit packages that cover essential NCD services and medicines, will leave the region far from achieving SDG 3, 4, and the UHC. We therefore call on member states to set clear domestic financing targets with explicit budgetary benchmarks, implement the Abuja Declaration and allocate at least 15% of national budgets to health, increase domestic revenue for health through implementation of excise taxes on unhealthy goods in line with the WHO's NCD best buys and WHO's 3x35 initiative, expand primary health care, increase equitable access to medicines and medical services, and integrate NCD services within existing health programs for HIV and TB to maximize resources and address comorbidities. Thank you.
Thank you. Can we have World Heart Federation?
Honorable Chair, distinguished guests, cardiovascular diseases impose a significant economic burden on individuals and households in the African region. As such, universal health coverage is critical to ensure equitable and widespread access to essential cardiovascular health services. To achieve universal health coverage, health systems must be built on a foundation of sustainable financing, strengthened primary health care, and robust cross-sector collaboration. Therefore, we urge member states to adopt and implement the strategy. In particular, to accelerate progress towards UHC through robust and well-financed primary health care systems and ensure accessibility, affordability, quality, and equity, integrate evidence-based cost-effective cardiovascular interventions into national UHC benefit packages, drawing from WHO's NCD's best buys, and develop or strengthen national cardiovascular health plans to secure sustainable funding and expand across the continuum of cardiovascular care, drawing from World Health Federation's framework for cardiovascular health action plan. Thank you, Chair.
Can we have International Federation of Pharmaceutical Manufacturers and Associations? Please stick to 1 minute.
IFPMA welcomes the strategy for financing the future of health in the WHO African region and its focus on sustainable, efficient, and inclusive financing systems to advance UHC, financial protection, and improved access to quality care. We strongly support its objectives to strengthen national health financing systems, improve equitable and efficient resource use, reduce out-of-pocket spending, reinforce governance and accountability, and integrate health financing into national and regional development agendas. We welcome the emphasis on accountability and stronger health financing capacity to support evidence-based decision-making and strategic purchasing. Stronger coordination between ministries of health and finance anchored in joint planning is essential to align funding with national priorities, improve efficiency, and maximize the impact of available resources. The innovative pharmaceutical industry stands ready to contribute through partnerships, innovation, and expertise that support access to quality assured medicines, vaccines, diagnostics, and health technologies. I thank you, Chair.
Thank you so much. Can we have West African Alcohol Policy Alliance?
Monsieur le Président.
Chair, honorable ministers, distinguished delegates, the West African Alcohol Policy Alliance applauds the strategy for financing future of health in the WHO African region. We congratulate the regional office for having supplied a roadmap to deal with fiscal pressures because of declining ODA and also because of the high expenditure faced by countries in the region. Taxes on alcohol, tobacco, and sugar are important mechanisms to mobilize domestic resources to promote sustainable financing of health. Taxation is one of the most efficient policies of WHO to also generate additional resources for health. Well-designed taxes, well-thought-out taxes can lead to less harmful consumption, promoting health and helping achieve UHC. We urge member states to implement tax policies linked to alcohol to allow for more measures to do with prevention. We encourage member states to prioritize the fight against alcohol and include it in public financial management with a view to the pursuit of UHC. Thank you.
Stipulated time of 1 minute, please. Can we now have Stitching Farm Access International?
Chair, Excellencies, Farm Access commends the strategy for anchoring health financing in country leadership, sustainability, and innovation. We welcome its call to mobilize private sector financing and de-risk private investment. This is crucial given that about half of care continent-wide is delivered privately, including for the poor. This private sector capacity is underfunded and uneven in quality, but if financed and accredited, it can support UHC through public-private partnerships. Our Medical Credit Fund, founded in 2009 as Africa's first impact fund for health SMEs, proves the business case for financing and delivering quality primary care to millions in the informal sector. MCF has dispersed 200 million euros in loans to 2,500 primary healthcare providers at a 95% repayment rate. In collaboration with internationally accredited safe care standards, it has revitalized primary care delivery for the poor. And using mobile technology for collateral-free loans, it has also advanced financial inclusion for female health entrepreneurs, the backbone of Africa's healthcare delivery system. This is the blended finance and innovation this strategy calls for, and we stand ready to share our experiences and support this strategy. Thank you.
Thank you so much. Can we have Drugs for Neglected Diseases Initiative?
Thank you, Chair. DNDi welcomes this strategy and asks that it address how R&D for neglected patients is sustained. Market incentives alone fail to deliver innovation for diseases that primarily affect vulnerable and underserved populations. The Lusaka Agenda, in its fifth shift, provides strong entry points through its commitments to fund preparedness to allocate resources based on disease burden, poverty, and needs of underserved populations. These principles should also guide investments in health innovation. We therefore encourage member states to recognize neglected disease research and development as a regional public good, support collaborative and not-for-profit innovation models, and commit to sustainable financing. To ensure investment deliver public benefit, public-funded R&D must include conditions including affordability, knowledge, technology transfer, and to speed innovation and ensure access. Thank you.
Thank you so much. Can we have Federation of African Medical Students Association?
Honorable Chairperson, distinguished delegate, the Federation of African Medical Students Associations, FAMSA, representing over 220,000 medical students across Africa, welcomes the strategy for financing the future of health 2026-2035. The region faces a projected 30% decline in external assistance and out-of-pocket spending at 35%. Well above the WHO benchmark, underscoring the urgency of domestic resource mobilization. FAMSA calls on member states to establish independent national health trusts, self-replenishing public entities, potential structures as public business to generate sustainable domestic revenue insulated from annual budget cycles and donor volatility through earmarked health taxes, pooled contributions, and reinvested returns. This model aligns with the strategy's revenue-raising and pooling objectives, and we urge the committee to consider it as member state advanced domestic financing reforms. Thank you.
Thank you so much. Can we have International Pharmaceutical Students Federation?
Honorable Chair, distinguished delegates, the International Pharmaceutical Students Federation, representing over 600,000 pharmacy students and recent graduates globally, recognizes that sustainable health financing is essential to achieving universal health coverage in Africa. IPSF has been actively engaged in policy and advocacy engagements on health financing and universal health coverage, recognizing the importance of equitable access to healthcare for all. These advocacy efforts have been key to educating our member organizations about the importance of health financing and identifying key gaps in their respective countries. We therefore call upon member states and stakeholders to prioritize financing for health and essential medicines and reduce out-of-pocket expenditure. Governments should invest in the health workforce and establish opportunities for regional youth dialogues in policy formation and implementation. Financing health is not merely an economic decision, it's an investment in health and equity, ensuring that no patient is left behind because they cannot afford the medicines they need. Thank you.
Thank you. Can we have Movendi International?
Movend International welcomes the strategy's call to advance pro-health taxes, especially alcohol taxes, to reduce healthcare burden and costs and raise additional funds for fair, resilient health financing for our region. As external assistance is set to continue falling and creative care already receives 2.4 times more funding than prevention, alcohol taxation offers exactly the domestic health-first revenues this strategy needs, preventing harm, reducing costs while building fiscal self-reliance. Movend International analysis of alcohol taxation best practices shows how countries are succeeding. We call on member states to prioritize alcohol excise tax reform as core to this financing strategy. We call on member states to prioritize alcohol excise tax to reform as core of this member financing strategy and call on WHO to fulfill its commitment to partner with civil society in advancing it. Movend International stands ready to help build the investment case for alcohol policy in our joint effort. Thank you.
Thank you, Movendi. Can we now have Public Services International?
Thank you, Chair. The world has changed since the last strategy adopted in 2006. The global financial crisis reveals the structural flaws of neoliberal political economy that has informed health financing in Africa since 1981. Unfortunately, corporations and wealthier countries continue to normalize this failed global system, which is at the heart of the structural weakness and fiscal pressures identified in the draft strategy. PSI supports the strategy's principles stand for national ownership and sovereignty over health financing. We urge member states to live up to the Abuja Declaration and commit resources to where it matters most. We further call on member states to be wary of for-profit private interests and eschew the commodification of healthcare. Only public spending and governance of healthcare delivery can put people over profits and ensure universal access to quality healthcare. I thank you, Chair.
Thank you. Thank you so much. Can we have International Federation of Medical Students Association?
Honorable Chair, Your Excellencies, universal health coverage cannot be achieved when seeking healthcare itself drives people into poverty. The International Federation of Medical Students Association, representing 123 national member organizations and over 1.5 million medical students across the globe, underscores the importance of this strategy and requests member states to prioritize sustainable domestic financing, protecting people from financing hardship, alongside stronger public financial management to ensure resources translate into equitable access and quality care. We further call for routine tracking of health expenditure and financial hardship to inform transparent financial decisions on national and regional levels. Health financing reforms must meaningfully engage civil society, academia, and young people as partners in shaping sustainable health systems. As future health professionals, we need health systems where access to essential care is determined by health needs, not the ability to pay. Health for all requires financing that leaves no one behind. Thank you.
Thank you so much. Can we now have International Planned Parenthood Federation?
Thank you, Mr. Chair.
IPPF Africa Regional Office welcomes the financial framework and the strategy and commends WHO for this. As countries implement this strategy, IPPF urges that sexual and reproductive health and rights, or SRHR, be recognized as a core component of the investment. With declining external assistance and growing fiscal pressure, sustainable domestic financing for SRHR is essential to safeguard progress so far made in maternal, child, and adolescent health. We welcome the strategy's emphasis on reducing out-of-pocket spending, strengthening primary health care, and protecting vulnerable populations. These reforms provide an opportunity to fully integrate comprehensive SRHR services into national benefit packages and public financing mechanisms. Mr. Chair, financing the future of health in Africa will only succeed if it includes financing sexual and reproductive health services and rights for all people. I thank you.
Thank you so much. And now we have African Leaders Malaria Alliance. You have the floor.
I thank you, Honorable Chair, Honorable Ministers. The African Leaders Malaria Alliance welcomes this strategy and commends the Secretariat. The strategy sets a solid framework for the development of a country-specific national sustainable financing plan. We urge countries to include national health councils and funds in these plans. Our experience with End Malaria and NTD councils and funds, which are country-owned and country-led multi-sectoral forums to accelerate progress in the fight against malaria and NTDs, has been promising, mobilizing over US $240 million in a very short period of time. The councils bring together multiple government ministers, chairs of relevant parliamentary committees, private sector chief executives, philanthropist leaders, traditional and religious leaders, and civil society.
I think you have to wind up.
By complementing existing structures and partners, the councils will ensure that health priorities are prioritized across all sectors and that they have adequate financial and in-kind resources to implement necessary interventions. I thank you, Mr. Chair.
Thank you. Thank you all for your contributions. I see no more requests from the floor. Are there any comments from Secretariat?
Thank you very much, Chair. And again, I'd like to acknowledge the comments, recommendations, commitments that have been expressed by the 32 member states that took the floor to comment on this agenda item, as well as 15 non-state actors, our partners in these efforts. Several specific asks and questions have been put forward for us to consider. We have taken. We're looking at the requests for continuing technical assistance and accompanying as countries transition towards more local, more domestic-based financing, but also all those models that need to be put in place. We note the request to pay attention to the, special needs countries such as the SIDS. The Honorable Delegate from Ethiopia, you had very clear requests on areas that we would need to incorporate for the technical completeness of the text that we have. We take those into account. The Honorable Delegate from Namibia, with the request for us to include in our reports in future measures to support countries in that the advocacy. Of course, this is something that when countries engage in bilateral agreements in debt, it is usually outside the remit of the health sector. So as the Secretariat of the World Health Organization, of you member states as the World Health Organization, we have to work together on seeing how through a health sector government-led process, these discussions can be brought to the ministers, the finance ministers, planning ministers that usually engage in those agreements. So we have to work with you. We will accompany the member states. The leadership has to be at the government level. So, but we are here and we are ready to see how that can be done, because we have to work on all fronts to try and achieve the benefits for health that have been jeopardized because of some of those arrangements. So we've taken note of all the comments, and we're going to be making these documents, bringing them up to date based on the recommendations, and also standing ready to work with you as we move forward on the implementation. Thank you very much, Chair.
Thank you. The Secretariat has taken note of the comments raised. Is the Regional Committee ready to adopt the resolution contained in AFR/RC76/WP3, which includes the adoption of the strategy for financing the future of health in the WHO African region, 2026 to 2025, as contained in document AFR/RC76/6. I see no objection. It is so decided.
Distinguished delegate, nous passons maintenant.
Distinguished delegates, let's now move to item 11 of our agenda, namely a regional strategy on regulation of medical products in the African region, 2026-2035. Kindly refer to document AFR/RC76/7 and the accompanying resolution contained in document AFR/RC76/WP4. The documents will be presented by Dr. Onyango, Director of the Health Systems and Services Cluster.
Promise that this is the last time I'm signing out to present a paper to the regional committee. So as the slides come up, thank you. On behalf of the Secretariat, I am privileged to introduce document AFR/RC76/7, Regional Strategy on Regulation of Medical Products in the African Region, 2026 to 2035, and the associated resolution in document AFR/RC76/WP4. The purpose of the strategy is to support member states to achieve mature, efficient, and harmonized regulatory systems that ensure timely access to quality assured, safe, and effective medical products in the African region. Next slide. The context in which this is happening is we need the strengthening of systems for regulating medicines, vaccines, diagnostics, and medical devices in order to improve access to safe, effective, and quality products. The strategy builds on achievements from the 2016 to 2025 strategy, including progress in regulatory harmonization, WHO benchmarking, and the establishment of the African Medicines Agency, AMA. A stronger and harmonized regulatory ecosystem is essential to improve access to quality assured medical products, support local manufacturing, protect populations from substandard and falsified products, and strengthen Africa's preparedness for future health emergencies. I think if you attended, and I'm sure most of you did attend, the Monday ministerial dialogue, some of these ecosystem needs became very clear from the presentations that were made and the discussions that ensued. So I think that was an excellent preparation for this. So we will not be talking about things that are new as we go through the rest of the strategy, and we go to the slide 3. So what are our key challenges, the challenges that are being addressed by this strategy? First is the fragmentation. Next slide, please. Thank you. First is the fragmented regulatory systems across African countries. Then within countries, most national regulatory authorities are below WHO maturity level 3. We are still experiencing shortages of skilled personnel and insufficient funding to increase their capacities and strengthen our regulatory environment. Limited digitization and uptake of technologies in the sector, technologies that would help us to facilitate the review processes, assessment processes, and institution of changes that would make a robust system. Challenges in legal and governance frameworks, and of course, at the end of the line, the continued circulation of substandard and falsified medical products with the cost that that has in human health and sometimes human life. Next slide. So what are the recommendations that we're putting forward in order to address these challenges? First, strengthening legal, governance, and policy frameworks aligned with international standards, building stronger and more autonomous national regulatory authorities equipped with appropriate technologies to enable them to conduct their work, expanding regional harmonization activities and reliance mechanisms through the African Medicines Agency and the regional economic communities, strengthening surveillance and control of substandard and falsified medical products, medical and other, improve emergency preparedness and expedited regulatory pathways that will help us to respond to emerging situations that need rapid identification of medical measures, and ensuring sustainable financing and political commitment from member states. So, what are the key activities then that we would like to propose for member states to consider in the next slide? The Secretariat invites member states to consider the following strategic actions: to introduce policy changes and investments that will enhance capacities of the national regulatory authorities, facilitate regional regulatory harmonization and convergence by ensuring that legal systems support reliance and recognition so that we can work across borders, and that also includes the ratification of the AMA Treaty. Invest in appropriate technologies and ensure that digital platforms are compatible so that we can work more seamlessly within countries but also across countries as we look to continental harmonization. Provide sustainable financing and political commitment to the implementation of this strategy. So, to conclude, on behalf of the Secretariat, I submit the strategy and the associated resolution for the regional committee's consideration and adoption. Thank you.
Merci, Dr. Onyango.
Thank you, Dr. Onyango. I now open the floor to member states from the African region for their interventions.
La Guinée, vous avez la parole.
Guinea has the floor, followed by Kenya. Kenya, get ready. Mr. Chair, ladies and gentlemen, Excellencies Ministers, distinguished delegates, Guinea supports the regional strategy on regulation of medical products 2026-2035, very important for UHC and health security. Within the Simendo 2040 reforms, we are transforming our national directorate for pharmaceuticals and medicines. It's going to become an autonomous regulatory agency that we're going to strengthen. Digitalization has become our priority for transparency and interoperability. Furthermore, Guinea is investing in local production with three pharmaceutical structures supported by this new mechanism. Health security is at the center of our strategy, amongst others. Digitalization made easy, control will strengthen our sovereignty, and the sovereignty will guarantee the continent's autonomy. We are fighting illicit products, substandard and falsified products with secure withdrawal and destruction of these products. Three things: you have to support countries so that they can go to a regulatory maturity, promote a dematerialization and interoperability, joint assessments and sharing of information, and also reciprocity should be promoted. Guinea says that we have to avoid having two levels of implementation. WHO and partners should support countries that are less mature with clear budgeted or costed plans. Pharmaceutical regulation is an strategic investment for the safety of patients, local production, and Africa's health sovereignty. Thank you.
Le Kenya, vous avez...
Kenya has the floor. Ghana, get ready after Kenya.
For the presentation, 39 regulatory authorities worldwide have WHO-listed authority status, but none is in Africa. This demonstrates why a regional strategy on regulation of medical products 2026-2035 is important. Kenya supports the strategy and the accompanying resolution. Effective regulation is not red tape. It is essential for local manufacturing, market access, and health security. Kenya ratified the African Medicine Agency in 2023 and is investing in local production through the Kenya Biovax Institute. However, we still import 70 to 80% of our pharmaceuticals. This makes a strong case for regulatory system a national priority. Kenya also recognizes its own regulatory challenges. The Pharmacy and Poison Board has not yet attained ML3. Achieving ML3 for medicines and vaccines is therefore our central objective, and supporting the commercialization of locally manufactured products and the eligible under the eligible for United Nations procurement. Kenya proposes 5 priorities. First, the strategy requires concrete and costing financing, including dedicated budget line, ring-fence regulatory fees, and implementation plans. Second, reliance, joint assessment, and joint inspection must preserve the legal responsibilities of national authorities. Third, baselines and complete monitoring framework should be established by 2027, allowing for meaningful reporting from 2028. Fourth, countries below ML3 should receive differentiated and practical institutional support. Fifth, medical devices, in vitro diagnosis, blood products, and biotherapeutics should receive proportional attention alongside medicines and vaccines. These proposals will strengthen, not weaken, the strategy. By 2025, Kenya hopes that an African regulatory authority will achieve WHO-listed authority status. Kenya is committed to making that a reality. I thank you.
La parole au Ghana.
Ghana has the floor. Niger will follow.
Thank you, Chair. The strategy provides an important framework for strengthening regulatory systems, advancing harmonization and reliance, and ensuring access to safe, effective, and quality-assured medical products across Africa. Ghana is proud that the Food and Drugs Authority has attained WHO Maturity Level 3, reflecting sustained investment in regulatory governance, quality systems, and human resource capacity. This has strengthened public protection while supporting local pharmaceutical manufacturing and regional market access. We are further strengthening the link between regulation and local production through the no registration, no importation policy, exports certification, and the GMP roadmap under the PharmaVax Ghana program. Ghana will continue to strengthen digital regulatory systems, quality management, and human resource capacity towards maturity level 4 and ultimately WHO level listed authority status. Support regional harmonization, reliance, and joint work sharing, including through the African Medicines Agency, and promote regulatory systems that support local manufacturing investment and access to medicines and vaccines. Chair, successful implementation will require sustained domestic financing, stronger regional cooperation, and predictable technical support. We endorse the regional strategy and reaffirm Ghana's commitment to working with WHO, the African Medicines Agency, and member states to strengthen regulatory systems and ensure access to quality medical products across Africa. Thank you, Chair.
Niger, followed by Mozambique.
Monsieur le Président.
Thank you, Chair. Niger, Lords, the preparation of the regional strategy on regulation of medical products in the African region and reaffirms its commitment to strengthening its national regulatory system under the Nigerian regulatory body for the pharmaceutical sector. We have been able to do good regulatory work in the country, focusing on the Horizon 2035. We are firmly convinced that we need to achieve regulatory maturity, which is a pillar of health sovereignty, with a view to reaching a mature regulatory level, one that is performing and digitalized. We are looking towards the horizon of 2035 so that we can reach ML3 level. We need to accelerate digital transformation, harmonize with regional and sub-regional mechanisms, consolidate pharmacovigilance and oversight with a view to guaranteeing sovereignty in this field. In order to achieve this, we need to mobilize budget resources, guarantee twinning, mentoring, pharmacovigilance, post-marketing surveillance, working with AMA and at the Africa CDC. We need to ensure there is a sharing of regulatory data with certain bodies in the private sector, civil society, and the academic world, which is in line with the regional strategy. We already have done a lot of work that is in line with the regional strategy, converging with the WMOA strategy, and also with the work being done by the African Medicines Agency. We support the regional strategy on regulation of medical products. Mozambique, you have the floor, and we invite other member states to do the same. Thank you. Thank you very much, Chair. Thank you for giving us the floor. The Regional Strategy on Regulation of Medical Products in the African Region 2026-2035 has ambitious targets, including the increase in the number of NRAs of ML3 level. We're very proud as a country to have achieved this target, and our new target right now is to get to ML4 level. Expanding digital systems to produce reports and also preparing for public health emergencies are other targets. We fully support the targets laid down and believe that achieving these requires political leadership, sustainable financing, constant capacity building of human resources, and close collaboration between member states, the WHO, AMA, the regional economic communities, and development partners. Allow me to restate the Mozambican government's commitment to continue investing in strengthening the institutions involved in regulatory activities and modernizing systems, including digitalization of services, post-marketing surveillance, and active participation in continental and regional mechanisms for harmonization. And this strategy is a historical opportunity for us to consolidate a stronger African regulatory culture, one that is resilient and long-lasting. We firmly support the approval of this regional strategy. Thank you.
La parole est au Congo.
Congo has the floor, and then Comoros, followed by Gambia. We would like to congratulate the Secretariat for having included the Regional Strategy on Regulation of Medical Products in the African Region 2026-2035 on the agenda. This initiative is very important for our region in a context where the availability, safety, and efficacy of medical products are fundamental in order for us to protect our population's health and also strengthen health sovereignty in our countries. Like other member states, we are working at a regional and sub-regional level to strengthen our pharmaceutical sector, working with the regional economic regional body and the WHO. Self-benchmarking is important, and this has allowed us to identify measures that are required to strengthen our pharmaceutical regulatory system, such as certifying medical products, pharmacovigilance, quality control, and licensing. This is part of a structured national plan. We have a plan for medical products 2025-2030, a national pharmaceutical policy, and a master plan, as well as a medical supply center. We accord extreme importance to combating falsified and substandard medical products. We are committed to, at the highest level, ratifying the AMA Treaty, which we did in 2022, and we have also started collaborating more with other countries and institutions, working towards pooled procurement, focusing also on local production of medicines. There are still, however, operational challenges when it comes to capacity building requirements, which is why thank you very much. We are in line with the strategy. Comoros has the floor. Thank you very much, Chair. The Union of Comoros would like to thank the Secretariat for drafting this regional strategy on regulation of medical products in the African region 2026-2035, and we support its adoption. For Comoros, strengthening the national regulatory system for medical products is fundamental when thinking about the pursuit of UHC and health security, but implementing such a system requires technical support and financial support in line with the requirements of small island states. We are paying we believe that special attention should be paid to small island states in helping recognize the decisions made by reference authorities and also by AMA. Technical support and financial support to improve the legal framework and regulatory measures and pharmacovigilance, as well as post-market surveillance. Digital solutions should also be found in proportion with national capacities. We need rapid access, safe access to quality medical products, especially in emergency situations. We therefore fully support the strategy and the accompanying resolution and encourage all to equitably implement it. Thank you.
La Gambie, vous avez la parole.
The Gambia, you have the floor. Zambia will go next.
Thank you, Chair. The Republic of the Gambia commends WHO AFRO for developing this strategy and fully supports its adoption. The strategy provides a timely framework to strengthen regulatory systems and promote equitable access to quality, safe, efficacious, and affordable medical products across the region. The Gambia has made important progress through the Medicine Controls Agency and collaboration with regional and international partners. The country has also benefited from regional harmonization initiatives and WHO-supported capacity building programs, which have strengthened regulatory functions, quality assurance systems, and inspection capabilities. The Gambia therefore supports the strategy's call for investment in workforce development, institutional strengthening, data-driven regulatory decision-making, and participation in regional joint assessments, inspections, and reliance mechanisms. We encourage WHO, the African Medicines Agency, and partners to continue supporting member states through technical assistance, training, benchmarking, and stronger regional regulatory networks. In conclusion, the Gambia fully endorses the adoption of this resolution and reaffirms its commitment to working with WHO, the African Medicines Agency, member states, and partners to build stronger, more resilient, and effective regulatory systems that ensure timely access to safe, quality-assured medical products for all. Thank you.
Merci, la Gambie. Zambie, vous avez la parole. Le Zimbabwe se prépare.
Honorable Chairperson, Zambia commends the Secretariat for the comprehensive regional strategy on the regulation of medicine products 2026-2035. The strategy reaffirms our commitment to strengthening national regulatory capacity in line with its objectives. Zambia Medicine Regulatory Authority, ZAMLA, continue to advance regulatory reforms guided by the World Health Organization Global Benchmarking Tool. Following our most recent self-assessment, Zambia was placed at maturity level 1, largely due to legal framework gaps now being addressed through the pending Medicine and Allied Substance Bill. Of the 317 identified institutional development actions across regulatory guidelines, standard operating procedures, and human resources, over 70% have now been completed. Zambia is targeting attainment of the maturity level 3 by 2027. We continue to strengthen regional and continental collaboration through the Tazewona Initiative and active engagement with the African Medicine Agency. Zambia is also fostering local manufacturing through 11 operational facilities producing essential medicine, including antimalarials, antibiotics, antiretrovirals, and intravenous fluid. Zambia support mechanism including pre-licensing, technical assistance, risk-based inspections, and international partnership that are helping address
Merci.
financing skills
Merci,
and
la Zambie.
infrastructure.
Le Zimbabwe a la parole. Le Sénégal se prépare.
Thank you, Chair. Zimbabwe welcomes and appreciates the development of the regional strategy on regulation of medical products in the African region 2026 to 2030. We commend WHO and member states for advancing a common framework to strengthen regulatory systems, promote local manufacturing, accelerate access to quality assured medical products, and combat substandard and falsified products. Zimbabwe's experience demonstrates the value of sustained investment in regulatory capacity. The Medicines Control Authority of Zimbabwe has attained WHO Global Benchmarking to Maturity Level 3 and has since been assessed for Maturity Level 3, with the country eagerly awaiting that outcome. This progress complements our national ambition to expand local pharmaceutical production, reduce import dependence, and position Zimbabwe as a regional hub for quality assured medical products. We have also made practical progress in reliance, including fast-track pathways for products approved by trusted regulatory authorities, while strengthening post-marketing surveillance and digital regulatory systems. Through the Maturity Level 3 National Regulatory Authorities Reliance Mechanism, currently chaired by Medicines Control Authority of Zimbabwe, Zimbabwe is contributing to closer regulatory cooperation and information sharing across Africa. Mr. Chairperson, as we move towards implementation, Zimbabwe wishes to see this strategy translated into practical support for member states. We encourage expanded reliance mechanisms, stronger continental information sharing on substandard and falsified products, coordinated investment in digital regulatory systems, and sustained support for regulators and local manufacturers. Zimbabwe remains fully committed to this agenda and stands ready to share its experience and work with WHO, African Medicines Agents, and fellow member states to ensure that the strategy delivers tangible results for Africa. I thank you.
La parole au Sénégal.
Senegal has the floor, followed by Burkina. Chair, Senegal welcomes the regional strategy on regulation of medical products 2026-2035 and congratulates the Secretariat for the quality of its work. The Senegalese NMRA has reached level 2 maturity and has therefore become the first Francophone country to reach this target. Institutional reforms based on strengthened governance, better procedures, greater transparency, and qualified human resources. All of this allows for our regulatory system to become more credible, favors local production, and allows us to work towards becoming a recognized regulatory body in the eyes of WHO. We have also carried out our own evaluation with the help of WHO for the regulation of medical devices, in vitro diagnostics, and blood products. Chair, we are in line with the guiding principles of the strategy. We salute the emphasis on independent decision makers based on risk analysis and encourage WHO to monitor closely these complex reforms. We think we should continue to work with the regional economic communities, AMA, and other institutions, and we are fully aligned with this effort. Fighting against substandard and falsified products is also a priority in terms of public health. We are also in line with continental regulatory convergence, and we thank you for your attention.
La parole est au Burkina Faso.
Burkina Faso has the floor, and then Burundi will follow. Thank you, Chair. Chair, the delegation of Burkina Faso would like to thank the Secretariat for the high standard of the documents submitted and welcomes the regional strategy. Burkina Faso is continuing to strengthen its regulatory, quality control, and market surveillance framework. In 2025, 485 products were inspected with a compliance rate of 93%, and 31 reports of quality defects were processed. Our country has also adopted a national strategic plan to combat substandard or falsified medical products. Institutional strengthening took a strategic turn in 2026 with the creation of the FASO Food and Drug Administration, FASO FDA, resulting from the merger of the National Pharmaceutical Regulatory Agency and the National Agency for Health Safety to improve efficiency. Burkina Faso attaches particular importance to post-market surveillance, traceability, information sharing, and the fight against informal and illicit supply chains. Our country also supports regulatory harmonization, cooperation with AMA, which are essential for local production, technology transfer, and pharmaceutical sovereignty. Finally, Chair, our delegation supports the adoption of the Regional Strategy 2026-2035 and encourages the WHO to assist member states in sustainably strengthening their regulatory capacities so as to ensure equitable access to safe, effective, and high-quality medical products. Thank you for your attention. Burundi, you have the floor, and then Mali. Chair, Burundi congratulates WHO for drafting this regional strategy. We believe this strategy is an important step forward to ensure access to safe, efficient, and quality medical products. We are in line with the guidelines proposed and are organizing ourselves nationally to strengthen this regulatory system for health products. We adopted a law that regulates health products inspired on the African Union model law. We have also created an NMRA, and we are currently implementing our strategic plan in line with our national development plan with a view to consolidating technical capacities and also operational capacities. We believe that fighting against substandard and falsified products requires collective action, and so we urge everyone to share information and collaborate, especially when it comes to market surveillance, inspections, controls of products, especially that cross borders. We encourage digitalization of regulatory systems and the creation of interoperable mechanisms that will allow for quick, secure, and trustworthy exchange of information so that the NMRAs can exchange data. We support this strategy and commit to working with member states, AMA, WHO, and other partners so as to strengthen our regulatory systems and thus better protect the health of our populations. Thank you. Mali has the floor, and then Tanzania. Thank you very much, Chair. Mali would like to laud the Secretariat for the draft regional strategy. This is very important in the pursuit of UHC and in order to improve primary health care. It focuses on strengthening our NRAs so that we can achieve the ML levels under the WHO framework. Our national authorities have not yet reached ML3 level and face a number of challenges. Despite the framework we have, the National Laboratory for Accreditation and Control continues to work with WEMOA and AMA so as to undertake reforms that will strengthen our regulatory capacity linked to medical products, post-marketing surveillance, controls of importers and distributors, and accelerating mechanisms for granting authorizations. We also need to continue working on a roadmap, work on legal reforms to strengthen regulation and authorization mechanisms with a view to also improving capacity building in human resources and sustainable financing. Thank you.
La parole est à la Tanzanie et Swahili se prépare.
Thank you, Chair. Tanzania commend the Secretariat and welcome the regional strategy on regulation of health products in the region. At the outset, Tanzania congratulates Mozambique for becoming the 9th out of 47 member states and the 10th in Africa with the NRA operating at WHO ML3. Tanzania is proud to have been the first country in Africa to open the door towards ML3 in 2018 and for sustaining this achievement through a reassessment that was done and announced by WHO in 2025. Now we are investing and improving our systems towards ML4. Chair, Tanzania strongly believes that strong and independent regulatory systems are essential to protect public health and ensure access to safe, effective, quality assured, and affordable medicine, vaccine, diagnostic, and medical devices. This is becoming critical in view of the fact that approximately 22% of the medicines circulating in Africa are reported to be either falsified or substandard. Tanzania welcomes the focus of the strategy on strengthening national regulatory authorities, regional harmonization, digital systems, post-market surveillance, and regulatory preparedness during public health emergencies. Tanzania underscores the need for sustainable domestic financing for regulatory systems, a skilled regulatory workforce, interoperable digital systems, and a close collaboration among member states, regional economic communities, the African Medicine Agency, and the WHO. Tanzania reaffirms its commitment in support of the strategy and is ready to work together with member states towards its implementation by sharing experience so that all people in Africa region can access quality assured medical products. Thank you, Chair.
La parole est à
Eswatini now has the floor. Algeria goes next.
Honorable Chairperson, Excellencies, distinguished delegates, Eswatini welcomes the regional strategy on regulation medical products in African region for 2026 to 2035 and supports both strategy and its accompanying resolution. Chairperson, regulation is invisible to the public until it pays. Every medicine, vaccine, diagnostic, and device reaching a patient in Eswatini depends on a system that is competent, independent, and adequately resourced. Consumer protection is critical as a preventive measure and in defining the extent of negative externalities policies. We are candid about where we stand. Our regulatory system has been assessed at the first of the World Health Organization for maturity levels. The authority envisaged in our own legislation a decade ago is not yet established, and marked entry still rests largely on product listing, which records a product rather than evaluating it, cannot be suspended, varied, or revoked the way an authorization can. Our Medicine Regulatory Authority Board is now established with a mandate to operationalize the authority. Our Central Medical Stores became a state-owned entity under the legislation enacted in 2025, and we fund vaccine commodity procurement entity entirely from our own budget. This is precisely why regional harmonization, reliance, and work sharing matter to us. Reliance is not on abdication of sovereignty responsibility, but the intelligent use of collective capacity. We commit to legal reform, workforce development, infrastructure development, not only for pharmaceuticals, but for health claims, consumer products, and sustainable financing. To completing the ratification of the African Medicine Agency Treaty and to regulatory preparedness for emergencies.
La parole est à l'Algérie.
Algeria has the floor.
Of the Kingdom of Saudi Arabia is support.
La parole est à l'Algérie.
Algeria has the floor.
Et l'Angola se prépare.
Angola can prepare.
Thank you, Mr. President. Algeria considers the strengthening of regulatory systems an essential lever for ensuring that our populations have access to safe, effective, and quality-assured medical products, while at the same time consolidating our health and industrial sovereignty. In this regard, we would like to highlight three priorities. First, to continue regulatory harmonization and convergence across Africa by strengthening trust, the sharing of expertise and mutual recognition among regulatory authorities. Algeria reaffirms its full support for the African Medicines Agency, AMA, in advancing this process. Second, to promote regulatory harmonization alongside the development of sustainable local and regional pharmaceutical production. The Algiers Declaration on Local Production provides an important reference in this regard, particularly with respect to technology transfer, the strengthening of industrial and regulatory capacities, and regional cooperation. Third, to continue strengthening the maturity of national regulatory authorities with the objective of enabling more African regulatory authorities to achieve WHO Maturity Level 3, thereby better ensuring the quality and safety of medical products and combating substandard and falsified products. Finally, Algeria calls for the coordinated implementation of these efforts with the initiative of the African Union, particularly thus of the AMA and Africa CDC, and reaffirms its full readiness to contribute to these collective efforts towards a more integrated, more resilient, and more health sovereign Africa. Thank you.
La parole est à
Angola has the floor. CAR next. Thank you very much, Chair. The Angolan delegation thanks the Secretariat and congratulates them for drafting the Regional Strategy on Regulation of Medical Products 2026-2035. We consider this to be essential to ensure access to safe, affordable, quality-assured products contributing to UHC and health security. We support the strategy and the accompanying resolution, recognizing the importance of strengthening regulatory systems, harmonizing regionally, and strengthening AMA. Allow us to share with you briefly the experience of our country. In 2021, Angola set up the Angolan regulatory body for medical products and health technologies, which has been important in strengthening regulation of the pharmaceutical sector at a national level. Under its National Development Plan for 2023-2027, we have seen great progress, namely revision and updating of the legal framework, including legislation on medicines and medical devices, implementation in 2023 of the integrated system for medical registration in Angola, digital and electronic registration of medicines, and also improving of our national pharmacovigilance system. We've reinforced medicines security regulation, and despite this progress, there are of course challenges ahead so that we achieve ML3 level by 2027. In particular, the creation of the National Laboratory for Quality Control for Medicines, capacity building of our human resources, and also improvement in regulatory capacity. We're working hard on this so as to make significant progress in this field. We support the adoption of the Regional Strategy on Regulation of Medical Products 2026-2035 and the accompanying resolution, and reaffirm our commitment to implementing it and encourage the WHO and partners to continue on this path. Thank you.
Merci, Monsieur le Président. La République centrafricaine remercie le secrétariat de l'OMS.
I would like to thank the WHO's Secretariat for the presentation of the regional strategy concerning regulation of medical products from 2026-2035. And would like to commend the relevance concerning quality improvement, security, accessibility of medical products in Africa. CAR acknowledges the progress made in the past 10 years through the various initiatives such as AMRH, comparative analysis, and the creation of AMA. CAR has made significant progress in the field of regulation, notably through the adoption of law number 20012 on medicines, other health products, and practice of pharmacy, joint reviews for the authorization of health products conducted with CEMAC member states, and the transformation of the Directorate of Pharmacy into a medicines agency. which is currently awaiting approval. We have also intensified our fight against substandard and falsified medical products. We believe that implementing this strategy should focus or pay particular attention to technical assistance, training human resources, modernizing infrastructure, digitalization of procedures, strengthening pharmacovigilance, and market surveillance. We also support the quest for greater regulatory convergence and harmonization across Africa, strengthening AMRH, fully operationalizing AMA, and the increased involvement of regional economic communities are, in our view, essential. The success of the 2026-2035 strategy will require, above all, strong political commitment, sustainable funding, and effective coordination between member states, WHO, AMA, the African Union, REX, and TFPs. In closing, the Central African Republic would like to support the adoption of the Regional Strategy on Regulation of Medical Products 2026-2035 and the related resolution. Thank you very much for your attention.
L'Éthiopie a la parole.
Ethiopia has the floor.
Thank you, Chair. Ethiopia welcomes the regional strategy on regulation of medical products in the African region 2026 to 2035 and supports its endorsement together with the accompanying resolution. Access to safe, effective, quality assured and affordable medical products is fundamental to universal health coverage, health security and pharmaceutical sovereignty. We therefore see this strategy as an important roadmap for regulatory strengthening, harmonization, equitable access, and stronger health security across our region. The situation remains challenging, although regulatory capacity is improving. 39 of 47 member states remain below WHO maturity level 3, and none of the globally designated WHO-listed authorities is currently from Africa. These gaps contribute to the circulation of substandard and falsified products and weaken confidence in African markets. Ethiopia is proud to contribute to the solution. The Ethiopian Food and Drug Authority has attained WHO maturity level 3 following formal benchmarking against more than 250 WHO GBT indicators completed in September 2025. Ethiopia sees this achievement not as an endpoint, but as a platform for continued improvement and regional collaboration. Strong regulation is also essential for local manufacturing and technology transfer. Ethiopia's local production now accounts for more than 40% of medicines on our market, while the Kilinto Special Economic Zone is supporting pharmaceutical investment. As we pursue greater African pharmaceutical self-reliance, regulation must be understood not as a barrier to industrialization, but as its precondition. Ethiopia particularly supports harmonization, reliance, work sharing, digitization, stronger post-market surveillance, regulatory workforce development, and expedited pathways for public health emergencies. We are also ready to share our experience in electronic regulatory systems and to collaborate through twinning, mentorship, staff exchange, and joint assessments. Building on our maturity level 3 achievement, Ethiopia will advance towards maturity level 4 and beyond, while supporting other African regulatory authorities on this journey. We therefore fully endorse the strategy and call for sustained political commitment, predictable financing, and collaborative action to turn this roadmap into measurable regulatory capacity and better access to quality assured medical products across Africa. I thank you, Chair.
Merci, l'Éthiopie.
Thank you, Ethiopia. You're lucky because I wasn't really paying attention. Madagascar has the floor. South Africa, get ready. Thank you, Mr. Chair. Madagascar is very enthusiastic when it comes to this regional strategy on regulation of medical products in the African region 2026-2035. Our priorities and efforts are in line with this strategy. In particular, the implementation of our National Institutional Development Plan. We want to move on to level 1 to level 3 by 2030. We are updating our health code, strengthening the legal, technical, and financial authority of the Madagascar Medicine Agency. The REAMS and LIMS programs are being made interoperable to improve traceability and surveillance. Strengthening also early detection and surveillance of substandard or falsified medical products with the WHO network and the national platform Vigit Mobile. Integration within AMA, promoting flexibility based on our national capacity, and respecting the regulatory sovereignty of our country. Madagascar stresses the fact that the implementation of this strategy should definitely take into account the reality of countries that have limited capacities, and therefore there should be a technical and financial support appropriately in order to strengthen our human resources and also to help us when it comes to the lack of specialized regulatory agencies. Let's make health, safety a reality for each and every African citizen together. Thank you. South Africa has the floor. Eritrea, get ready.
South Africa shares the vision of achieving mature, harmonized, digitalized, and sustainable regulatory systems across Africa, as robust regulation is the bedrock of public health protection, fostering local pharmaceutical production, and building mutual confidence in African manufactured health products and continental health sovereignty. Our national experience through the South African Health Products Regulatory Authority demonstrates that structured institutional growth yields tangible results. Having achieved WHO maturity level 3 for vaccines and most medicines regulatory functions, SAPRA is actively advancing on a structured pathway towards WHO-listed authority designation. To turn the 2035 targets of this strategy into reality, South Africa emphasizes 3 critical accelerators. First, sustainable financing and autonomy. Regulatory systems cannot scale advanced functions without predictable, sustainable funding models. We advocate for targeted bridging finance mechanisms, strong political commitment, and optimal revenue retention to support laboratory development, market surveillance, and workforce expansion. Second, digital transformation and reliance. Digital tools such as the ECTD submissions, artificial intelligence screening, and integrated e-RIMS are vital to reducing review backlogs and powering regional work sharing. We urge accelerated cooperation on digital standards and the expansion of reliance pathways. Thirdly, continental harmonization and AMA. South Africa remains deeply committed to the African Medicines Agency, the AMRH initiative, and regional platforms like Zazibona. Operationalizing AMA as a WLA benchmark is essential to eliminating duplication and fast-tracking patient access. Finally, as demonstrated by our recent launch of the National Action Plan Against Substandard and Falsified Medical Products, our ongoing emergency preparedness.
Thank you, South Africa. Eritrea has the floor. So go get ready.
It's lessons learned. Thank you.
L'Eritrea la parole.
Eritrea, followed by Togo.
Thank you, Chair. Eritrea welcomes the strategy and its focus on strengthening national regulatory authority, advancing regulatory convergence and reliance. Eritrea also supports the overall directions of a strategy and endorses its vision of mature, efficient, and harmonized and resilience. At the national level, Eritrea remains committed to protecting public health through efficient oversight of medicines and other medical products. Looking ahead, we will continue to strengthening national regulatory capacity. We call for sustained WHO and partner support through tailored technical assistance, capacity building, laboratory strengthening, regulatory information system, and knowledge sharing among the national regulatory authorities. Finally, Eritrea reaffirms its commitment to working with WHO, member states, partners to build trust regulatory system and ensures equality and equitable access to safety, effective and quality assured medical products for all people of the region. Thank you.
Togo
has the floor. Uganda will follow. Thank you, Mr. Chair. Togo would like to congratulate the Secretariat for the quality of this progress report, noting progress, measures, challenges, and the way forward. Concerning governance, Togo has started establishing a national agency for pharmaceutical regulation with full autonomy in order to have a system to regulate medicines and other health products. We are also aiming at having integrated and stable equipment based on the YMU standards and the 2030 National Health Policy. Togo has also signed the treaty, the AMA Treaty, confirming its commitment towards strengthening the national pharmaceutical regulation framework. We also want to promote regulation in Africa. Concerning the fight against substandard and falsified medical products, in January 2020, we started the Lomé Initiative against the substandard and falsified medical products. We have a national plan 2023-2027 that is being implemented, and this was done with the support of our partners. In order to be effective, we must implement urgent measures so that pharmaceutical regulatory bodies can have reached the necessary maturity level. There needs to be regulatory trust, especially when human resources are very limited. Togo takes note of the report and would like to call on adopting the related resolution. Sorry, thank you.
La parole.
Uganda has the floor, followed by Chad.
Chair, distinguished delegates, previous assessments of our Uganda National Drug Authority by WHO using the global benchmark tool identified regulatory weaknesses related to gaps in the law. Uganda recently enacted the National Drug and Health Products 2026 that addresses the gaps in the previous law and provides a legal basis for enforcing regulatory compliance. Chair, Uganda therefore requests the WHO technical support to re-evaluate our regulatory capacity as we aspire to achieve higher maturity level 3. I thank you.
Chad, you have the floor. Nigeria, get ready. Thank you, Mr. Chair. Chad would like to thank WHO for presenting the Regional Strategy on Regulation of Medical Products in the African region 2026-2035. It is perfectly in line with the challenges and priorities in Chad. We support the adoption of said strategy as well as the accompanying resolution. Chad has signed the AMA Treaty and has therefore taken measures to accelerate the operationalization of this agency. And that is done through strengthening governance of the medicine sector so that the country can have a solid regulatory framework that will guarantee that our populations will have access to medicine, vaccines, diagnosis tools, medical equipment, and blood products that are sure, effective, quality, and affordable. And in 2024, Chad has adopted the Medicrime Convention of the Council of Europe. A ratifying law was voted in 2025. So Chad is committed to aligning its legislation on international and regional norms. We'll be using the global tool for the comparative tool of WHO, and we're going to work on an institutional building plan, budgeted, that will lead us progressively towards ML3. We're also going to strengthen the post-commercialization, surveillance, pharmacosurveillance, quality assurance, and applicable measures for medical emergencies. We would like to call on the WHO, AMA, and REX, as well as partners, call on them to support countries on the technical and financial level. Let it be equitable and based on our fragility. Also, we recommend that the future results framework comprises progressive national targets, comparable indicators, biannual accountability mechanism all the while, support respecting sovereignty of member states, and that will also accelerate convergence. We support the adoption of this strategy. Nigeria has the floor. Nigeria has the floor, followed by Cameroon.
Nigeria welcomes the strategy on regulation of medical products in the African region 2026 to 2035 and fully supports its adoption. In accordance with the strategy, the Nigeria Alcohol Policy and its multi-sectoral implementation plan has been developed and its implementation is ongoing. Nigeria is leveraging existing mandates and regulatory framework across relevant institutions to strengthen alcohol control. Nigeria has 2 model treatment centers providing treatment and rehabilitation services for substance use disorder, including alcohol-related disorder, with data reported through Nigerian Network for Epidemiology on Drug Use. Nigeria urges member states to intensify enforcement of controls on availability, minimum legal drinking age, advertising, marketing, promotion, and drink driving, strengthen national alcohol surveillance and data system for evidence-based decision-making and monitoring, expand access to screening, brief interventions, treatment, rehabilitation, and recovery services for alcohol use disorders, exploit appropriate allocation of alcohol tax revenues to prevention, treatment, rehabilitation, and related health priorities, establish annual country-level monitoring scorecards aligned with the WHO framework to track progress towards the 2028 milestone and 2030 target. We remain committed to fully implementing the strategy and sustaining the gains for the benefit of our people. Thank you, Chair.
Le Cameroun a la parole.
Cameroon has the floor, followed by Mauritania. Mr. Chair, Cameroon would like to congratulate the Secretariat for this quality report. We note the progress challenges when it comes to the regulation of medical products in Africa. Cameroon is highly concerned when it comes to the proliferation of substandard and falsified medical products. It is a direct threat towards the health, safety, and security of our population and hinders access to quality health care in the context of the UHC. Do note that in Cameroon, though efforts were made when it comes to the regulatory framework, national capacities when it comes to certification are limited. 19 out of the 175 products presented in 2024 were rejected due to lack of quality. There are many constraints and challenges, notably control laboratories are limited, lack of intersectoral collaboration when it comes to fighting illegal and illicit products. We would like the national regulatory systems to be strengthened thanks to more international cooperation in the areas of research, technological transfer, pharmaceutical innovation. It is essential that we establish trust that will allow us to identify, exclude, and sanction falsified medical products, and that will help us to ensure access to quality products. And there should be African cooperation when it comes to strengthening local capacity. We need to support national and regional bodies. Thank you for your attention.
La Mauritania.
Thank you. Mauritania has the floor. Followed by Malawi. Thank you, Mr. Chair. Mauritania would like to congratulate WHO for this strategy. It is a pillar for health safety and our health sovereignty. We have many reforms ongoing to strengthen our pharmaceutical regulatory framework. So when it comes to registration, quality control, pharmacovigilance, and the fight against falsified medical products in 2024, an interministerial committee was established, headed by the Prime Minister. We focus on the pharmaceutical sector, adopted a new law, strengthened entry points, safe or secure transportation of medical products, and the national hub for medicines traceability with the important TA from WHO, and we thank you for that. Last month, in collaboration with WHO, we organized an investment forum focused on local production of medicines. There was a Nouakchott declaration as an outcome, and we wanted to work towards a more South-South cooperation in medicine, production of medicines and other products. So we want to strengthen our regulatory framework, digitalize procedures. There will be post-commercialization surveillance, and we want to strengthen or deepen our cooperation with AMA. We fully support the adoption of the Regional Strategy 2026-2035 on regulation of medical products in the African region. Thank you.
Merci. La parole
Thank you. Malawi has the floor.
Thank you very much, Chair. Malawi endorses the regional strategy on regulation of medical products in the African region. Strengthening pharmaceutical and regulatory systems is a priority under our health sector strategic plan 3, which is 2023-2030. And it aims to improve the availability, quality, and rational utilization of medicines and related medical supplies. And we want to balance our 3 Ps, the patients, the products, as well as the personnel, inclusive of the strategy. And of course, the WHO GBT, the benchmarking 2 assessment, which was conducted in 2023 March, it showed that our regulatory authority was operating at a maturity level 1. And of course, the assessment identified the absence of a comprehensive quality management system. And indeed, it's a critical gap impacting the effectiveness and efficiency of the authorities' operations. And following the 2023 assessment, WHO facilitated the development of our national action plan to combat the substandard and falsified medical products by December 2028. It is our hope that through this, we'll be able to transit and move to maturation level 3. And additionally, the country is accelerating digital transformation through digital platforms for reporting substandard and falsified medical products and pharmacovigilance cases, while enhancing real-time information management and regulatory decision-making. These efforts are strengthening regulatory governance, transparency, efficiency, and accountability, thereby contributing to improved access to safe, effective, and quality-assured medical products for the people of Malawi. And Malawi affirms its commitment to further adapt the WHO strategy for ensuring equitable, affordable access to safe, effective, and quality-assured healthy products and technologies. Thank you.
Merci.
Thank you, distinguished delegates. There are no more interventions from our member states. So I'll now like to open the floor to member states from other regions, UN agencies, and other IGOs. I'll invite them to raise their nameplates. I remind you that you have 1 minute. Iran has the floor.
Dear Mr. Chair, thank you so much. On behalf of the Islamic Republic of Iran, I wish to express our strong support for adopting the regional strategy on medical products regulations. We believe that this is a vital step towards health security and self-sufficiency for Africa. While Iran University of Medical Science is an academic institution, we work closely with Iran's established pharmaceutical and medical device industries sectors with GMP compliance productions, WHO-aligned quality standards, and proven export experience to over 20 countries. We see clear opportunities for Iranian companies to contribute meaningfully under this strategy in different levels. One, local production partnership, established joint manufacturing ventures in Africa for medicines, biosimilars, and medical devices, reducing reliance on imports. Second, reliable and affordable supply, provide cost-competitive essentials, drugs, and diagnostics tailored for African public health program. And third is technology and skills transfers, train local workforce in production, quality assurances, and maintenance, building sustainable domestic capacity. IUMS stands ready to serve as a technical and academic bridge supporting regulation.
Thank you, Iran. Malaria Alliance. Amma, get ready.
Delegates, we, the African Leaders Malaria Alliance, commend the WHO Regional Office for the regional strategy on regulation of medical products in the African region. The strategy will improve access to new tools and ensure that substandard products no longer enter our markets. Implementing this strategy, on the other hand, will ensure medical products reach and benefit the communities that need them. We therefore call on countries and partners to urgently operationalize the strategy, ensuring that new technologies such as spatial eminators and gene drive are deployed as soon as they are pre-qualified by WHO. ALMA commits to continuing to leverage ALMA's heads of state and government to drive regulatory harmonization and convergence. We are pleased to note that member states are sharing practical experience on how to move faster within the existing architecture. Lastly, we encourage member states to invest in regional production of medical products as part of our collective efforts to addressing supply chain hurdles. I thank you, Mr. Chair.
The African Medicines Agency has the floor.
Excellencies, AMA welcomes this regional strategy and strongly supports its endorsement. Africa has made significant progress. The next decade must be about connecting and scaling what works. First, strong national authorities and regs must remain the foundation. AMA will not replace NRAs. Together with the WHO, we must continue to strengthen them, building the trust that enables reliance, greater efficiency, and faster access. Second, we must now translate harmonization into genuine reliance, supported by continued domestication of the AU model law. Africa cannot continue repeating the same scientific work country by country. Our direction must be increasingly one application, rigorous scientific review, and multiple markets, and countries retain sovereignty decision-making. Third, connect our systems digitally, continental safety databases for substandard and falsified medical products that enable countries to share information and detect risks. Our next chapter must be coherent, predictable African regulatory architecture where investment and innovation will succeed, that local manufacturers can navigate and patients can experience through faster access to quality assured medical products. AMA is ready to play its part. I thank you, Chair.
Merci.
Thank you. African Continental Free Trade Area has the floor.
Merci à vous.
Thank you, colleagues, for your valuable comments. I understand that several non-state actors have requested to deliver statements on this agenda item, and they are now invited to do so. The African Society for Laboratory Medicine has the floor.
Thank you so much, Chairperson. The African Society for Laboratory Medicine, ASLM, welcomes and supports the regional strategy on the regulation of medical products. As Africa expands local manufacturing, including diagnostics, strong regulatory systems are essential to ensure quality, safety, and public confidence. Regulatory strengthening must advance along innovation. Working with member states and continental partners through initiatives such as Africa Collaborative to advance diagnostics and manufacturing to accelerate diagnostic excellence in Africa, ASLM supports diagnostic evaluation, quality assurance, and regulatory readiness to accelerate access to quality-assured diagnostics. We encourage member states to strengthen regulatory harmonization and invest in African innovation so that every community benefits from safe, reliable, and affordable diagnostics. Thank you.
Thank you. International Society. Oh no, Doctors Without Borders corrects the speakers. The International Society of Physical and Rehabilitation Medicine next.
Comments. WHO and Africa member states ensure that regional health and regulatory strategies explicitly recognize and facilitate humanitarian medical access. Regulatory frameworks should distinguish humanitarian from commercial supply channels and establish clear, predictable pathways for emergency imports, humanitarian donations, product sampling, and expedited access to quality-assured medicines and medical products. These provisions should be embedded in national legislation to reduce reliance on ad hoc exemptions or informal arrangements. I thank you.
The International Society of Physical and Rehabilitation Medicine.
The International Society of Physical and Rehabilitation Medicine, together with the World Rehabilitation Alliance, welcome the regional strategy on regulation of medical products in the African region and support its adoption. Assistive technology is a subset of health technology that refer to assistive product and related systems and services developed for people to maintain or improve functioning. Regulation of assistive technology within health systems ensure that assistive products such as wheelchair, prosthesis, orthosis, hearing aid, eye glasses, and digital communication tools are safe, effective, high quality, and affordable. Strengthening assistive technology ecosystem through appropriate legislation and regulatory procedures is essential to progressively expand access to assistive products toward universal coverage. We therefore call on member states in the WHO African region to integrate assistive products into national medical product regulatory system and standardization procedure to promote their availability, accessibility, quality, safety, and affordability for all who need them. Thank you for your attention.
Thank you. The International Federation of Pharmaceutical Manufacturers and Associations has the floor.
Thank you, Chair. IFPMA welcomes the proposed strategy on regulation of medical products and commends WHO AFRO, member states, and regional institutions for their commitment to continue strengthening regulatory systems across the continent. Central to this endeavor is the consistent application of internationally recognized regulatory standard, guidelines, and best practices across the African regulatory systems. The African Medicines Agency is uniquely positioned to champion this adoption and provide leadership in translating these standards into harmonized continental procedures, thereby promoting regulatory convergence, strengthening trust in regulatory decisions, and supporting more efficient and predictable pathways for access to medical products. We emphasize the need for effective, timely partnerships that engage industry throughout development of policy and regulatory processes. Industry brings valuable, practical, and technical expertise to strengthen regulatory capacity, digitalization, reliance, and AMA's operationalization across the continent. We look forward to continued collaboration in implementing this important strategy, combating illicit, substandard, and falsified medicines, and advancing equitable access to medical innovation across the African region. The innovative biopharmaceutical industry remains
Thank you.
Partnership with
La
WHO.
Fédération.
The International Pharmaceutical Students Federation.
La Fédération internationale.
The International Pharmaceutical Students Federation has the floor.
Monsieur le Président,
Chair, dear delegates, the International Pharmaceutical Students Federation represents more than 600,000 students and recent graduates in over 50 countries. It is very important to train and raise awareness about substandard and falsified medical products. We urge WHO and member states to strengthen regulation of medical products in the African region so as to ensure patient safety and access to safe and quality assured medicines by accelerating operationalization of AMA and strengthening financing of NRAs, harmonizing pharmaceutical training, supporting students in the field of pharmacovigilance. Thank you.
International Service.
Public Services International, you have the floor. Distinguished delegates, on behalf of the Public Services International, I represent the African population. Let us not forget that their lives, our lives, depend only on us. We need to be bold in wanting to succeed. We welcome the regional strategy on regulation of medical products. It is, however, true that no African country is among the 39 countries that are on the WLA list. We need to be successful, but that requires regional cooperation. We propose the creation of an African Fund for Medicine and Pharmaceutical Innovation. We ask member states to think about the AMRH initiative launched in North Africa recently. We ask professionals in the health field, their associations, federations, to focus on regulatory frameworks. We also laud this push for good governance. Thank you. The International Federation of Medical Students.
Thank you, Chair. Universal health coverage requires access to medical products that are safe, effective, quality assured, and affordable. A product intended to heal must never become a threat. We welcome the Regional Strategy on Regulation of Medical Products 2026-2035 and commend progress, including national regulatory authorities reaching WHO Maturity Level 3, increasing from 1 to 8, and the operationalization of the African Medicines Agency. However, despite the progress, 39 of 47 member states remain below Level 3, highlighting persistent gaps. We, as the International Federation of Medical Students Associations, call for integrating pharmacovigilance and adverse event reporting into medical education, meaningful youth and student representation in regulatory platforms, equity-focused regulatory strengthening, particularly for underserved and rural communities, and stronger regional collaboration and sharing of best practices. As the future healthcare workforce, we are ready to contribute to safer regulatory systems. Thank you.
Thank you. I see no further requests for the floor. Are there any comments from the Secretariat?
Thank you, Chair, and thank you, Member States, distinguished delegates, for the interest and the contributions you've made in reviewing and sharing your reflections on the strategy. We will take into account your recommendations, the request to accompany countries that need to be supported along the maturity level pathway. We have also taken into account the requests that what should be added to the strategy, the 5 points that were raised by the Honorable Delegate from Kenya. We recognize the contributions from the observations also from our partners, and of course, particularly the African Medicines Association, because that's going to be perhaps the first one that needs to become part of the WHO listed authorities, and it's through the efforts and collaboration of all of us. So we've taken note of the comments on where we need to strengthen, and we will, if need be, perhaps get in touch with specific contributors so that we are sure to capture the recommendations, but we've taken them all into account. And we thank you very much for the commitments that you already have made and are continuing to implement to ensure that we can have a strong regulated and create a strongly regulated regulatory system for the region. Chair, thank you.
Merci. Le secret.
Thank you. The Secretariat has taken note of the comments raised. Is the Regional Committee ready to adopt the resolution contained in document AFR/RC76/WP4, which includes the adoption of the Regional Strategy on Regulation of Medical Products in the African Region 2026-2035, as contained in document AFR/RC76/7? I see no objections. It is so decided. We will now continue with a special briefing session on the ongoing Ebola virus disease outbreak caused by the Bundibugyo virus. As you are aware, the Bundibugyo Ebola outbreak remains in a phase of intense transmission with even further geographical spread. And working with its partners, WHO continues to scale up surveillance, case management, contact tracing, community engagement, and cross-border preparedness to contain the outbreak and prevent any further spread. I would now like to give the floor to Dr. Marie, Director of Emergency Preparedness and Response Cluster. Over to you, Dr. Marie. You have the floor.
Thank you. Good afternoon. Good afternoon. Bonsoir. Boa tarde. Honorable Ministers, Excellencies, distinguished delegates, thank you for making time for this special session. I will provide a brief update on the ongoing Bundibugyo virus disease outbreak, focusing on 3 issues. The first one, where the outbreak stands today, how the response is evolving, and most importantly, what we collectively need to do now. Because this is a regional emergency and it is require a collective response. Slide. Let me first place this outbreak into context. Our region, the African region, we carry more than 60% of all graded emergency globally. And this year alone, since 1st of January until August, we are responding to 71 outbreaks across 33 countries. And we have already lost more than 10,000 lives to outbreak. We have cholera, measles, mpox, and Ebola Bundibugyo. They represent so far the 4 largest outbreaks that we have in the regions. Next. When we look at the Ebola outbreak in Africa, the Bundibugyo, this is the 3rd Bundibugyo outbreak that Africa has ever recorded. After Uganda in 2007 and the DRC in 2012. But the scales of this outbreak now is unlike anything we have seen for this species, Bundibugyo. The 2 earlier events together caused roughly 200 cases. And the current outbreak, as of 24th of August, has already surpassed 5,600 cases. In the broader family of Ebola outbreak, only West Africa in 2014 and 2016 was larger. So we are, in effect, facing the largest Budzin-Bujo outbreak in history. Next. So the first signal appeared in early March, and cluster of death initially assessed as measles, as malaria, or other fevers. Testing was negative for Ebola Zaire species. So it took until 15th of May for sequencing to confirm Budzin-Bujo virus and trigger the official declaration in Uganda and DRC the same day. And Uganda that day also reported its first imported case almost immediately. And WHO determined the event as a public health emergency of international concern. Sequencing data tell us that the virus was circulating well before we confirm it, sometimes around February. And some anthropological data even say that it was there in December 2025. Next slide. So as of 24th of August, the Democratic Republic of the Congo has reported 5,665 confirmed cases and 2,715 deaths, with a case fatality ratio of approximately 48%. Uganda has contained its outbreak with 20 confirmed cases, while one imported case was reported in France. The immediate challenge, therefore, remains the very large and geographically expanding outbreak in the Democratic Republic of the Congo. Next slide. Today, 26th of August, marked the 42nd day since the last confirmed case was discharged from the treatment center in Uganda. That means 2 full incubation cycles, making sure that no more residual risk of Ebola is in the country and making the end of the outbreak in Uganda. Can we applaud Uganda? Next slide, please. So now let's focus on DRC. In DRC, we have 6 provinces and 58 health zones are now affected. For those who are not familiar with DRC, a health zone can be larger than my country. I'm from Haiti. My country is only 26 kilometers square. And in DRC, one health zone can be bigger. And the health zone is the administrative division of the health sector. It is important to note also that we have good news in this outbreak. 1,245 patients have recovered from this outbreak. And however, Ituri, the province of Ituri, carries the overwhelming burden with over 4,700 cases. Next slide. Geographically, this outbreak is heavily concentrated. In Ituri province alone, as I already mentioned, accounts for 84% of cumulative cases and 78% of deaths, with nearly 8 in 10 of its health zone is already affected. Next slide. This is the epi curve. I mean, there's a special evolution of the outbreak. This shows you how daily and weekly the outbreak is evolving. We can see in that graph that transmission remains very active, and the recent weeks reflect both ongoing spread. And here, the message I want you to have is that we have slowed the acceleration, but we have not yet bent this curve. That is the task that we have ahead altogether. Next slide. This map shows why this outbreak cannot be treated as a purely national event. The affected zone sit astride major mobility corridors. Mining routes, trade roads, and cross-border movement toward Uganda, South Sudan, and Central African Republic. People move and the virus moves with them. Every corridor you can see in this map here is a potential export pathway. Managing transmission, therefore, means managing movements, screening at point of entry, and coordinating across borders. Next slide. The demographic matters also. Who are the most infected? We can see the most affected group is the working age adults, 18 to 49 years old. Women represent 53% of reported cases. Most are striking and most painful, children under 5 have the highest case fatality ratio, and around 60%. This pattern shaped our clinical priorities. Pediatric care is highly needed, maternal services, and they remind us that this virus is hitting the most vulnerable population. Next. This slide breaks what I just said. This is the fatality down by age and sex. While females are the most affected in this outbreak, males are dying more in this outbreak. You can see that females are dying at 35.2% and male at 40.8%. So the pattern is really consistent of what I said before. The very young, as you can see, in place, the older age group carry the heaviest fatality. Children under 5 are dying at 69.5%. Next slide. This slide is, for me, the single most important operational slide. It is a high proportion. First of all, in blue, you have the death in community, and in green, you have the death in the ETU, in the Ebola treatment units. You can see that there is a high proportion of deaths are occurring in the community, not in our treatment center. When people die at home, they were not isolated, their contact were not traced, and unsafe burial can seed new chain of transmission. That means community deaths are both a measure of where are we failing to reach people early and also a driver of continued spread in the community. Next slide. We have the key risk drivers. The bottom line I want you, Excellencies, Honorable Minister, to take from this section is the response is not struggling because of any one factor, because of one single factor. We have a combination of those factors. First, the hazard itself. It's very serious, often fatal virus with no vaccine or specific treatment. Second, delay in detection. I just informed you that the virus has been there since February and we detected it in May. Weeks pass before confirmation. Third, we have the breaches in infection prevention that is reflected in a lot of number of healthcare workers infected. Fourth, we have sustained community transmission through family, through healthcare center, and also to unsafe burial. And fifth, we have the insecurity that limits our team access. And sixth, regional mobility that I showed you that raise the risk of export. That means there is not a single driver explain this outbreak. As I mentioned, it is a combination of all of those. Next slide. Now I will go to operation. How we turn to operation. What are we actually doing on the ground, pillar by pillar? I will walk you through how the response is organized, how are we conducting surveillance, diagnostic, case management, infection control, and community engagement, and how are we protecting essential services at the same time? Because women continue to deliver. Children continue to need their routine immunization. I really want you to see not just the scale of the challenge, but the scale of the machinery now working to meet it. Here you can see the organizational of the response. The response is government-led, and I want to stress that. It is government-led and partner we are there to support. There is a 3-level architecture that has been put in place. We have the national leadership through the coordination platform, the provincial cells across the affected provinces, and the health zone teams that are anchored in communities. So 95 partners are mapped against gap to reduce duplication. We have a coordination where all partners are sitting together so that we mutualize our effort. Next slide. Excellencies, this outbreak is not happening in isolation. In the 58 Ebola-affected health zone, Ebola is colliding with a pre-existing humanitarian crisis. Humanitarian coverage in these zones is dangerously low. I repeat, is dangerously low, often below 40% for water. Those populations, they don't have access to water, to clean water. Access to health is very low. Food security, in this place we have a very high level of malnutrition. That means roughly 1.5 million people not reached with food assistance and 1.7 million without essential non-Ebola health services and 833,000 without adequate water and sanitation. Next slide. On surveillance, we have done better now. We are seeing some progress. Contact follow-up has improved from around 40% to roughly 85%. We have received about 76,000 alerts, verifying over 84% of them. More than 22,000 contacts have been listed. At point of entry, over 11 million travelers have crossed, and nearly all were screening during the 500 days of the response. However, we need to be also conscious that daily follow-up is still below our 95% target, and our contact-to-case ratio remains too low. We are improving. We are not yet there, but we need to be there. Next slide. Diagnostic capacity has expanded substantially. 21 laboratories are now active, from 1 to 21. We can say we have done a lot, with 5 more decentralized labs coming online and a further 10 to 20 in planning. We have reached a daily capacity around 3,000 tests. Critically, phylogenetic analysis is also available, and the new analysis we have, they point to a new zoonotic spillover followed by human-to-human transmission. And that gives us reassurance that there is no evidence of viral mutation so far. This is a good news. That's bringing testing closer to patients, and one of the clearest ways we shorten the time from onset to isolation. Next slide. On case management, we have 10 partners in the field supporting the ministry across 49 treatment centers, with over 1,300 active beds and around 800 confirmed cases hospitalized today. So we expect to reach nearly 1,700 beds by mid-September. That's been allocation accordingly to epidemiological trend, and also including dedicated pediatric, critical care and maternity capacity inside of Ebola treatment centers. Clinical care is improving with oxygen therapy available. We have oxygen concentrators. We also have biochemistry equipment. An ambulance and safe burial center has been operational, and also a therapeutic trial is underway. So the message here is that if we have better bed capacity closer to the patients, we can save more lives. Next slide. When we look at infection prevention and control, it is organized around the concept of IPC rings. That means rapid action around every confirmed case in the household and also in the health facilities. More than 450 rings has been activated. Over 2,900 households and 850 health facilities have been decontaminated by the team in the field. And more than 1,000 frontline workers are working in IPC only, including safe and dignified burial team. They have been trained, and over 450 exposed healthcare workers have been assessed. So protecting healthcare workers is a priority for us. Safe and dignified burial is also one of our top priorities to stop this outbreak. Next slide. When we look at risk communication and community engagement, We have now operate at real scale. We have already reached over 6 million of population of people. More than 1.8 million of households has been visited one by one, and nearly 60,000 community alert has been generated by the community relays. So activity spans in 6 provinces. All those activities that we are mentioning, they are occurring in all the 6 provinces. We have 6,000 community relay are deployed, and over 100 radio stations have aired thousands of spots, reaching millions monthly. Crucially, engagement is enable safe burial, contact listing, and rapid rumor resolution. When communities trust us, they alert us earlier, and earlier alert save lives. Next slide. Here, I want you to really see when we say that this response is a community-centered approach. What does that mean in reality? We listen first. We co-design action. We work through trusted local actors, survivors, women, youth, motor taxi drivers. And we link every community action directly to stopping transmission. Community have moved from passively receiving messages when we started this outbreak to actively shaping response decision. Community dialogue is now an operational entry point for case detection, refuel, and safe practices. Engagement is not an add-on to communication. It is a control measure for us. To reinforce that point, we have shifted from one-way risk communication to really community-led detection. Next slide. We also move on clinical trial. But I want to be straight with you about the medical countermeasure. There is no confirmed cross-protection between the existing Zaire Ebola vaccine and Budimbujo. A clinical trial phase 3 will start soon to assess if there is that cross-protection. And so far, there is no Budimbujo vaccine specific for Budimbujo. And we are also starting a clinical trial phase 1 for the specific vaccine, and that will take months. So in the meantime, we are also pursuing other clinical trials, like the clinical trial for the treatment with the monoclonal antibodies and the remdesivir, and also the post-exposition prophylaxis with the obeldesivir. So until those clinical trials can deliver our response, can deliver our, that we have treatment or vaccine, our life-saving tools remain early detection, isolation, and quality supportive care. Next slide. But despite all those achievements in the response after the 100 days in DRC, we still have some challenges. We still have insecurity and armed group activity that restrict access and have led to incidents affecting our facilities and operations. Community trust, even though we are working with them, but community trust remains fragile in some areas. And with episodes of resistance and burial practices that really complicate unsafe burial. And we also have to tell that the countermeasure and financing, we face the absence of an effective vaccine and treatment, and a response that is still under-resourced relative to the scale of this outbreak. These are the obstacles standing between us and control the outbreak. Next slide. However, to date, our logistic and operation team have successfully established a resilient, rapid response supply chain, distributing essential medical supplies and personal protective equipment across all high-risk zones. But yet, we are now facing a critical 30 million funding gap to sustain this operation with only the logistics. Next slide. This is a specific need of another 20 million to secure critical supply chain in the Democratic Republic of the Congo. And without this immediate investment, we risk stalling the momentum we have built and compromising our ability to maintain the life-saving services delivery to the community that it need the most. Next slide. We also integrated the prevention of sexual harassment across this BVD response. I really want to emphasize that community protection, protection of the people, protection of the most vulnerable, of the people we serve, is built into this response. We have integrated the prevention of sexual exploitation, abuse, and harassment across every pillar. Under a government-led, the government also have that pillar, interagency mechanisms, the UN, we are supporting the coordination. We also have community-based complaint and referral channel that has been established. We have risk assessment that has been conducted and led by the community. We also put in place some mitigation measure that has been identified with survivor-centered approach. This is an emergency, a very big scale of emergency. Therefore, safeguarding the community protection is not optional. It is a measure of the integrity of our collective response. Next slide. So now we will switch to preparedness. I now turn really, because it is where honorable minister outside of DRC have the most direct stake. Containing the outbreak at source is our first line of defense. But every neighboring at risk country must be ready. In this section, I will show you our assessment of spillover risk, the state of readiness across the region, and the simulation exercise that we have conducting in some countries to support them. This slide shows you our spillover risk map, and it has changed in just 2 months. In May, Uganda topped the risk ranking, but August, with Uganda's outbreak contained, the risk has moved northwest. The Central African Republic is now our highest risk country, followed closely by South Sudan, because the epidemic has reached their adjacent border. My key message for you today, act on the risk score, not the case count. South Sudan's surveillance gap put it at an imminent risk before case number would ever trigger a reaction. Next slide. This is the status of readiness for the Bujumbura threat as of July. We have supported at-risk countries to complete readiness assessment, and a number of high-risk countries now have contingency plan and budget in place. But readiness is uneven. Some countries have moved quickly, others have gaps in key capacities. The purpose of showing you these, honorable ministers, excellencies, this is not to grade any member state. It is to identify precisely where support and investment must go now, while our caseload are still 0. Next slide. To make readiness real, we have run simulation exercise across the region. 20 exercises have been conducted, engaging 15 countries. 10 countries are already implementing the key recommendations that emerge. 5 are still to confirm implementation, and we are following up with them. Simulation exercise is a very important exercise as it will expose the weak point, coordination, isolation, sample transportation before we have a case in the country. I really encourage all member states, every member state represented here, to complete this simulation exercise and crucially act on their recommendation. Next slide. So what now the shift in the strategy in the response in DRC? In this slide, we capture a deliberate shift in the response. We are moving from pledge to disbursement so that community become operation on the ground. We are scaling up community-centered approach, expanding bed capacity, and reinforcing contact tracing and active case searching. We are enhancing preparedness in high-risk zone, and we are working to enable humanitarian trust so we can reach affected community. In short, we are moving from planning to execution and from centralized messaging to community-led action. Next slide. This is the current funding situation against a total requirement of 518 million under the Continental Emergency Plan together with Africa CDC. We have secured 1.3 billion in pledge, but with 150.5 million committed and 323 million disbursed. Importantly, WHO has directly mobilized 91 million with a further 25 million in the funding pipeline. So the funding mix also demonstrates the strong contribution of external partners alongside domestic resources. The Democratic Republic of the Congo has disbursed 50 million to contribute to this outbreak. And so far in Africa, 18 countries have contributed. Going forward, our focus should therefore be on accelerating commitment and disbursement and ensuring that available funding is strategically aligned. Next slide. This progress would not have been possible without the strong commitment of support of our donors, of our partners. We would like to express our sincere appreciation to the United Kingdom, Germany, Australia, the United Arab Emirates, Italy, Denmark, and the Netherlands, as well as the European Union civil protection mechanisms for their continued support. We are equally grateful to our global health and philanthropy partners, including Gates Foundation, the Global Fund, Novo Nordisk Foundation, the Children Investment Fund Foundation, and the Wellcome Trust. We are also deeply value the contribution of the UN Central Emergency Response Fund, Africa Development Bank, and World Bank. Each of these partners have been instrumental in strengthening preparedness, enhancing response capacity, and enabling countries to better manage emergency. So thank you to all of you. Next slide, please. Honorable ministers, previous slide. Honorable ministers, this slide brings me to what we are asking you today. We have 5 priorities we would like you to support us. First, let's have one voice on secure humanitarian access. Let's implement the initiative that you approve in the World Health Assembly, Health for Peace and Peace for Health. Second, increase and accelerated funding for both preparedness and response. Third, strengthen cross-border collaboration and lift travel and trade restriction in line with IHR recommendation. Fourth, let's integrate standardized emergency curricula over the continent at medical and paramedical school, because so many of the people you train, you invest in, are losing their life when there is an emergency, because they are not trained in infection prevention and control, they are not trained in surveillance system. We are waiting for them to work so they can receive training. Those trainings should be part of their core curricula the time they are still at medical school or paramedical school. And fifth, consistent member state contribution to the African Public Health Emergency Fund so we can strengthen Africa emergency preparedness capacity. Honorable ministers, excellencies, let me remind you that this outbreak is serious and it is not yet contained, but it is not beyond our collective reach. With the access, the financing, and the solidarity, we can bend this curve and protect the communities and the border we all share. Thank you. Merci beaucoup e muito obrigada.
Merci beaucoup, Dr.
Thank you very much, Dr. Belizer. I now open the floor to African member states for their interventions.
La Zambie, vous avez la parole.
Zambia has the floor, followed by Uganda.
Chairperson, Zambia appreciates the update on the Bundibuyo virus disease outbreak and commends the affected countries, WHO, Africa CDC, and partners for their continued response. Given our geographical proximity and extensive population movement along trade and transport corridors linking Zambia with the Democratic Republic of Congo and the wider region, this outbreak remains of particular concern. Zambia has therefore maintained heightened preparedness, emphasizing early detection, rapid investigation, and containment of any imported cases. Our National Public Health Emergency Operations Center has been activated at Grade 2 alert mode with strengthened surveillance, laboratory readiness, infection prevention and control, case management, risk communication, and points of entry preparedness. By early July, Zambia had investigated 5 alerts, all of which tested negative. These investigations provided valuable opportunities to test our systems and identify areas requiring further strengthening. Our experience underscores 3 priorities. Preparedness must extend to subnational levels, cross-border information sharing must be rapid and consistent, and countries require sustainable access to PPE, laboratory supplies, trained SAGE personnel, and appropriate isolation capacity. Zambia therefore calls for continued regional coordination and partner support. No country can adequately protect itself in isolation. Regional preparedness must translate into coordinated operational readiness across borders. I thank you.
Uganda, vous avez la parole.
Uganda has the floor, followed by DRC.
We want to appreciate the presentation by WHO on the current Bundibujo outbreak. Uganda wants to add its voice to thanking the many partners not yet listed on those who have responded and supported the response to Ebola. I realize that list was not exhaustive. Secondly, we want to appreciate the President of Uganda for allowing Uganda to deploy its health workers across the border, a true test of solidarity. So as you fund the response, Uganda has already set up 2 treatment centers and 2 laboratory setups, and we are yet currently expanding the 3rd. We look forward to partnering with those who want to support DRC through Uganda, and many are doing so. Finally, Chair, 30 days ago, Uganda declared the end of our outbreak because this was a unique outbreak of imported cases. Uganda stands to share experience, including sharing with WHO in how to revise the declaration protocols, including treatment, because we've shown that we currently have only a case fatality rate at 20%, 10%, not 20. That can be different if you allow WHO also to learn from Uganda. I thank you.
La RDC, vous avez...
DRC, you have the floor, followed by Ethiopia. Excellency, Mr. Chair, DRC would like to commend WHO for this presentation. It clearly shows the situation of the pandemic in our country, and we'd like to, and you have reiterated WHO's central role in international solidarity. This is the 16th Ebola virus outbreak in DRC. The 16th pandemic is happening in a specific context. As recalled, you have a context of insecurity, there's a humanitarian crisis and a strong concentration, demographic population and mobility, despite the health system being almost inexistent in the region, we have been able to detect the pandemic, and thanks to the WHO support and other partner support, a response is being organized and implemented, and it becomes stronger every day. in our country, we authorize children's vaccination when it comes to the Zaire strand, because cross immunization is a hypothesis, and we hope that that will help us contain the pandemic, or this outbreak. So we are also open to trials and research for other vaccines in collaboration with WHO, CDC Africa, and other partners. Currently, we have received 16,000 vaccine doses out of 50,000 expected, and we're still working on the surveillance strengthening, and strengthening also the response within the community. And the government mobilized and disbursed $50 million in order to boost the response to this outbreak. We remain confident that with the concerted efforts of the international community and regional community, we will be able to contain this outbreak, and we will be able to cast out this disease from Africa and avoid its spilling over in the whole region, on the whole continent, and in the rest of the world, to the rest of the world. Thank you.
Merci, la RDC.
Thank you, DRC. Ethiopia, you have the floor, followed by Algeria.
Thank you, Chair. Ethiopia would like to update the Committee on our national preparedness and public health measures following the emergence of a Bundibugyo strain of Ebola virus disease detected in DRC and Uganda. Recognizing the risk of the disease, Ethiopia immediately activated proactive containment and readiness measures and has undertaken the following preparedness actions. The country heightened public health surveillance, enhanced points of entry screening, including mandatory travel declaration forms for passengers from affected areas. These operations have been active at international airports and designated ground crossings since May 17, 2026. Since then, the National Public Health Emergency Operations Center at Ethiopian Public Health Institute has been in the alert mode. A comprehensive emergency preparedness and response plan has been prepared across 12 technical pillars. Our rapid response teams have been deployed to high-risk areas to evaluate the readiness of districts, health facilities, and point of entries. Extensive orientations and comprehensive clinical trainings have been delivered for public and private healthcare workers. The field hospital has been designated and prepared as an isolation center. Multiple functional and field level simulation exercises have been conducted, including one at Bole International Airport and another involving sub-national public health emergency operation centers. Ethiopia remains committed to enhancing its preparedness and response capabilities in alignment with the WHO and Africa CDC Joint Continental Ebola Response Plan. We reaffirm our solidarity with affected nations and remain vigilant in safeguarding our population and region against cross-border transmission. Thank you, Chair.
Algeria has the floor, followed by Côte d'Ivoire.
Thank you, Mr. President. Mr. President, we are happy to hear that the spread of Ebola epidemic in Uganda is under control. We expect very soon the same outcome in the Democratic Republic of Congo. Mr. President, this epidemic has demonstrated the vulnerability of the continent and the need to strengthen its health security, including sustainable investment in public health systems. Algeria has always placed particular importance on international solidarity and cooperation in the field of health. Faced with the threat posed by the Ebola epidemic, particularly in Uganda and in Democratic Republic of the Congo, our country has demonstrated its commitment alongside the international community to help contain and eradicate this disease. In this context, Algeria has notably provided the financial contribution to the CDC Africa to support efforts to combat the epidemic and strengthen health response capacities. This contribution reflects Algeria's determination to actively participate in international efforts by supporting countries and organizations involved in the prevention, surveillance, and management of the disease. Through this action, Algeria reaffirms its commitment to the principles of solidarity, international cooperation, and collective responsibility in the face of global health crisis. The fight against Ebola, like any pandemic, requires joint mobilization and close cooperation between states and health organizations. Algeria will therefore continue to support initiatives aimed at protecting populations and strengthening health security, convinced that international solidarity is essential to effectively address major health threats. Thank you.
La Côte d'Ivoire, la
Cote d'Ivoire has the floor, followed by Kenya. Thank you, Mr. Chair, ladies and gentlemen. This new Ebola outbreak in Central Africa requires a constant preparedness, strengthened international cooperation, and national systems that can respond swiftly. With all of these challenges, Cote d'Ivoire has strategically decided to invest in a sustainable manner in preparedness rather than response. Given the current Ebola outbreak, or in view of it, our country has activated its national alert and preparedness mechanism under the aegis of the government. A certain number of priority measures were implemented, such as the immediate heightening of epidemiological surveillance on the national territory. We also intensified border control, air, land, sea, with an online platform to monitor passengers coming from risk areas. We also strengthened laboratory and diagnosis capacities, established specialized contact tracing teams. We strengthened communication around risk, communication campaigns towards the population, also organized simulation exercises in order to test our response capacity. Our priority remains sustainable capacity building at the national level, and that is why we are strengthening rapid intervention teams, working on also establishing a national emergency team. There's also training of health staff. Emergency logistics are being strengthened. Health surveillance, modern analysis tools for risks are an asset in order to reach our goal, which is early detection, being able to decide quickly and to act more effectively. We would like to commend WHO for its crucial role in this response, and we'd like to thank the various partners and countries for their support. And Cote d'Ivoire is actually part of those who contributed to the tune of $2 million to Africa CDC. Thank you.
Kenya.
Kenya has the floor. Togo prepares.
Honorable Chair, Kenya thanks the WHO for this special briefing session on the ongoing Ebola virus disease outbreak in the Democratic Republic of Congo. Since the declaration of the ongoing outbreak, Kenya has not recorded a case. However, we fully acknowledge that due to high cross-border movement, trade and population mobility within the region, Kenya is at risk of importation of the disease. In view of this, we have initiated and continue to implement various preparedness measures, including activation of our National Public Health Operations Center, as well as the 26 subnational level emergency operation centers to support structured coordination of preparedness interventions. We have also activated an incident management system, screened more than 487,000 travelers across 26 points of entry. We have heightened our surveillance for the disease since the outbreak began, leading to investigation of 206 alerts. Samples collected following investigation of these alerts have been tested in 5 designated laboratories and all turned negative for the disease. We have trained more than 3,500 healthcare workers at both national and subnational level, sensitizing them on various components of the disease. We have also heightened risk communication and community engagement. Owing to high cross-border movement and population mobility within the region, Kenya urges all member states to strengthen timely information sharing across the borders to inform timely actions. We congratulate the Republic of Uganda for quickly bringing the outbreak there to a control and stand in solidarity with the Democratic Republic of Congo as we combat this outbreak. Thank you.
Thank you. Togo has the floor. Guinea will go next. Thank you very much, Chair. Togo would like to thank the Secretariat for the brilliant presentation that we have just seen about the current epidemic on the continent. We're mobilizing our national emergency team through sustained support, preparing for the response. We encourage member states with advanced experience in preparation of response to share best practice in terms of governance and continuous training. We urge the member states, the partners, and WHO to help in capacity building, to deploy people across borders so that nobody is left without the requisite capacity in the face of emergencies. Thank you very much. Thank you very much. Guinea has the floor. Congo will follow. Thank you very much, Chair. Ladies and gentlemen, the Republic of Guinea would like to thank WHO for this presentation on the Ebola virus disease situation in the DRC and Uganda. The experience teaches us that preparation is fundamental when we are faced with Ebola. We need to be one step ahead in terms of response. Under the coordination of our Ministry of Health, a number of different measures have been undertaken. Guinea has relaunched the agreement for coordination of emergencies in airport environments. We are strengthening measures in the air transport sector and at points of entry. We've assessed the risks of the epidemic at this level. We've identified capacity building required. The diagnostics teams were employed to help with early detection as required. At the same time, rapid intervention teams have received training in public health emergencies in the hinterland of the country as well, preparing for public health emergencies at all levels. In order to test national capacity, we are planning to engage in a national simulation exercise and cross-border exercise as well at regional level, working with neighboring countries, Liberia, Sierra Leone, and other countries. We are fully aware that preparation requires predictable funding, pre-positioning of inputs and operational capacity. We ask WHO partners and others to support our exercise and to help fill the gap where insufficiencies have been detected in terms of medication, treatment, and others. Thank you.
La parole est au Congo et RC.
Congo, then the Central African Republic. Chair, ladies and gentlemen, Congo, through me, congratulates the Executive Secretary of the Regional Office of WHO for this very important point on the agenda dedicated to the Bundibugyo Ebola virus. Congo would like to express its solidarity vis-à-vis the DRC that is having to deal with this epidemic, and we would like to applaud the efforts made by the authorities, the communities, and all partners working on the response. Our country has not yet been affected by the Ebola virus. However, our geographic positioning, the borders with the DRC, the mobility across borders, air, river borders, etc., and also border points expose us to a risk of importing the disease. And so we have activated the National Preparedness Mechanism. The National Emergency Center is on alert, and the National Preparation and Response Plan for Ebola has been revised and updated. Surveillance has been strengthened at point of entry, in training, and also at community level. Furthermore, other measures are being undertaken, in particular, control of travelers, tracking of stocks in terms of PPE, and also awareness raising at community level, and also awareness raising in terms of the travelers using French and local languages. We need to ensure capabilities at points of entry, a lack of capacity in terms of training for some public health professionals, and also the need for laboratory capacity in Brazzaville and Pointe Noire. This is why we restate our commitment to strengthening our preparedness and response mechanisms, working with WHO and the member states, as well as our technical and financial partners. Thank you.
Yes, yeah,
The Central African Republic has the floor, and then Comoros. Thank you very much, Chair. Regional Director of WHO, ladies and gentlemen, honorable ministers, distinguished delegates. The Central African Republic would like to thank WHO, CDC Africa, and all other partners for the support given to fight the Ebola virus. The Central African Republic is exposed to a very high risk of importing the disease, namely the Bujumbura strain, because of its geographical proximity to DRC. We share more than 1,600 kilometers of river borders. We have adapted our preparation based on the 12 pillars proposed by the WHO. After the declaration of the epidemic on the 15th of May 2026, the Management Committee was activated at our level. Based on the risk levels, 3 health districts were classified as priority level. Communication risk plans have been updated. 79% of community health workers in high-risk districts have been trained in early detection of EVD. Points of entry have gone from 4 to 50. And we are now also collecting numerical data. We are also collaborating with the Democratic Republic of the Congo. Mobile laboratories have been deployed to the districts closest to the risk areas, namely Umbongo district. High-level efforts are being made also to mobilize resources that will allow us to implement our national plan, preparedness plan. Preparedness against EVD was complicated by an outbreak of cholera, which is why our health minister is not here today. He is on the ground dealing with this outbreak. Thank you.
merci, RCA.
Thank you very much, Car. Comoros, you have the floor. Thank you very much, Chair. The Comoros would like to thank WHO for having put this EVD issue on the agenda. It is obviously affecting our continent as a whole. The declaration of public health emergency of international concern has led us to take this matter very seriously. Although we do not have borders neighboring with these countries, they're not neighboring countries. However, we do now have more people traveling to our country from all of the countries affected, often trying to get to Europe because we're close to the Reunion and Mayotte. So we are receiving more people passing through from other places in the world, which is why we are preparing for possible importation of the epidemic. And so a number of different meetings have taken place at the level of our government authorities, the Minister of Health, the Minister of Home Affairs, and other units have worked together to come up with a strategy to control migratory flows. A number of different exercises were conducted. We had to review our Ebola management plan. This was updated, and we set up a team that is in charge of managing the first case should one emerge. And we also undertook training of surveillance agents at the borders, and the borders, the official borders now have surveillance because we have porous borders. Clandestine migration is a great concern. We need further strengthening, therefore, at this level. As for challenges, well, the diagnostic element is the biggest challenge. We need diagnostics tests. We have a lack of those. And there's also the matter of PPE, personal protective equipment, specific equipment for EVD. This is what we need to manage cases. Thank you.
Merci.
Thank you very much, distinguished delegate. I see no further requests for the floor from the member states of the region. I invite member states from other regions, UN agencies, and other non-governmental organizations to ask for the floor by raising their nameplates. Thank you. UNICEF, you have the floor. IOM next.
Thank you, Chairperson. UNICEF commends the government of the DRC, WHO, African CDC, partners and communities for their leadership, commitment, and collective effort to contain the Ebola outbreak and protect affected populations. UNICEF would like to emphasize these 3 key points. The response must continue to protect children and mothers while maintaining access to essential maternal, newborn, and child services, particularly in the affected and hard-to-reach communities. So the scale and the speed of the response must match the scale of the outbreak. Community trust and engagement are fundamental to controlling Ebola and ensuring people continue to access essential health and non-health services. And lastly, we must continue to learn and strengthen for the future. We must continue to capture and apply lessons from the response to strengthen preparedness, health systems, and community resilience, and reduce the risk and impact of similar outbreaks in the future. Finally, UNICEF remains committed to working alongside the government, WHO, African CDC, partners, and community to protect children and mothers, sustain essential health and non-health services, strengthen community trust, support communities to contain the outbreak, and turn the lessons from this response into stronger preparedness for the future outbreak. Thank you.
Merci.
Thank you very much, UNICEF. The IOM, you have the floor.
As the UN Agency for Migration, IOM recognizes that population mobility is a critical consideration in all outbreak response and preparedness efforts. Migrants, cross-border traders, transport workers, refugees, IDPs, pastoralists, and border communities are often among the first populations exposed to these emerging public health threats, as shared also with member states in this meeting. While they also face major barriers, to this, in support of government-led efforts, IOM has scaled up operations across different countries which are at risk as well as those that have been affected, with significant work in DRC, Uganda, South Sudan, Rwanda, Burundi, and other member states. To date, we have mobilized more than 23.6 million USD and provided more than 19.8 million health screenings at 227 points of entry. Through population mobility mapping, IOM is working closely with governments to identify high-risk mobility corridors, congregation points, border communities, and formal and informal crossings where disease transition risks may be elevated. Lastly, IOM remains very committed to working under the leadership of member states and in coordination with WHO and Africa CDC to strengthen POE preparedness, protect migrants and mobile populations to ensure that our continent is safeguarded in this and any other future outbreaks. Thank you.
Gavi, à vous la parole.
Gavi, you have the floor.
Thank you very much, Mr. Chair and Excellency. Gavi stands with the Democratic Republic of Congo and Gavi stands with the Democratic Republic of Congo and with all countries in the region at risk of Ebola. To support the response, Gavi has mobilized 50 million US dollars. This includes 40 million to accelerate access to potential vaccine against Bundibugyo Ebola virus, and 10 million to help affected countries, including DRC and Uganda, to protect frontline healthcare workers and sustain essential immunization services. Gavi has also invested significantly in regional coordination efforts through support to key partners, including WHO, Africa CDC, and UNICEF. In addition, through the Gavi-funded Ebola vaccine stockpile, more than 70,000 doses of Ervebo have been made available to support studies on cross-protection and the vaccination of frontline health workers. Finally, Gavi remained fully committed to supporting the people of the Democratic Republic of Congo and all countries facing the threat of Ebola. We will continue working alongside government and partners to support response efforts and help ensure that vaccines can contribute to bringing this outbreak to an end. I thank you.
Merci.
Thank you. The International Federation of the Medicines Industry, you have the floor.
Thank you. Marking the 100th day after the Bundibugyo outbreak was declared, the global pharmaceutical industry underscores its commitment and track record to tackling health emergencies. Within a matter of days after the announcement of the outbreak, biotechnology and pharmaceutical companies mobilized along governments, Africa CDC, WHO, CEPI, Gavi, and other partners to develop new vaccines and therapeutics and explore cross-activity from existing ones for the current outbreak. This rapid response demonstrates the willingness of companies to voluntarily contribute to the collective response efforts and the value of years of prior investment in science, platform technologies, partnerships, and preparedness. We see this outbreak as a wake-up call for negotiators discussing the pandemic agreement's PABS annex. We caution that some proposals under discussion could add complexity and cost to the response to future pandemics and delay access to critical samples and information that scientific research relies on to develop and deliver medicines and vaccines. This will not do anything to strengthen the R&D pipeline either, to improve global preparedness, and will likely lead to fewer companies working on crucial areas of public health during the inter-pandemic period. We call on the PAB system to strengthen the conditions that encourage company engagement in pandemic preparedness and response, including ensuring timely and open sharing of pathogens and data, legal certainty for researchers and manufacturers, predictable rules, and partnerships that allow science to move forward. A complete version of the statement is available on the IFPMA website. Thank you.
Merci.
Thank you. Thank you for these very valuable comments. Are there any comments from the Secretariat?
Oui. Okay. Yeah, merci beaucoup.
Yes, thank you, Chair.
Thank you to all the countries who provide their input and also their appreciation, and also most importantly, what they are doing in order to prepare before they can have a case of outbreak. So regarding the number of partners, I agree that the list is not exhaustive. However, I think I have to make an advocacy for all the donors of the partner that are providing funding to this Ebola outbreak to use the tracking tool, the financing tracking tool that has been provided. It is online and it will be made available to everyone so we can have the information. It is really in terms of transparency, but also in terms of information sharing, so the information can be available and we can also represent it in presentation like this. We really appreciate that, and we will hope that every member state here, we are receiving some funding for this outbreak in terms of preparedness or response, so they can ask them to use the tracking tool so we can monitor those funding adequately. So regarding also the cross-border, I think one of the lessons learned in this outbreak is that a virus doesn't respect borders. So we cannot also, think that our border, we can close border. in Africa, we don't have borders. We have population living all over together. They are doing market together. They get married together. They have children cross the border. So administratively, we can say we have borders, but when we look at the way of living of our communities in Africa, we don't have borders. So this is why we are having those a MOU or Memorandum of Understanding on how to share information. What kind of information should be shared between countries? The real-time sharing information. How we can make more coordination across borders. So now population don't need to be restricted of movement, but they know where the services are available so they can access to the service. So with that, I would like to invite you to the cross-border side event tomorrow at 7, so we can continue discuss that. We have 11 countries that already come together in order to agree in some of them to review that MOU that can really establish this commitment on how we can work together across those borders. So let me stop there. And we also take note of some countries with the lack of tests of Comor, that we will work together with you to see how we can provide some equipment and also some tests to pre-position those in Comor. And let me say thank you, Mr. Chair, and thank you to all the member states. Thank you to Gavi and all the institutions that are supporting this response in DRC and the preparedness in the high-risk countries. Thank you. Over to you, Mr. Chair.
Thank you very much to the Secretariat. The Regional Committee has taken note of the update on the ongoing Ebola virus disease outbreak caused by the Bundibugyo virus. Thank you all for your very important contributions. This concludes our consideration of this agenda item, special session. Thank you. Distinguished delegates, this concludes our deliberations for today. Before we close today's proceedings, I would like to give the floor to the Secretariat for any announcements or practical information they may have.
Before we conclude, I would like to draw your attention to the side event number 2, entitled Multi-Disease Elimination in Africa, Celebrating Gains and Accelerating Progress, which will start now in this same room, Conference Room 1. We kindly ask that you remain seated, please. Tomorrow, Thursday, 27th August, we will have the side event number 3, entitled Strengthening Cross-Border, All Hazards, Preparedness and Response in Africa, from Fragmented Actions to Collective Resilience, which will take place from 7:30 a.m. to 8:45 in Conference Room 1. The plenary session will resume at 9 a.m. with agenda item 12, the Regional Framework on Emergency Medical Teams 2026 to 2030. The lunch break will take place from 12:30 to 14 hours. During the lunch break, a closed-door session on polio for Lake Chad basin countries, which will be held from 12:45 to 13:45 hours, which will be by invitation only. Finally, please note that the last side event of the Regional Committee, which is side event number 4, on the WHO Regional Health Data Hub, will take place tomorrow from 17:45 to 1900 hours, following the closure of the plenary session in this very room, Conference Room 1. I wish you a very good evening and thank you for joining us. And once again, please stay and remain seated for the side event number 2. Thank you.
Merci.
Thank you, Secretariat. I thank you all for your active participation and for your constructive contributions throughout the day. I wish you a pleasant evening and look forward to seeing you all tomorrow morning. The meeting is therefore adjourned.
Merci beaucoup. Merci. Merci beaucoup.
Distinguished delegates, please remain seated. The side event starts now. Please take your seats, please.
You want me to speak? On souhaiterait vous demander de rester assis. La session sur l'élimination des maladies va commencer immédiatement.
I would request that you remain seated as the side event will begin immediately.
Hello. Good evening, Excellencies, Honorable Ministers, colleagues, ladies and gentlemen, lovers of disease-free Africa. We are about to start the side event on multi-disease elimination. We all kindly come in, take our seats so that we can move on to the next session or the various sessions of the side event on multi-disease elimination. Celebrating our successes and sustaining, accelerating the gains. Please come inside. No, sir. working. Please, let's get seated so that we can start the side event right away. This evening, we celebrate the power of big, bold ideas. As a student of history, I remember that in 1962, an eminent African who later became the president of Zambia published the book, Zambia Shall Be Free. 2 years later, Zambia gained its independence in 1964. The power of big, bold ideas. Sometime down the line, we decided on multi-disease elimination because it is possible for Africa to be disease-free. And tonight, we gather in this side event to celebrate these successes as well as sustain the gains. This evening, we are honored to be in the presence of senior government leaders, partners, civil society representatives, and global health stakeholders, and they'll be joining us here tonight. We will have about 6-7 steps we will take tonight in this session. We'll begin with a short video with some snippets of disease elimination in countries over the past years. After that, there will be a session of opening remarks by our distinguished leaders. And then thirdly, there will be a regional overview of multi-disease elimination presented shortly to give us the perspective for this evening. And then we'll hear directly from ministers or heads of country delegations who have recently achieved major milestones. We'll also engage key stakeholders, key partners on how support mechanisms can best align with country priorities. Towards the end, we hope that Excellencies, Honorable Ministers, you will endorse a call to action to commit towards multi-disease elimination. Then we will have some group pictures taken, and then there will be a cocktail. Or will there be a party? We will celebrate. Therefore, it's my pleasure on behalf of the World Health Organization in the African region to welcome us to this side event. We will start with the video. Can we screen the video? Can we screen the video? Our comps team is here. Let's play the video now. I think it's coming.
The World Health Organization has verified that Cape Verde, Mauritius, and Seychelles have eventually eliminated both measles and rubella.
While we are waiting for the video, we'll move forward in order not to lose more time. Or is the video ready?
The World Health Organization has verified that Cape Verde, Mauritius, and Seychelles have eventually eliminated both measles and rubella, becoming the first sub-Saharan African countries to achieve this goal. This victory is a victory for Africa. It shows that when governments invest in prevention, when communities champion vaccination, and when health systems stay resilient, extraordinary things happen.
We have successfully kept measles and rubella transmission at bay for decades. This success is not only the result of tireless work on the ground, but also the collaborative efforts of our health professionals, local communities, and partners like the WHO.
Elimination is not the end of the journey. Sustaining this status requires constant vigilance, rapid detection, and immediate response to any imported case.
Our regional goal, as set out, the Immunization Agenda 2030 framework, it is to eliminate measles, rubella in at least 80% of the African countries come 2030. Already 45 countries provide a second measles dose, and 35 have introduced the rubella vaccine into their national schedules.
Vaccination is the best investment in the health of your children.
I'm here in Kinshasa, along with my colleague. They're introducing a very large measles rubella campaign and introduction for the entire country. This is an amazing achievement.
Gratifying to note that after 22 years of concerted effort, we have now come to the situation where the World Health Organization has recognized that Namibia is on the path to elimination of mother-to-child transmission of HIV and also hepatitis B. So this serves as an encouragement for us to continue and save more lives.
This achievement is a result of decades of sustained commitment from policymakers and health workers to parents, teachers, and the community champions who have ensured that no child is left unprotected. Africa can lead the world in disease elimination when we stay united in purpose and action.
It's okay. Yeah. That video is in celebration of the achievements in many countries: Burundi, Mauritius, Mauritania, Senegal, eliminating trachoma. Namibia becoming the first country to achieve gold tier level in elimination of mother-to-child transmission of HIV/AIDS. These are extraordinary achievements. Millions of children vaccinated against diseases. Kenya eliminating human Africa trypanosomiasis. These achievements are worthy of celebration. It shows that it is possible to eliminate not one but multiple diseases in Africa. Cabo Verde, Seychelles, and Mauritius have eliminated malaria, have eliminated measles and rubella. So we are celebrating tonight what is possible. And to move us forward, I would like to invite to the high table Dr. Mese Hailu, the Director General of Ethiopia Public Health Institute, who is representing the Minister of Health. Please come right to the high table. Also, I welcome Professor Giulio Rakotonirina, sorry about mispronunciation, Director of Health, Human Affairs and Social Development, African Union Commission, I believe representing the Commissioner. Please come right up to the high table. And so we'll go quickly into the opening session. It's my pleasure to invite Dr. Ailu, the Director General of Ethiopia Public Health Institute, to give the opening statement on behalf of the Minister and the Government of Ethiopia. Dr. Mese Ailu, please go ahead.
Thank you very much, Chair. I'm making this opening remark on behalf of Her Excellency Dr. Mekdes Dabat, Minister of the Federal Democratic Republic of Ethiopia, Minister of Health, Honorable Ministers of Health, Regional Directors of the WHO Regional Office for Africa, distinguished delegates and partners, representatives of civil society and the communities, colleagues and friends. Good evening and welcome to this important side event on multi-disease elimination, eradication, and control in our region. It is a privilege to stand before fellow ministers and partners who are united in the belief that we must protect and build upon the health gains our countries have worked so hard to achieve. We meet at a moment defined by four converging realities. First, growing number of African countries are reaching or approaching elimination milestones for diseases that have burdened our communities for generations. Second, the current financial crisis places these hard-won gains at real risk of reversal if we do not act deliberately to protect them. Third, our major financing mechanisms are increasingly emphasizing sustainability, transition, co-financing, and integrated service delivery, a shift that demands our rethink how we plan and invest. And fourth, fighting multiple disease proves a simple truth: investing in public health benefits every program. Therefore, the objectives of these side events are clear and as follows: to position multi-disease elimination, eradication, and control as a unifying agenda for ministers and partners across the African region, to celebrate the validated milestones achieved between 2024 and 26, and to recognize the political, technical, and community leadership that made them possible, to secure concrete commitments to protect our gains in an increasingly constrained financing environment, and to identify a small group of pathfinder countries that can demonstrate what integrated multi-disease elimination approaches look like in practice. And finally, to mandate the regional office and our partners to develop a follow-up roadmap and a 2027 to 2030 results framework that will carry this agenda forward with clarity and accountability. Ethiopia's experience illustrates the impact of sustained integrated health investments. Since the year 2000, Ethiopia has reduced under 5 mortality from 166 to 51 deaths per 1,000 live births. Infant mortality has fallen from 97 to 39 deaths per 1,000 live births, and neonatal mortality has declined from 49 to 25 deaths per 1,000 live births over the same period. Similarly, the maternal mortality has fallen significantly from 871 to 141 deaths per 100,000 live births. These numbers matter because behind every percentage point is a woman who received the care she needed, a child who survived, and family that was able to plan for the future. But we also know that the work is far from finished. The question before us now is how we take these gains further and ensure that progress reaches every community, including those still left behind. Allow me to go a little further and share where our service delivery data tell us we are making genuine progress and where they tell us just as clearly that gaps remain. Through our big catch-up initiatives, we have achieved a 57% reduction in zero-dose children by vaccinating 2.5 million children in February 2026. And skilled bed attendance now stands at 80%, and yet nutrition remains a serious concern with 39.9% of children stunted and 5% wasted, and youth-friendly services are available in only 55% of facilities against a target of 85%. These figures remind us that expanding access is only half the task. Quality and readiness of services must keep pace. On communicable diseases, our progress is real but uneven. HIV incidence has fallen by approximately 85%, and we are making a strong progress towards the 395 targets through geographic and population level disparities persist. Tuberculosis treatment success stands at 98.7%, yet an estimated 80% of cases remain undetected. Leprosy has been eliminated subnationally, and at the same time, we cannot look away from the rising burden of non-communicable diseases, which now account for 45% of all deaths nationally, led by cardiovascular disease and cancer. This is why Ethiopia is pursuing 5 interconnected priorities. Number 1, and the first priority is sustainable health financing, because no gain we have described today can be protected on donor funding alone. We must steadily increase domestic resource mobilization and use every available finance instrument wisely. Second, a envisioned approach to primary health care, bringing service closer to families and closing the readiness and quality gaps our own data exposed. Third, digital transformation so that we can track our zero-dose children, our TB cases, our NCD patients, and our commodities with precision this multi-disease agenda demands. The fourth one is health workforce development, because every statistic that has been shared represents the work of health worker, and we must invest in their numbers, their skills, and their motivation. And finally, the fifth one is strengthen self-reliance through local manufacturing, so that our health security is not held hostage to global supply shocks in moments of crisis. Excellencies and colleagues, the path to elimination is rarely linear and is never achieved by any one country, minister, or partner alone. It requires political will, sustained across electoral cycles, technical excellence, sustained across health systems, and community trust, sustained across generations. It requires humility to acknowledge that a milestone validated is not a finished program, but a foundation on which we must continue to build. As we deliberate today, I invite each of you to bring not only your successes, but your candid challenges, for it is in that honesty that we will find the most useful commitments and the most durable partnerships. I invite you also to think beyond your own borders. Ethiopia stands ready to be a partner in this endeavor, to share what we have learned, both from successes and from the gaps we continue to close, and to learn in turn from every country represented in this room. I look forward to a productive discussion and concrete commitments that help build a healthier, more resilient Africa where disease elimination improves daily life for every family and community. Thank you, and I wish you all a productive and successful session. Thank you, Chair.
Thank you very much, Your Excellency. And thank you for making clear that we need a roadmap towards integrated multi-disease elimination. And I totally agree. I believe that that's the direction to go. The next person to speak to us for 4 minutes is Professor Julio. Please, the Director for Health, Humanitarian Affairs, and Social Development in the African Union. Please, you have the floor.
Thank you so much, Chair. Honorable Ministers, Head of Delegations, dear colleagues from WHO Afro, ladies and gentlemen, all protocol observed. It is a great honor for me to speak today on behalf of African Union Commission. So let me first to thank WHO Afro for bringing us together for this important discussion. Today, we celebrate the progress that Africa has made in disease elimination. We also renew our political commitment to go further and faster. The African Union Commission has a clear political role in this effort. We bring our member states together. We build common positions, and we help turn the decisions of our head of states into action. Over the years, the Commission has worked closely with member states, Africa CDC, WHO, and other partners to strengthen health systems across our continent. We have supported stronger surveillance, early warning, and rapid response to health threats. We have also promoted cooperation between countries, especially in areas where disease cross borders. Our message is clear. Disease elimination must remain an African priority, led and owned by our member states. This means strengthening national leadership. It means increasing domestic health financing, and it means building health systems that can continue to deliver results for our people. The commitment of our head of states, including the Abuja Declaration and our African Union roadmap towards 2030, give us strong political declaration and direction. Our responsibility now is to turn this commitment into action at country level. We also need to work together across different diseases. Our triple elimination agenda is a good example. Through this agenda, we are working toward eliminating the transmission of HIV, syphilis, and hepatitis B from mother to child. This integrated approach helps us use our resources well. It also helps us provide better services to mother, children, and families. Excellencies, Africa has shown strong commitment and resilience in recent years. Many of our member states have continued their health programs while facing important financial challenges. I would like to sincerely thank our partners and founders who have continued to stand with us and support Africans' effort. At the same time, we are strengthening our own capacity. We need to increase domestic financing. We need to strengthen our health system. This is also about health sovereignty. Africa must have the capacity to protect the health of its people and to respond to health threats with confidence. Today, we recognize countries that have successfully eliminated disease. Let us celebrate their achievement as a source of hope for the whole continent. They show us that with political will, strong leadership, country ownership, and partnership, disease elimination is possible. The African Union Commission remains fully committed to this journey. I thank you for your kind attention and wish you very fruitful deliberations. Thank you.
Thank you very much. Thank you, Your Excellency. Disease elimination is possible, and disease elimination must remain an African priority, and we must have the systems that deliver. Thank you so very much. Now I have the honor to bring to the microphone Dr. Abdulrahman Diallo, the Director for Program Management in WHO African Region. Dr. Diallo, you have the microphone.
Thank you, Dr. Kalu. Excellencies, ministers, heads of delegations, partners, colleagues, friends, distinguished guests, good evening. On behalf of the Regional Director, it is a pleasure to welcome you to this side event on multi-disease elimination in Africa, celebrating gains and accelerating progress. This evening gives us an opportunity to recognize what African countries have achieved, to reflect on the challenges ahead, and to consider how we sustain and accelerate progress. Let me begin with some encouraging news. 9 African countries are now free of trachoma, with the recent addition of Burundi, Mauritania, and Senegal. Niger has become the first country in Africa and only the 5th in the world to eliminate river blindness. Guinea and Kenya have eliminated sleeping sickness, bringing the regional total to 10 countries and reducing cases by 98% since 2000. Botswana has become the first high HIV burden country anywhere in the world to achieve WHO Gold Tier certification for eliminating mother-to-child HIV transmission. And Cape Verde, Mauritius, and Seychelles have become the first countries in sub-Saharan Africa to be verified free of measles and rubella. These achievements are a tribute to political leadership, committed health workers, engaged communities, and strong partnerships. They also reflect the vision set out in our regional strategy ending disease in Africa. We should take pride in this progress. We should also recognize the context in which it has been achieved. The past year has been one of the most difficult financing periods our region has experienced. Reductions in external support have placed many programs under pressure, yet countries have continued to deliver important results. The financing environment is evolving. Major global health partners are shifting towards sustainability, domestic investment, country ownership, and integrated approaches. That calls for a different way of thinking about disease elimination. Our recent experience points us in the right direction. The diseases we are working to eliminate may be different, but the systems that support them are often the same. Strong surveillance, quality laboratories, reliable data, community health services, primary health care. Investments in these shared foundations strengthen many programs simultaneously. They improve our ability to detect outbreaks earlier, respond more effectively, and deliver better health services for our populations. This is the rationale for a multi-disease approach. It encourages us to strengthen common systems rather than working in silos. It supports greater integration within primary health care. It also reinforces collaboration across sectors, recognizing that many of the factors influencing health lie beyond the health sector itself. The challenge now is to maintain the gains and help more countries achieve them. This requires stronger national systems, sustained domestic leadership, and continued partnership. It also requires that countries remain at the center of decisions about their own priorities, investments, and pathways towards disease elimination. Over the next 90 minutes, you will hear from ministers whose countries have reached important elimination milestones or from their representatives. You will hear from our partners about the changing financing landscape, and you will hear how shared investments can help countries protect recent gains while accelerating progress towards new ones. Our aim this evening is to leave with a shared understanding of the priorities before us and a common commitment to the next phase of disease elimination in the African region. The Addis Ababa call to action will help provide that shared direction. I look forward to a productive session and thank you very much. Over to you, Dr. Kalu.
Thank you very much, and thanks for keeping to time. To provide the setting, the broad perspective on where the African region stands today in the journey towards multi-disease elimination, I'm pleased to bring to the podium Dr. Benindo, who is Director for Disease Prevention and Control in the Africa Regional Office of WHO. And before he begins to speak, it's my pleasure to welcome Dr. Franklin Asier-Dubeko, Director of Public Health, Ghana Health Services. Please come right up to the high table and take your place. Yes, Benindo, you have the floor.
Bonjour à tous. The room is quiet. Hein?
Bonjour.
Bonjour à tous. Good afternoon or good evening. I don't know what the time is. Bon tardi. I'm not listening. We are too quiet. So, Monsieur le ministre de la Santé du Niger.
Minister of Health of Niger, Excellency Ministry of Health Cabo Verde, ministers present here, the partners. We have Richard representing Gavi, Poland, Gates Foundation, Robert, UNITAID, the colleagues and participants. We have just finished the session on Ebola, And the main objective when we have a Ebola outbreak is to control this outbreak, of course. It's one of the expected results. However, we have some diseases that we can eliminate or eradicate. And for a Minister of Health or a head of in the health department, you face a series of public health issues. Often we have diseases, outbreaks, issues related to human resources, issues related in strengthening health systems, issues related to financing. But now if you imagine what is expected from a Minister of Health, specifically from the population, but also from the ones nominating the minister, designating the minister, is to show there are tangible results that are achieved. And these tangible results may not be the trainings that you have conducted. One of the main tangible results is to show that we were able to eliminate a disease or eliminate several diseases at the same time. So for a Minister of Health, if you manage to eliminate one or more diseases, as you have seen in the previous video, it is a huge celebration that follows, which is not only a success for the Minister of Health, but for the country as a whole. Now, if we take Niger, for instance, Niger currently is the only country in Africa to have eliminated onchocerciasis. And this, a round of applause for Niger. So the objective of this session is to take stock on the elimination of diseases, what it takes in terms of cost on eliminating diseases, but also what is the cost of not eliminating these diseases, and finally, a series of actions that are required to eliminate diseases. Next slide, please.
At the end of this session, 4 key messages. We all know the African region is plagued by numerous infectious diseases. But despite the financial constraints, despite all the challenges, the WHO African region has been able to eliminate a number of diseases. So our first key message here is the elimination is possible in Africa. And we've been able to document that elimination. The second one, in terms of the return on investment, elimination is one of the key public health results where you can quickly see a return on investment. One of the things we need to be aware of, for all the countries that have been able to eliminate at least one disease, there are 6 conditions that should be met. And I'll provide you some details around these conditions. And lastly, even when you have been able to eliminate a given disease, you need to find a way of sustaining that status, because if for some reasons you are not able to sustain the status, the certificate will be basically removed. So these are really the 4 key messages we would like you to get out of this specific side event on multi-disease elimination. Next. Now, in terms of where we are as far as the elimination is concerned in this region, you know the WHO African region is made up of 47 countries. Of those 47 countries, 46 have been able to eliminate, eradicate, or control at least one disease. If we look at the NTDs, We have close to 23 countries that have been able to eliminate at least one neglected tropical disease. Trachoma, we do have 10 countries over the past 42 years that have been able to eliminate trachoma. When it comes to measles and rubella, Capo Verde, I think they are here, Mauritius and Seychelles have been able to achieve that milestone. When we go to malaria, Algeria, some years ago, Mauritius, and more recently Cape Verde have been able also to eliminate malaria. When it comes to immunization, on the maternal and neotetanus elimination, we have most of our countries, 35 out of 47 have been able to achieve that status. One of the most interesting parts is, despite our struggle in the continent, we are first in a number of areas. I mentioned Niger, which is the third country in the region that had been able to achieve the elimination of onchocerciasis. Guinea and Kenya were able to eliminate human African trypanosomiasis, especially the Gambiaceae and the Rhodesians. Capo Verde, it's in this region the third sub-Saharan African country that was certified malaria-free. And Dr. Kalu mentioned also for Botswana being the first high-burden country that has been able to achieve the worldwide gold tier for the elimination of maternal to child transmission. So this just tells you we've been able to eliminate some of these diseases. Now, when you look at the typology of these diseases, it goes from NTD to malaria, which means if you would like to address the multi-disease elimination, there will be need for shared investment in a number of areas. I'll come to that later on. Next slide. It costs when you want to achieve elimination. So the cost of action versus the cost of inaction is highlighted in this slide. When we look at NTD, modeling suggests that from 2015 to 2030, if you are able to eliminate most of the preventive chemotherapy and case management NTDs, we can have a return, a benefit of in terms of billions. So it's close to $300 billion US. However, if we don't manage properly some of these diseases, it costs, and the cost is expressed in terms of billions. You may all recall the major Ebola outbreak in West Africa, which basically costed close to $53 billion US. So once again, it just highlights the need for focusing on multi-disease elimination in this continent. Next slide. When it comes to what makes it possible to achieve elimination, we've seen a number of countries achieving that status. As part of the literature review, part of the discussions with member states, there are 6 conditions that should be met when a country needs to pursue elimination. One is the political ownership, as you can imagine, having a budget, domestic budget lines, network of laboratories, which can now not only facilitate the diagnosis of NTDs, but also measles, malaria. The critical role of community as a delivery systems, the alignment of partners, we've been discussing that over the past 2 days, but more importantly, the importance of data. If you don't have the data, you cannot prepare a dossier for elimination. If you don't have the data, it's very difficult to have the surveillance working. If you don't have the data, it's very hard to demonstrate that the elimination was achieved. So the investment in data becomes critical. Next slide. So we all know, like I was saying, it costs a lot of money to pursue the elimination goals. One of the areas which we believe may require our collective attention, it's really the surveillance, like I was saying, which is critical even for the post-validation, the laboratory networks, data like I mentioned, supply chain and last mile, the country-led coordination and accountability. So we all know sometimes in terms of partners financing some of the areas, we usually focus on vertical kind of programs, but I think these cross-cutting areas, when you look at some of the funding being provided, there's a possibility of reviewing those funds and making sure that the cross-cutting areas can be funded so that it will help not only address one disease, but multiple diseases. So our suggestion will be whenever proposals are developed, please ensure that some of these cross-cutting areas are factored into those proposals so that you can at least take the benefit of using like the same laboratory to diagnose and confirm multiple diseases. Next. To conclude, if there's one ask, we are asking, one ask here, it's really the, as you can imagine, for you to, the way our ministries or even agencies are structured, integration can be a challenge. The cross-cutting funding of specific areas can be a challenge. So what we are suggesting is for us to ministers to adopt the suggested Addis Ababa call to action, which basically describes what is needed to achieve the multi-disease elimination. With that, I would like to thank you for your attention.
Thank you, Dr. Mpuma. Again, multi-disease elimination is possible. Examples of countries that have achieved it, some with multiple diseases, has been given, and also the 6 conditions that must be met to achieve multi-disease elimination in a country. Earlier on, we were told we need a roadmap, and that roadmap must lead us to meeting these 6 conditions in each country. The essence of that presentation is to set the scene before we now dig down into the countries. And that is the next session we are going into. The ministers and heads of delegations who are seated on this high table, we have to tell us about their experiences in multiple disease elimination. We will start with Niger Republic, and it's my pleasure to invite His Excellency Colonel Major Dr. Garba Hakimi, Minister of Public Health, Population and Social Affairs of Niger, to share with us what Niger became the first African country to eliminate onchocerciasis. The question, Your Excellency, is this: what political and programmatic decisions were most critical to reaching these milestones, and what is needed to protect this gain? Your Excellency.
Merci, Monsieur le Modérateur. Chers participants.
Thank you, moderator. Dear participants, it's with pleasure that I take the floor during this side event on the elimination of diseases in Africa, celebrate results, imagine, of the 76th session of the Regional Committee. Allow me to thank all the organizers for inviting us in this meeting to share on this thematic area. I'd like to use this opportunity to express our gratitude of Niger to the WHO General Director for officially announcing the elimination of Kusikros by our country as the first African country. I would like to remind us all that this celebration is the result of a huge effort with strong leadership of the highest authority of the country, the commitment of all stakeholders in the country, technical partners, and the various communities. After the elimination, the challenge is to keep the status and go towards the certification of eliminating other diseases such as trachoma, malaria, and lymphatic diseases. And regarding post-elimination of onchocerciasis, we are in a stage of post-elimination surveillance until we are able to eliminate the transmission of the disease to neighboring countries to avoid recurrence of the disease in line with the recommendation of WHO. This requires a full involvement of all health sector stakeholders. And at the first place, we have the beneficiary population. This surveillance is required because we have huge borders, big borders that we share with Nigeria, for instance, more than 1,700 kilometers. We also share border with Benin. We also share borders with Burkina Faso and Mali, for which the risk is less because they are far away from the risk areas in Niger. In this regard, several actions were carried out, mainly. First, the development of an action plan with the health districts and regions regarding cross-border surveillance. We also did the mapping and the update of border villages at risk, the training of 108 health officers in all border health facilities with neighboring countries on post-elimination surveillance of this disease. We have also the identification of risk sites of reappearance of onchocerciasis in or beyond our borders to strengthen our follow-up. The establishment of an integrated surveillance plan during cross-border meetings organized during the preparation of mass immunization campaigns, the organization of sensitization or awareness creation campaigns on post-elimination surveillance in cross-border villages, the training of 102 community officers in borders areas in terms of elimination of this disease, the regular update of various activities in collaboration with cross-border agents, the organization of various meetings with villages nearing the borders, capacity building of laboratories to conduct adequate tests when we discover OV150 ADN during our surveillance, strengthening of communication between cross-border health facilities of neighboring countries, the establishment of guidelines on managing rumors, the availability of community agents on integrated supports on early detection of cases, and finally, the follow-up of data related to the disease reported by EDHS. Niger is well determined to take all the necessary action so that this success that we achieved is an example to strengthen the fight against other diseases and keep our status. We are well advanced in the process to eliminate the trachoma, for instance. By way of conclusion, I would like to express my gratitude to all partners who have supported us in terms of achieving this result in eliminating onchocercosis, and invite them to continue their support to not only to maintain our success, but also continue supporting us in our fight in eliminating other diseases which are a health burden in our country, for their elimination and control. Ladies and gentlemen, I thank you.
Thank you, Your Excellency. This is very interesting. He said that the commitment of all stakeholders, government and partners, was central to the success recorded, and capacity building at all levels, especially at the cross-border areas. This is fantastic. Now, we'll move on to the next country. Cabo Verde was one among the first countries in sub-Saharan Africa to eliminate measles and rubella. And so here we have His Excellency Dr. Lucio Miranda Fernandez, Minister of Health, Cabo Verde. Your Excellency, I'd like to know what lessons can other countries learn from Cabo Verde that you think is central to the success you recorded? Over to you, Your Excellency.
Sua Excelência,
Your Excellency, the President of the session, Your Excellency, the Regional Director of the WHO for Africa, Your Excellency, dear Ministers of Health, honorable guests, ladies and gentlemen, allow me to start by thanking the WHO for the opportunity that is given to Cape Verde to share its experience in a topic that is very important for the public health, which is the elimination of diseases. Cape Verde has a good history in public health, and it's an example that the elimination of multiple diseases, it's possible when we have political commitment, consistent investment, and high coverage of vaccines, and robust epidemiologic work, and strong involvement of the community. In less than 10 years, our country reached 3 important milestones. The certification of a country free of polio in November 2026, the certification of elimination of paludismo or malaria in January 2024, the certification for measles and rubella in 2025. This was possible, but it's not the end. It's an incentive for us to keep working and take the ambitions of the public health forward. I want to use this opportunity in this committee to announce that Cape Verde takes the challenge of preparing the process in order to get the certification for elimination of vertical transmission for HIV. It's an objective that it's possible to reach thanks to the work that the country is undertaking on this topic. For 7 years now, that Cape Verde does not have new cases of vertical transmission for HIV. In this context, we are going to request the technical support of the WHO so that together we can reach this important milestone for Cape Verde and for the African region, showing once again that the elimination of diseases it's possible when there is leadership, investment, and perseverance. The results mentioned, they show that even if you are a small state, it's possible to reach huge milestones in public health when there is strategic vision, public policies, strong institutions, and a coordinated action between the government, health professionals, the international partners, and the communities. It's a great honor to be able to present in this session the voice of our country, showing that regardless of the size of the country or the available resources, when there is political leadership, consistent investment in public health, and strong community mobilization, it's possible to reach extraordinary results. In January 2024, Cape Verde became the third African country and the 42nd country to get a certification from the WHO for the elimination of malaria. This represents more than an international recognition. It represents decades of persistent work, dedication of our health professionals, investment of the state, the support of international stakeholders, and active participation of the community in our country. The success of Cape Verde focused in 5 important pillars: strong political leadership that put the elimination of malaria as a national priority and made sure that we have public policies during all the years. In the second place, a robust system for surveillance that was able to identify cases, identify the origin, and come up with an immediate answer to avoid any case of transmission. Third place, the integration of the control of vectors. We worked in the implementation of measurements for prevention, looking at the reality of each island. In the fourth place, we have also strengthened the information, making sure that we have early diagnosis and universal access to the services in all the territory. And finally, the involvement of the communities. And since no public health strategy is long-lasting, it's important to involve the community. The certification for Cape Verde in January 2024 was an important milestone to the country and to the whole region in Africa. Cape Verde became the first African country to reach this certification, showing that the elimination of the disease is a possible target whenever we have political willingness and sustainable investment. It's also important to state that the certification is not the end of the work. It is the beginning of a new responsibility. We need to preserve this status. In a world where we have climate change, we have persistent reduction of finance, the risks are very high. It was for that reason that the government of Cape Verde has set as priority to protect the milestone reached. In the scope of the project of the government, of the program of the government, we want to make sure that we keep these rapid mechanisms in order to support all the clients. We are investing strongly in searching the entry points in the country. We are training the professionals, and we are also making sure that we keep the community aware. But we also learned an important lesson. The elimination of malaria does not depend only on the health sector. It requires a multisectorial vision. It requires good sanitation policies, water supply, good urban organization, and social mobilization. It was with this integrated vision that we have promoted a campaign in the country to clean it. And this was done in all the municipalities of Cape Verde, making sure that we involve the army, the social protection, the firefighters, the private sector, and all the citizens. It was an important action, but we also tried to make sure that people understand that prevention is very important. And we are very happy to say that this movement is bringing very positive results translated into campaigns to clean the country. And this is done by the community associations, churches, NGOs, and several entities in the civil society for different places in the country, reinforcing the message that the prevention starts in each community and that it should be part of the daily activity of everyone. And we know that to eliminate mosquitoes is very important. In fact, it's the best way to avoid malaria and other diseases transmitted by the mosquitoes. We are also investing in digital transformation, in strengthening the systems of health and also surveillance that are state of the art, integrated and based on data. Your Excellencies, the experience of Cape Verde shows that the elimination of disease is not a result of isolated measures. It's a result of political policy, surveillance in the population, in institutional coordination, and the capacity of the countries in keeping surveillance levels even when we don't have cases. For that reason, I would like to use these opportunities to thank the WHO, our international partners, and all the health professionals in Cape Verde that during all these years made this possible. Our priority is very clear. Not only keep Cape Verde free of malaria, but also keep investing so that all the African regions can also move towards the elimination of these and other avoidable diseases. Because we believe that public health does not know borders, and we believe that the success of a country can inspire the success of the whole continent. Thank you.
Thank you very much, Your Excellency, the Minister, sharing your experience of Cabo Verde in multi-disease elimination. Again, talking about commitment, political leadership, robust surveillance system, rapid response, multi-sectoral approach. These are lessons that are emerging that we must integrate in that our roadmap. Now it's my pleasure to invite Botswana, Dr. Ratile Mfokeng Selei, who is representing the Minister of Health of Botswana. And my question to you, Excellency Dr. Ratile, is this. Botswana has achieved gold tier status on the path to eliminating mother-to-child transmission of HIV. What governance and accountability mechanisms were most critical to this achievement? Thank you.
Thank you very much, Chairperson. And I'm honored to be representing my Honorable Minister to share the experience of Botswana in this important conversation. Before I continue, I wish to congratulate the member states that have reached their elimination goals. This signifies a better quality for the lives of our people and the progress in our continent. It is indeed proof that Africa can eliminate some diseases, but as alluded to, this is now bringing us a challenge to ensure that we protect the gains we have made, to prevent reversal, and to build health systems that are capable of sustaining the elimination. Botswana is proud to become the first African country with a high HIV burden to achieve WHO validation on the path to elimination of mother-to-child transmission of HIV. And in 2025, we attained the gold tier status. This achievement for Botswana was not the result of a single intervention. It was a product of sustained political leadership and commitment at the highest level of government. Domestic investment on ARVs and other commodities, strong health systems with strong community involvement, evidence-based policies, and strong partnerships. Botswana's achievements have been strengthened through collaboration with To name a few partners: WHO, UNICEF, PEPFAR, the Global Fund, and civil society organizations and other implementing partners. These partnerships have contributed to service delivery, commodities, technical assistance, health worker capacity, quality improvement, to name a few. At the same time, communities remain central to sustaining our gains. EMTCT depends not only on the availability of services, but also on women and families accessing care early, remaining in care, and receiving the support required to achieve optimal health outcomes. It is therefore in that regard, Chairperson, that Botswana would like to make 3 commitments today. For Botswana, goal status is an important milestone, but it does not mean that the work is done. We understand that elimination and sustainability require us to maintain the systems that made success possible. These systems included or yielded us high coverage of testing and treatment, viral suppression, early infant diagnosis and follow-up of mother-baby pairs, reliable commodities, quality data, and accountable service delivery. It is therefore why our first commitment today is to protect the domestic investments required to sustain our elimination gain and to use our 2027 validation process to not simply be an assessment, but as an opportunity to strengthen the systems that will sustain elimination over the long term. Chairperson, we cannot afford to build a separate system for every disease we seek to eliminate. Botswana's experience has shown us that same platforms that deliver multiple health can deliver multiple health gains. We are therefore building on our EMTCT experience by integrating elimination of HIV, syphilis, hepatitis within maternal and child health services and primary health care. Our approach is to bring screening, diagnosis, treatment, and prevention closer to point of care. A woman should not have to navigate multiple programs to receive comprehensive care. This health system must bring integrated services to her. It is therefore why our second commitment is to accelerate integrated elimination within routine maternal and child health care services. Finally, Chairperson, the financing environment requires us to move from fragmented disease-specific investments towards shared investments in public health. The systems that support HIV elimination should support syphilis and hepatitis elimination and many other health priorities that we have. These are precisely the cross-cutting areas that have been talked about today and present opportunities for greater alignment and co-investment. It is that regard why our third commitment is to work with other member states and partners to advance integrated Botswana-led approaches to multi-disease elimination and to support greater alignment and efficiency in the use of available resources. As I conclude, Chairperson, it is clear that elimination is possible, but we are now at a critical juncture. We must move from validation to sustainability, from vertical programs to integrated platforms, and from fragmented investments to shared health system capabilities. For Botswana, we are targeting, of course, triple elimination of syphilis and hepatitis B alongside MTCT. Additionally, we are exploring how the investments that we have put up to eliminate those could lead us to elimination of malaria, measles, some select NTDs. Collectively, we believe we should leave this meeting with a commitment to protect the gains we have made and accelerate the next generation of elimination. I thank you, Chair.
Thank you very much. Thank you, Botswana. Great job and great commitment to integrate multiple diseases in their program. We are running out of time, so as we move forward, please use your 2 minutes wisely. It's my turn to call on Dr. Franklin Asiedu, Bekwe to share Ghana's experiences with integrated approaches. Your Excellency, Dr. Franklin, please, you have the microphone.
Thank you very much, Mr. Moderator, and good evening to everybody. I need to state that if you look at the presentation, Ghana does not belong to maybe the recently eliminated countries. We actually eliminated trachoma in 2018, and then sleeping sickness in 2023. So the idea is that why are we on this platform? And I think what is most important is the sustainability of your status. You can be eliminated, you can eliminate a disease condition, but then you may revert. So it's very important that you get your interventions right to maintain your status. So for Ghana, one of the things that we have been doing over the period is to try and move away from vertical programs to be more horizontal or more integrated. And I need to state that if you look at the health system that we have in Ghana, let's say at the national level, you have a lot of programs being vertical. But as you go down, it becomes, they tend to converge to each other because they are the same persons at the chief compound, at the sub-district, or the district who are managing measles, hepatitis, onchocerciasis, or what have you. So the idea is, how do you make sure that they work together to ensure the common good? So one of the things that we try to do at the national level is that for the NTDs, we try to merge some of them. And the idea is that if you look at broadly the NTDs, you can see that there are two main NTDs. So the PCs and then the case management NTDs. So we try to make sure that you have these two groups. And the essence of it is to ensure efficiency. In the era that we have very limited finances, you need to make sure that you make good use of your resources. So that's one thing that we try to do. And I need to state that we try to make sure that we use the district as the main area or focal point for our interventions. Because when the district is well knowledgeable of the issues, then clearly you can get the right things done. And the other intervention is that you need to use common approaches. So the home visits that the committee of nurses do. So what we've done is that we've tried to make sure that they have cards that has the pictures, that have simple definitions on them, that helps them to make sure that they'll be able to identify these conditions as early as possible. And I need to say that at the national level, you have a big umbrella body, which is the Inter-Country Coordinating Committee. So that ensures that there's a coordination of NTD activities in country, and that aligns us with our national NTD master plan. That ensures that we get the ultimate results that we need. So for us as a country, we are using this broad approach of making sure that we become more horizontal.
You have 30 seconds left.
Than being vertical. And I'll say that for the fact that for the past 8 years, we have not gotten any cases of trachoma, we have not gotten any cases of sleeping sickness, tells us that our approaches that we are using are working. Thank you very much.
Thank you very much for keeping to time. And we've been listening to countries sharing their experiences. You've heard about political commitment, domestic financing, coordination mechanisms, partnerships, cross-border collaboration, and other strategies that are used in the countries that they've shared their experiences. These are the things we wanted to hear, and that is why we brought them to share with us. Your Excellencies, thank you so very much for sharing these experiences. Please, let's applaud the countries, the ministers, and heads of delegations. And so that brings to an end this session on hearing from the countries. We will shift to hear from partners to share their own experiences on how they see themselves, the partnerships and investments going forward. How do we sustain progress? How do we accelerate impact? So that is the section we are going into. And it's my pleasure to welcome our partners to the high table. The first is the Deputy Director General of the Africa Center for Disease Control and Prevention is here, and that is Dr. Raji Tajuddin. Please welcome to the high table, Dr. Raj. You are welcome indeed. See here. I saw him coming. Oh yeah, he's here. Thank you, Dr. Raj. Then our very own Dr. Richard Mihigo, Director, Regions Advocacy at Gavi. Please welcome Dr. Richard. We'll hear from Gavi again. Then we have the Director of Africa for Gates Foundation, Dr. Pauline Basinga. Please come right on to the high table. Then we have Ms. Claudia Ahumada, Acting Head, Political and Civil Society Advocacy, Global Funds to Fight AIDS, TB, and Malaria. Please welcome Claudia. And then we have Mr. Robert Matiru, Director of Program Management, Unit 8. Okay. So welcome, Excellencies, colleagues, friends, family. It's our pleasure to welcome you to this session. And each person will have about 3 minutes to answer specific questions, and we'll start with my brother from Africa CDC. And looking at the continental priorities, what in your view is most needed to strengthen country ownership and domestic financing for multiple disease elimination?
Yeah, Excellencies, colleagues, ladies and gentlemen, allow me to first and foremost congratulate WHO for what has been a hugely successful RC 76 so far, and really thank WHO again for inviting Africa CDC to be part and parcel of this discussion. And allow me to also congratulate member states who have actually made significant strides when it comes to disease elimination, from those neglected tropical diseases to the malaria that we all know as we listen to excellencies, from around the table. Now, back to your question, my big brother, the moderator for this particular session. As we are all aware, in February 2025, our head of state and government here in Addis Ababa, Ethiopia, endorsed the Africa Health Security and Sovereignty Agenda. Disease elimination is actually integral to that particular Africa Health Security and Sovereignty Agenda. And there are 5 critical pillars underpinning this agenda, for which health financing is one of them. And now, since you have asked me to really focus my discussion around the role of financing when it comes to disease elimination, I would like to underscore the criticality of domestic financing when it comes to disease elimination. As we heard from the previous speakers, there's so much vertical programs when it comes to this disease elimination. And comes with vertical, programs is also the fact that resources are not streamlined. There's a lot of wastages. So I think the first thing we need to do is to streamline resources, as we've seen with Rwanda, we've seen with Ethiopia, the so-called one country, one budget, one plan, one M&E. If there's any place where that one country, one budget, one plan is really, really applicable, is when it comes to this disease elimination. So tied to that is the fact that even after we have been able to successfully eliminate disease, when it comes to the post-elimination strategy, finance is also at the core, of that. And this is where I would like to, inform or really crave the distinguished indulgence of our partners that the fact that disease has been eliminated does not mean we take away the fund. In fact, that is when we need to pump in more funding, because when you look at post-elimination strategy, what are we talking about? You need a very strong surveillance, that is underpinned by what? A lot of financing. You need a digital health, digital infrastructure that will allow you in terms of data and analytics. That cannot happen without adequate financing. You also need a very strong community engagement, after you've eliminated disease. Again, you need finance to be able to do that, Again, you need a very strong lab systems, even after you have eliminated the disease. So all these call for what? More and more, resources. And last but not the least, you need a very strong primary care system, that is pandemic ready, climate resilient, and domestically financed for you to be able to maintain the gains of whatever disease we've been able to eliminate. So let me stop here, and thank you again for the opportunity.
Thank you very much. I'll move over quickly to Gavi. Under the Gavi 6.0 strategy, how will support help strengthen sustainability and country ownership across the region? This is to you, Dr. Richard.
Yeah, thank you very much, Dr. Kalu. And let me, like my colleague from Africa CDC, first thank really WHO for putting on the agenda this very important agenda item. Disease elimination, disease eradication, multi-disease elimination, as we have heard in the presentation made by Dr. Benito. I think it's something that is really at the core of the Gavi mission. And we were very happy to the invitation we received, so thank you. Let me, before even maybe going into the details of what we are doing, to just give a bit of the context on how we are supporting disease elimination across the board. So since the beginning of this year, Gavi, the Vaccine Alliance, we launched our sixth 5-year strategy, which is now commonly known as Gavi 6.0. And at the heart of this new strategy period, we have really tried to put the country needs, the country aspiration and priorities at the center of the implementation strategy. So Gavi 6.0 has fundamentally simplified how country can access and manage funding in order to support their disease elimination or control goal. I would just like to give you 4 numbers that carry that story. Number one, and we have been communicating this to the countries that are present here, we have moved from 8 to 1 funding lever only, providing a single cash grant to the countries. And into that one cash grant to the countries have the flexibility to decide how to allocate this cash grant. And I heard about all the priorities that are needed to be put in place to either attain or sustain the progress made during an eradication process. Number 2, we have tried also to accelerate the timeline from the application process to the delivery. Coming from a process where this was taking more than a year, we are aiming now to reduce the timeline from application to delivery at a minimum 6 months. Number 3, one of the constraints that we have seen and country have quite reported heavily in the past was the complexity and multiple requirements in our grant application process. So what we are trying to do, we have combined most of these things from 6 different application guidelines to 2 application guidelines, which will aim at reducing by 3/4 all the application requirements, making it very easy for countries to access the grants that we are providing. And then finally, we are moving from a multiple number of applications, close to 680, to only 57 applications, which means it will be only one application per country, which will help country to have fewer applications, fewer documents to draft, etc. So with this new model, we are going to continue to actively support country-led disease elimination goal. We are a full member of the Polio Oversight Board, and we will continue to support the polio eradication goal. We will continue to support the measles elimination goal by funding both the routine immunization, which should be the foundation of any elimination disease prevention target, but also to provide the necessary resources for all the measles and rubella catch-up campaign. We will as well continue to support the goal of maternal neonatal tetanus to make sure that the remaining 12 countries, as we have heard during Dr. Benizzo's presentation, that need to achieve this elimination reach their goal. Finally, Dr. Kalu, we stand with WHO, UNICEF, and other partners in this country-led multi-disease elimination goal, and Gavi will always be there to support this initiative. So I thank you.
Thank you very much. Thank you very much. You can see our partners who provide this seed funding while we are driving domestic financing in our countries. The money has to come from within our country. We have to leverage resources that are available using the external funding as seed grants, more or less. Thank you, Dr. Richard. Now may I invite Dr. Claudia Pauline first. Pauline Basinga, the question is this: where is the foundation seeing the greatest impact, and how are your priorities evolving in today's financing landscape? Pauline is representing Gates Foundation. Over to you.
Thank you very much, moderator. I'll also start as my colleague Taj and Richard to really thank WHO, but also very specifically thank the country that chose really great example. Cape Verde, Niger, Botswana, Ghana. I really hope that WHO will make this session videos available for the multiple students in public health and School of Medicine across Africa to actually see what is happening on the continent. Because sometimes we teach them things that are, sometimes, outdated, and they are not seeing exactly the progress that you all are making. So really, congratulations. Very briefly, I would say that the Gates Foundation is very, very pleased to be invited to this session. And as you know, our chair and the CEO and the board have made a decision to close the foundation in 19 years, in 2045, because they strongly believe that most of the diseases that we are dealing with are going to be eliminated. We strongly believe in elimination and eradication. And this session is exactly the kind of thing that we strongly believe in. And if we continue to really drive this focus, discipline, execution, partnership, and really continue to drive innovation in terms of how we implement programs, we're going to eliminate many diseases. So we have three big goals. Number one is to really eradicate or decrease maternal and neonatal mortality significantly. The second one is to really drive down most of the infectious diseases, starting by polio, which we are very, very close in partnership with many of the partners that are here, malaria, and many of the NTD diseases. And the third one is really to lift as many people out of poverty. We know that all these diseases that we're talking about trap many of our people out of poverty. So as you can see, elimination and eradication are core to what the foundation does. But also one thing I wanted to add is the fact that both at the global, regional, and the country level, there's something that is happening now. Domestic funding are needed most, and the fiscal space for government is shrinking. The ODA is decreasing quite significantly. There is an emergency of AI, but most importantly, all of us, we have a huge responsibilities, and we heard it from the ministers, to really think about how we deliver program differently from the global level. Even as at the Gates Foundation, as you know, we're organized in quite a vertical way, disease by diseases, but we are doing our best to strengthen our presence on the continent so that we can show more and more in a very coordinated way. We're not going to remove the target in terms of really picking disease by disease and looking at what is needed to eliminate those diseases, but we're going to be more intentional as we engage with countries. Also at the regional level, there is a need for WHO, Africa CDC, all the other partners, AMA, etc., to work in a way that they all support countries so that we can actually achieve the goals. Even at the ministries of health, most of the time, the countries that have been able to achieve eradication, you can see that when you go to the Ministry of Health, there are not many cars that are going to do different campaigns. They've been able to integrate, not for the sake of integration, but really looking at how we achieve the goal. It's how we organize our ministries, how we organize our programs. It's not to eliminate all the vertical program, but it's to be really intentional in terms of the goals. We know if we need to eliminate a disease, what is the target? What are the data we need to put in place? The surveillance, the teams that we need to build. How do we engage community so that at the community level, we don't have a community health worker who's in charge of malaria, one for onchocerciasis, etc. We can actually cut the cost of doing business by actually doing integration when it matters. And if we need to continue some vertical to achieve the goal, we can do it. I'll close by saying, as I was listening to the Minister of Health from Cape Verde, it reminded me the World Cup. You know, we all watched the World Cup. You saw what they did. It was impressive. They kept their goals. They did a lot. But one thing that we need collectively to do as Africans is to make sure that that 87 minutes where we almost give up, so that we didn't get to the goals to actually win the World Cup, we stop it in terms of diseases. We need to focus, keep disciplined implementation of our program. I think we'll be able to actually get rid of polio, get rid of most of the NTDs, really increase coverage of our immunization, as Richard was saying, and then we'll be able to actually make sure that the young people that are being born, Africa will be the continent that will have most kids so that our kids will survive more than 5 years. They will be the future of this world. So thank you very much, and I can assure you that the Gates Foundation will continue to be your partner for the next 19 to 20 years to really help you eradicate more diseases. Thank you very much for having us.
Thank you. With multi-disease elimination, you probably will not need the 20 years. Now I come over to you, Ms. Claudia Ahumada from Global Fund. The question I have for you is this. With Grant Cycle 8, how is Global Fund supporting sustainability while ensuring countries are not left with unfunded responsibilities during transition? Over to you.
Thank you very much. Since you mentioned Grant Cycle 8, I do need to start with acknowledging the tremendous partnership that we have established with WHO Afro, where they have been helping us in reviewing the priorities for Grant Cycle 8, working across countries to make sure, one, that we are actually led by what countries across the continent tell us is needed, but then two, that there is a coherence with the data and the evidence that WHO Afro is putting forward. So thank you for that. Now, in terms of how we are ensuring sustainability, I would make 3 key points. The first one, this dichotomy that we talk about a lot between vertical and horizontal health programs is, to a degree, false. No. The Global Fund to fight AIDS, tuberculosis, and malaria, one can think, oh, you work on these 3 diseases. We do, but not just that. And you see this all working in your ministries, no? The Global Fund, yes, we invest in the 3 diseases, but at the same time, we are, and we have been for the last 8 years, the biggest investor in pandemic preparedness and response. We are also the biggest investment in health system strengthening. Why? Because what works to prevent and to address one disease helps to prevent and address other diseases. And we're seeing this in Ebola. We talked about it earlier in the Ebola session. When you're addressing Ebola, you are also necessarily addressing other diseases such as malaria. So that's number 1. Then the second thing in terms of sustainability is around efforts to integrate. No, We need to be looking at how we integrate our responses, the offers that we put forward to our communities. Though we know that as human beings, as women, as men, we face a myriad of health issues, and continuing to address them separately doesn't work for the reality of people's lives. And that has to be our key driver, no? How does integration help us achieve better health outcomes? Not how many organizations can we collapse into one? How many programs can we collapse? How much money can we save? That cannot be the driver of our integration effort. It really has to be about improved health outcomes. And then last but not least, the key to sustainability at the end of the day is your leadership. No? Organizations such as the Global Fund, such as the Gates Foundation and others, we will come and go in time. The countries, your leadership, your governments, your communities, that is what is going to stay. That is what is going to make sure that whatever elimination we achieve today continues to be a reality tomorrow. So looking again to your leadership and how we can continue to support that for sustainability. Thank you.
Thank you very much. Thank you. And now, Mr. Robert Matiru, in one word or two, which innovations in Unit A's portfolio do you believe holds the greatest potential for scaling impact across multiple diseases in Africa? Which innovations? Over to you, United.
Thank you, Mr. Chair, and thank you to WHO Afro for convening us here and for this important session. And thank you to the Honourable Ministers and Excellencies and other colleagues for setting the scene earlier. Time is not on our side, so I won't give word or two, but I'll give at least a couple of examples to answer your question. In our view, the tools that are closest to multi-disease scale are the ones that ride on infrastructure that countries have already built. So let me give the example of multi-disease molecular testing platforms. This continent already owns thousands of gene expert machines, for example, that have been introduced with the funding of partners as well as governments. And these same machines run HIV viral load tests, HPV testing for cervical cancer, hepatitis B and STI tests for sexually transmitted diseases. They've been decentralized as far as district and even lower levels in multiple countries. What is missing to take these to scale would be further expansion of those test menus, as our earlier colleagues said and others have said, around integrating further testing on those platforms and other platforms. We have to diversify the platforms available, but also the service contracts as well as the sample transport networks. So let's not reinvent the wheel. Countries have gone a long way in scaling multi-testing platforms, and we need to build on those even further. Happy to say that UNITAID is supporting multiple countries in Africa on market assessments on how to do this, and further introducing additional near point of care technologies that then, with support from the Global Fund, the US government, and other partners, we can take to scale. The second example I'll give is on long-acting technologies. We know that we still have at least 10 million people that still have to be put on HIV treatment, but we're at an inflection point now with long-acting technologies, and with the advent of lenacapavir, and we hope next year positive readouts of the one-monthly PrEP oral pill from MSD, we will be in a position where we can build on existing scale that has happened to date to put 75% of the people that need treatment on treatment, but use prevention as something that will prevent additional people acquiring HIV. And here the critical aspect will be introducing technologies that reduce the burden on health systems, which are already burdened and have been constrained by funding reductions across the board, but also provide the opportunity when those who seek that care to integrate care that's provided to them. So I'll leave it at those two examples in terms of examples of where we can leverage potential to scale for multi-disease approaches that will benefit countries, not just in this continent, but beyond. Thank you, Mr. Chair.
Thank you very much. And that brings us to the end of hearing from our partners. We've heard from member states. Excellencies, you heard we talked about commitments. We've put some commitments on paper, and I will invite my colleague, Dr. Elizabeth Juma, to read out commitments, and if you agree, the ayes will have it. Dr. Juma, could you read out the commitments to the Excellencies, the ministers of health from our member states.
Thank you, moderator. This is the Addis Ababa call to action, protecting and accelerating multi-disease elimination in Africa, made today in Addis Ababa, Ethiopia, on the 26th of August, 2026. Adopted at this high-level ministerial side event during the 76th session of the WHO Regional Committee for Africa. We, the ministers of health of the member states of the WHO African region, meeting in Addis Ababa, recognizing the remarkable progress achieved by African countries in controlling and eliminating multiple diseases that have burdened our populations for generations, acknowledging that conflict, climate change, population movements, emerging health threats, and constrained financing risk reversing these hard-won gains, recalling the existing global, continental, and regional frameworks, declarations, initiatives, and commitments that advance integrated disease elimination, health security, health sovereignty, resilient health systems, and sustainable financing, reaffirming that every African has the right to live free from preventable diseases and that disease control and elimination is fundamental to health, development, prosperity, and resilience. We commit to 1. Sustain political leadership by placing disease elimination among our national development priorities and strengthening country ownership, accountability, and sustainable domestic investment. 2. Protect and build on the gains already achieved by investing in resilient health systems and public health institutions, quality surveillance, laboratories, integrated service delivery, community health services, and uninterrupted access to affordable and quality assured essential health commodities. 3, commit to work together across sectors and with our partners to address the social, environmental, and economic factors that influence health while promoting innovation, evidence, and shared learning to accelerate progress. And 4, commit to strengthen regional solidarity by sharing knowledge, expertise, and experience, supporting one another in overcoming common challenges and speaking with one African voice in advancing disease elimination. We call upon our development partners to align their support with country priorities, strengthen national systems, and co-invest in sustainable cross-sectoral solutions that protect the health gains achieved across the region. We request the WHO Regional Office for Africa, working closely with member states, the Africa Centers for Disease Control, and other partners to support implementation of this call to action by facilitating technical cooperation, fostering regional collaboration, mobilizing partnerships, and reporting on progress to the regional committee. Thank you.
Thank you very much. Do I take that clap to mean acceptance of the call to action? Maybe I will ask His Excellency, the Minister of Health from Niger, to tell us if we are accepting this call to action on behalf of the Ministers of Health who are here. Your Excellency, you want to just say a sentence?
Merci, Monsieur le Modérateur.
Thank you very much, moderator. The relevance of such an intervention is unquestionable. Hence, we are fully committed. We are ready to abide by this call for action. Thank you.
Thank you very much. Before I call on the Director for Program Management in WHO Regional Office for Africa, Dr. Diallo, I would like to acknowledge all my colleagues who made this possible. There is Dr. Dorothy Achu is here, Dr. Elizabeth Juma, Alden is here, Marian, who am I missing? Our director, Dr. Mpuma. Who else? Dr. Kofi, Dr. Christine. These are members for our team that work behind the scenes and just let some of us sit in front. Your Excellency, the DPM, Dr. Diallo, you want to have a few words of reflections and close the meeting. Thank you, Dr. Diallo.
Thank you very much, Dr. Kalu. So on behalf of the regional director, I actually have written remarks from him, but I'll try to spare you reading the remarks as written. Just summarize and then get on the part where we would like to call for a commitment, and please accept my apologies for reading that part. But over the last 90 minutes, we heard perspectives from leaders. We heard perspectives from member states that have made significant progress towards disease elimination. We heard from our strategic and technical partners that have been instrumental in supporting those progress that we heard from different member states. I think it is pretty clear that what comes from that, not to repeat everything that has been said, that political leadership is absolutely key in this process, community engagement, strong national institutions, and sustainable commitment. And I also heard from some of our partners here that progress must never be taken for granted. And today, more than ever, we need to align investment with country priorities. We also heard some challenges that lie ahead, the work that still needs to be done for all of us collectively. Excellencies, heads of delegations, partners, this event was never only about celebrating what has already been achieved. It was intended to identify the commitments that will sustain momentum and guide the next phase of disease elimination in our region. That is the purpose of the Addis Ababa call to action for disease elimination. The call reflects the priorities that have emerged from our deliberations and our shared commitment to the next phase of this work. It commits us to sustain political leadership and strong domestic ownership. It also calls for continued investment in surveillance, laboratories, integrated service delivery, community health services, and the resilient systems that support those. Beyond the health sector, it encourages stronger collaboration across government and with development partners, while reinforcing the importance of regional solidarity, sharing knowledge, supporting one another, and advancing this agenda with one African voice. As WHO, we are fully committed to working with member states and partners to translate these commitments into practical action. Within 72 hours, we will circulate a concise ministerial partner communique summarizing the key messages and commitments from this event. We will finalize the priority action matrix on cross-cutting investments so that the alignment discussed this evening becomes a shared and financeable plan. We will identify a small group of pathfinder countries to demonstrate integrated multi-disease elimination approaches, document lessons learned from their experience, and share those lessons across the region. Within 90 days, we will present a follow-up roadmap, including partner mapping, financing opportunities, and results framework for 2027-2030. We will report regularly to this regional committee on progress against these commitments. Excellencies, partners, colleagues, friends, the achievements we have recognized this evening demonstrate what African leadership can accomplish. The conversations we have had demonstrate a shared determination to work differently, strengthen national leadership, and accelerate disease elimination through closer collaboration. Before we close, I would like to thank our member states for leadership, our technical teams for their dedication, and our partners for their continued commitment to this agenda. Progress of this kind depends on sustained collaboration, and I thank all of you for the role you have played in making it possible. I invite ministers and heads of delegations to join me in adopting the Addis Ababa call to action for disease elimination as our shared commitment to the next phase of this work. Africa has already shown that disease elimination is possible. The challenge before us now is how quickly we can make it the experience of every country in our region. I thank you, and I wish you a productive final day of this regional committee tomorrow. Good evening.
Thank you very much. And this concludes our side event. Thank you and have a very wonderful evening. There is cocktail available as you go out there. The receptionist will show you where it is right outside there. But before we leave the high table, we'll take some pictures. Yes. Let's just stand up and excellencies and heads of delegations that left earlier from countries, if you are still here, we would like you to join us in taking the pictures. Dr. Mese Hailu, please come right up. Professor Julio, come right up here. Dr. Benido, please come up here. Let's have the picture so that it's complete. Yes, Marianne, let's do it quickly.
Je pense que, voilà, it's for you. Okay, thank you.
No, you hold that one. There's still more, yeah. There's still more. Okay. It's not English. It's okay. Are they taking the picture? Okay. In dollars or in euro? Well, thank you.
Thank you, bro, for coming.